Yes, and thank you, Professor. I'm looking forward to have chance to participate your workshop. Hope to see you soon. And for
Thank you
those
very much.
audience, I will share the evaluation link for the certificate, and so by filling up the certificate, you may get a certificate of completion of this session. So Sachin, do you have anything to add?
So we've got another 2 minutes before we start our next session. So we'll take a break for 2 minutes and then we'll start the next session. When you share the screen, I'll share the advertisement promotional videos. You share the screen as soon as the next session starts, okay?
Okay, sure.
Thank you. Bye-bye.
Bye.
Thank you so much.
Thank you very much, Prof.
先生、ありがとうございました。
どうもありがとうございました。
先生先生も、皆さんありがとうございます。大島先生も。
ありがとうございました。ありがとうございます。
Good afternoon. First of all, I would like to thank the organizing committee. Tractography. Intentionally, I prepared this lecture on laboratory anatomy. So before interpreting imaging and trusting images, we must have our own mental image of the anatomical reality. So intentionally, I prepared this lecture on laboratory anatomy. So before interpreting imaging and trusting images, we must have our own mental image of the anatomical reality. So we'll show you the result of some fiber dissection specimens with some examples and how this knowledge can change the way we behave in the operating room and how we plan parenchymal approaches. Of course, I cannot discuss the whole connectoma in one single lecture, so I've chosen one specific region which I think is very illustrative of these principles, which is the left dominant temporal parietal junction, the inferior parietal lobe. The announcing of this meeting it was mentioned the importance of anatomical knowledge for neurosurgical intervention. So in this short lecture, I will illustrate this powerful association. Why to study the inferior parietal lobule? The inferior parietal lobule is a unique location in the brain. It's a carrefour between the parietal and temporal lobes. It's close to numerous eloquent areas in the brain, in both the cortex and deep parenchyma. It comprises supramarginal and angular gyrus. Is limited superiorly by the intraparietal sulcus that's separated from the superior parietal lobule. So classically, the inferior parietal lobule is associated with visual spatial integration, body image, language. The lesion is usually associated with M neglect, especially in the right hemisphere, and Gerstmann syndrome, which may happen with the lesion of the left hemisphere, which is a combination of dysgraphia, calculation difficulties, finger adenosia, and left-to-right confusion. So being surrounded by highly functional areas, this region is for excellence an associative region. It means that it integrates information from other centers, even distant ones, which makes the study of this region even more important. And imaging, the location of the inferior parietal lobule starts with the identification of basic landmarks, such as central lateral sulcus. If I see with the central, where the central and lateral sulcus are, I can start navigating in the anatomy more easily and know where everything was. So the peculiarities of the central sulcus will help us to identify it. I will only cite the main ones. First of all, of course, is the location and the orientation. In those axial slices, it will have a slight posterior location. It will be oriented obliquely, anteriorly, lateral, and inferiorly. And I can start looking for the central region, which is a combination of parallel structures, such as parallel structures, which are the precentral sulcus, postcentral sulcus, precentral sulcus, central sulcus, and postcentral sulcus, and two gyra, the precentral and postcentral sulcus. So there are 5 parallel structures. The precentral gyrus is often thicker than the postcentral gyrus, so I know where a motor strip is, where sensory strip is, and I have already the anterior limit of the supramarginal gyrus, the anterior limit of the inferior parietal lobule. Other tricks or the presence of those links with the frontal gyri, which is always present with the superior frontal gyrus and often present with the middle frontal gyrus also called the pli de passage, and the omega shape area of the hand, better saying here, which marks for us the somatotopical regions of the hand. And I would acknowledge that it's easier to find for all those characteristics and localize the superior and anterior limits of the inferior parietal lobule. Coming from up to down would be much more easier than starting from the bottom, from the lateral fissure. And then we can follow those limits, identify the intraparietal sulcus, and then you have delimited your region. You see again the intraparietal sulcus here, the inferior parietal lobule, nicely in this parasagittal slice, the supramarginal gyrus, and part of the angular. So here an example, it was a small ganglioma in a 41-year-old man. We presented the seizures. He didn't have access to functional and MRI, but we see this is a relatively high slice. We see we're above the ventricles, the semoval center is there. First thing we notice is the location of the central sulcus. Same thing we saw. So we apprehend immediately the location of the eloquent area, sensory, motor, and language would be below, and what matter structures would be in the depth. So in this specific case, the lesion is the anterolateral portion of this left dominant inferior parietal lobule. So we are in the supramarginal gyrus. This patient was operated awake. We see immediately the trolar vein just anterior to the tumor, and just behind the sensory strip, so the postcentral gyrus, exactly where it was expected to be when you look at this superficial venous anatomy, which is also very important for navigation. So this is kind of the exercise we should always do, not only for diagnostic purposes, but this is for the roadmap. This is part of individual anatomy, which is really important. This is another example, left side. So this is anterior, this is posterior. You have a richer sensory map and evident superficial sylvian vein. So I know this is superior temporal gyrus, and the lower vein is the frontal lobe in this case, but we have a smaller one, which also can be used for navigation as well. So this area is subjected to very frequent anatomical variations. The general scheme we see in the books is this two horse-shaped gyri. The anterior one is supramarginal around the posterior end of the lateral sulcus, and the posterior one, and also more inferior, is the angular gyrus around the posterior end of the supratemporal sulcus. So they are separated by the sulcus intermedius primus, or sulcus of Jensen, which separates supramarginal and angular. These sulcus may be absent. It's not uncommon for the supramarginal gyrus to be fused, merged with the angular gyrus, or to find a small, narrow, squeezed gyrus between supramarginal and postcentral gyrus, or between supramarginal and the angular gyrus, what's called the pre-SM and the pre-AG variant. I took a look at the literature for that, and roughly 40% only of this typical configuration has been found in real-world MRIs. Just a small anecdote to illustrate the power for functional anatomy. And this last year, 2021, a century passed since this young enthusiast, Wider Penfield, refused a lucrative position because it did not offer him the possibility of doing some brain research. He then accepted his position somewhere else in the US, and then you know the story, Canada and Montreal, etc. This is registered in some biographic documents and letters, and we know how this was just the beginning of a very beautiful story that definitively changed how we surgeons see the functional anatomy of the brain. So many concepts of Penfield are still relevant today, and that's why we decided to revisit this anatomy in a paper we did some years ago, using those anatomical landmarks to put together the findings in a small series of 14 patients that were very similar to each other, operated from the IPR. And that's what we got. And this is upside down to simulate surgical position, of course. So when operating the inferior parietal lobe, so the area of infiltration will be there. And then we can use this anatomy to mentally anticipate what the boundaries of the resection may be. If you were, of course, decided to respect functional boundaries to achieve minimal permanent neurological deficit, and functional boundaries that will not obligatorily respect sulcogyral anatomy. So the superior limit will be often morphological. This map is not very rich in this region in our experience. So these limits can be determined by the limit of tumor itself, an oncological security margin, or be purely anatomical, such as the intraparietal sulcus. The inferior limit will be notably recurrence of language disturbances and not anomia in most cases, or semantic disturbances, say during a naming task and in awake surgery. And this, of course, to the presence of Levernicka's area. The anterior limit is sensory, depending on how anterior the tumor extends. And the posterior limit, we can see very variable language disturbances, and sometimes, but most of them, the map is negative here. It was negative in that series. That's for the cortex. But if you go back to the MRI and you look at what what we will be dealing with during the deep stage of the section, we will ask ourselves what the deep limits could be. And of course, if you have DTI tractography, those techniques can show you that. There is a lot of green stuff there, so it means that there are a lot of anteroposterior fibers. But the objective here is to know the anatomy and to be able to anticipate it, which is fundamental in surgery. even more if you think about brain shift issues, and that these imaging techniques and neural navigation are not available everywhere in the world. So this is a post-operative MRI from that same tumor I showed you. I like this one very much because it shows very well the contour of the arcuate fasciculus around the insula. So we see the superior limited sulcus of the insula and part of the posterior inferior one. So you see how close, even a little bit inside our arcuate fasciculus we were, and we stopped it because we had phonological disturbances. So these are classical dissections we do in the lab with a Klinger technique or any variant of it, showing how after some work in the lab, the pieces that you prepare are almost a photography that you see of what you see in your real cases and vice versa. So it relates to the deep limits of resection. We did, as we did for the cortex, we put similar cases together, and you see how those disturbances were distributed. The phonological paraphasias were present in the depth. So the medial deep aspect of the cavity, when you see more superficial white matter, we did have some speech disturbances, but they were of articulatory type, like dysarthria, I'm sorry. And they were concentrated in this anterior-inferior region of the resection, and we didn't observe any semantic disorders. So let's then again use anatomy to interpret what is happening. The white matter structures are in the depth of the resection areas, and main the portion of the same oval center, as everything is hidden there, is interposed between the cortex, the approach, and the ventricle. And when the very superficial white matter is removed, then the white matter that approaches, it belongs to this associative system, which is the one of the superior longitudinal fasciculus and arcuate fasciculus. There are multiple subcomponents with different nomenclatures, classifications that are still evolving. But two elements of particular interest here. One is the arcuate fasciculus I showed you, and the other was this horizontal opercular portion, which is also called the SLF3. So those are structures associated with language networks, because they were providing connections between frontal and temporal language areas, so Broca and Wernicke. Connections that can be direct or indirect, but they always pass in the depth of the inferior parietal lobe. Another case, and the corresponding anatomy, so the specimens are always in the operative position, and we stimulate in contact with the arcuate fasciculus, temporary phonological disturbance. Here we have a residue that was intentionally left, and no DTI, but we see lab dissection, anatomy, arcuate fasciculus. Then, if you are more superficial, we're not in contact with the arcuate fasciculus, we are there, but we are really in the lateral most superficial portion of the semoval center, in which horizontal fibers are found, and some lab work will demonstrate this for you very promptly. So we can discuss this inferior parietal lobe anatomy in the context of the debate of location cerebral functions. As you know, in the 19th, 20th century, we developed a lot this locality system model. We all learned the anatomy like this, talking about somatotopy, retinotopy, tonotopy. There is, however, a growing second debate reinforced in this century. Is the fact that if you understand the existence of those specialized organs in the cortex, in order to function, they must be interconnected. So regardless the importance of one area, it will always be useless if it's not connected to the other. So this principle is very simple, but it changes a lot the way we look to anatomy. So this is an aspect that some of you know, it hasn't attracted me for some years now. Language is among the findings in mapping and awake disorders that shows this evolution of functional anatomy very well. So today is not surprising, but this topic was used to be treated in a very simplistic way in the past. We all learned in medical school, for example, that Broca's and Wernicke areas were connected by arc-rate fascicles. But as you saw in this series, there was no semantic disturbance, so how is possible? So it means that the network actually is more complex than that, and there is still a lot to be done, and a lot that we don't understand. This is an example of this. These are dysgraphias. They were noticed in one patient. These graphias were surprising in the beginning because it's not writing is not really part of the testings we do. So that's what I wanted to show. Here's some take-home message. So go beyond classical anatomy, think individual anatomy. Go beyond topography, think functional. Go beyond the cortex, think about the connection. This is the history of anatomy is very beautiful. We're living this. Explore all limits of the cavity. Mapping can increase our volume resection, and keep in mind, of course, the technical limits and our limits of exploring this. So thank you very much.
Good afternoon, everyone. Thank you, Professor Yokorkato, for the invitation. I'm very glad to be here. It's an honor for me to participate for its important congress. I will speak about surgery of AVM in eloquent areas, anatomical point of view. So these are the hospital where I perform most of my surgeries, Beneficência Portuguesa and São Paulo Hospital. This is my team. This is my book. Dr. Cato wrote the foreword of my book. It was very honor for me. This is my lab of microneural anatomy at Unifesp. Their medical students, residents, and fellows are able to practice their anatomy and microsurgical skills on placenta and cadavers. I want to urge you to practice. I have fellowship program in vascular neurosurgery. I have fellows from a lot of parts of the world. You are all welcome to visit whenever you have the chance of traveling to Brazil. The definition of the AVM. The AVM is a tangle of abnormal vessels between arteries and veins without capillaries. This picture shows the difference between the arterialized vein and the normal vein. In this picture, we can see the frontal horn and anterior view. In this anatomical specimen, we can also appreciate that all the suicide point to the lateral ventricles, which is very important to take into account in the study of the AVMs, that also tend to point towards to the lateral ventricles. There are a lot of shapes of AVMs. The shapes depends on where it's located in the brain. The AVMs can be seen as circular, squares, or cone-shaped. The conic is the most common because most AVMs originate from the sulcus and the gyrus of the lateral surface. What do I need to plan and operate on the AVMs? A neurosurgical needs ability, dedication, art, technique, training, anatomical knowledge. We should study the MRI and the angiogram to localize the AVM and understand the relationship between supplying arteries, draining veins, and the nidus. I consider the T2 to be the most important sequence as it allows you to visualize the location of the AVM in the parenchyma when studying the preoperative digital subtraction angiography. Remember, an AVM is defined by the filling of the draining vein in the arterial phase. The early arterial phase of the angiogram is key to identifying the number and the position of the fillers. The intermediate arterial phase defines the draining veins in this case. The first step to operate AVMs is go to the lab. Why lab is important? So it's possible to learn anatomy and the development of the neurosurgery technique. We can divide the brain into 3 different surfaces, the lateral, basal, and medial surface. Precentral sulcus is always discontinued. But why? Because the precentral gyrus is continued in this surface to the middle frontal gyrus. So when we have this gyrus, that it's a continuation of the precentral gyrus, we say that it's the middle frontal gyrus. Well, when we see the lateral surface, I look for the connection between the vertical sulcus and the horizontal sulcus. I find the connection, the vertical sulcus and the horizontal sulcus. The vertical sulcus is the precentral sulcus or the procentral sulcus, never the central sulcus. So if we can see the precentral sulcus here, the precentral sulcus here is the precentral gyrus, the central sulcus, the postcentral gyrus, the postcentral sulcus. Here, sulcus is the Sylvian fissure. The first horizontal sulcus above the Sylvian fissure is the inferior frontal sulcus. And the first horizontal sulcus below interhemispherical fissure is the superior frontal sulcus. We can see, if we can see the 2 horizontal sulcus, we have 3 horizontal gyrus, the superior horizontal frontal gyrus, the middle frontal gyrus, and the inferior frontal gyrus. Here we can see the postcentral gyrus, the vertical sulcus, when we can see the connection between the vertical sulcus and the horizontal sulcus. The vertical sulcus is the precentral sulcus or the postcentral sulcus. Here we can see the postcentral sulcus, the intraparietal sulcus. The horizontal sulcus is the intraparietal sulcus. The intraparietal sulcus divides the parietal lobe in 2 lobules, the superior parietal lobes and the inferior parietal lobes. And the inferior parietal lobule is formed by the supramarginal gyrus and the angular gyrus. In the MRI, it's the same. We can look for the connection between the vertical sulcus and the horizontal sulcus. The vertical sulcus here is the precentral sulcus or the postcentral sulcus, never the central sulcus. Here is the precentral sulcus, the precentral gyrus, the central sulcus, the postcentral gyrus, the intraparietal sulcus. Here is the superior parietal lobule. Where is this AVM? This AVM is located here. I'm looking for the connection between the vertical sulcus and the horizontal sulcus. Here is the precentral sulcus, precentral gyrus, central sulcus, postcentral gyrus, postcentral sulcus, intraparietal gyrus, interparietal sulcus. We can compare both sides. Here is the central sulcus, the precentral sulcus, the superior frontal sulcus, the precentral gyrus, the central sulcus, the postcentral gyrus, the postcentral sulcus. Where is this AVM? This AVM is located in the central sulcus and the posterior part of the precentral gyrus. In this MRI is the same. Where is this AVM? It's located in the central sulcus and the precentral gyrus. In the left, we can see that AVM of the central sulcus and the precentral gyrus. And in the right, we can see the complete resection of the AVM. We can see the precentral gyrus, central sulcus, and the postcentral gyrus. When we open the Sylvian fissure, we can see the insular lobe. The insular lobe is located in the deepest part, in the deep part of the Sylvian fissure. It's the floor of the Sylvian fissure. The limb insula. The limb insula is a very important point for us. Why is it very important for us? Because in this point, the M1 curve through M2. The limb insula is the lateral limit of the anterior perforate substance. is the limit of the lateral lenticular arteries. It's the point of the anterior part of the insula. We have the two important points in the sylvian fissure. The anterior sylvian point is the limen insula, and the posterior sylvian point. The posterior sylvian point is the Heschel gyrus. The second running point is the posterior sylvian point over the Heschel gyrus. These 2 points determine the beginning and the end of the insular loop. Here we can see the limen insula in the brain. Here we can see the sylvian fissure. At the anterior sylvian point, the sylvian fissure divided into portions: anterior, ascending, and the posterior rami of the sylvian fissure, and divide the inferior frontal gyrus in 3 parts: orbital, pars orbitalis, pars triangularis, and pars opercularis. Yet the apex of the pars triangularis point to the limen insula. The limen insula, what's the importance for the limen insula for us? In the limen insula, the middle cerebral artery cover the M1, cover to M2. Here we can see the Heschel gyrus. Here in this picture, show the Heschel gyrus point to the atrium. It's a very important point for us. Here we can see the M1. The M1 goes from the bifurcation of the internal choroidal artery to the limen insula, because the limen insula is the point where the M1 cover to M2. Here we can see again. Here. The M1 goes from medial to lateral. The M2 goes from anterior to posterior. The M1 is anterior to anterior face of the insula. The M2 is lateral to the lateral face of the insula. Is this anatomy? We can see the M1, the most of the bifurcation of the middle cerebral artery occurs in the M1. The most of the aneurysm of the middle cerebral occurs in the M1. Here we can see the M2. M2 goes from the limen insula to the anterior, superior, and inferior limitant sulcus of the insula. And M3 goes from the limitant sulcus of the insula to the limit of the sylvian fissure, lateral limit of the sylvian fissure. And the M4 goes from the sylvian fissure goes from spread on the lateral surface of the frontal parietal. In this lateral view, you can see that the level of the anterior sylvian point, the main trunk of the sylvian fissure divided into the anterior ascending and posterior horizontal rami. At this point, if you retract the cortex, we can see the pars triangularis is point to the limen insula. On the lateral surface of the brain, the lateral ventricles are distributed around the sylvian fissure. If we image a line through the upper limit of the lateral ventricles, the line would be at the level of the inferior frontal sulcus and also at the level of the interparietal sulcus. And we can see in this picture the pars triangularis and the opercularis correspond to the frontal horn. The precentral and postcentral gyra correspond to the body of the lateral ventricle. The supramarginal gyrus correspond to the atrium of the lateral ventricle, and the middle temporal gyrus correspond to the temporal horn of the lateral ventricle. The space is the natural corridors of the brain. Where is the natural? We can see the suprachiasmic space, the optic carotid space, carotid oculomotor, oculomotor freeborder of tentorial space. These are natural corridors of the brain. We can see the internal carotid, the optic nerve chiasm, the internal carotid artery. The internal carotid artery is inferolateral to the optic nerve. The third nerve is inferolateral to the internal carotid artery, and the freeborder of tentor is inferolateral to the third nerve. We can see the posterior cerebral artery superior to the third nerve and superior cerebral artery inferior to the third nerve. Finally, this picture shows the linear membrane that rests over both third cranial nerves. From the lab to the OR, with training. Lab training is important to acquire manual skills and dexterity before operate complex devices like AVM. The head position allows increase the venous outflow and reduce cerebral edema. The cranium needs to be sufficiently wide. We need to expose the AVM and the normal brain with the landmarks. I have published articles about terional, pretemporal, and OZ craniotomies. Let's go to the terional craniotomy step by step. I cut the skin from the superior border of the zygomatic arc until the midline of the head. We can see here, we can see the Sylvian fissure is the center of the craniotomy. The medial cerebral artery, the internal corridor, is the center of the craniotomy. Here I cut the bone. I do the borehole will be necessary, okay? And I cut the lateral part of the borehole. Here you can see the dura mater. And in the lab, we can simulate a surgical table with the instruments. The instruments adapt to my hands and not the hand to the instruments. Our instruments can be our ally or our enemy in the battle against the AVM. I recommended having more than one bipolar forceps and different sizes. I use the shorter ones for the superficial parts and the longer ones for the deep parts. Remember, the instruments adapt to your hand position, not other way. The craniotomy needs to be sufficiently wide. We need to expose the AVM and the normal brain with the landmarks. The placenta is the excellent training tool for vessels and their arachnoid dissection. Simulates very well the vessels and their arachnoids with their membranes. It's important to keep the dissection in the arachnoid plane. If you lose this plane, you might end in the nidus and provoke bleeding. This bleeding will occupy the subarachnoid and subipial space, and you will be unable to see anatomical landmarks if this happens. Here we can see the AVM completely demarcated after the initial arachnoid dissection. And then we can go forward to the skeletonization of vessels and coagulation. You can see the arterial vessels completely skeletonized, facilitating the identification of the branches, going to the AVM, to the safely coagulation and cut it. We repeat the same procedure surrounding the nidus until all the feeders are coagulated. We can coagulate the early drainage vein, and I remove this AVM. So, repeating, the most important thing is maintain the arachnoid planning. I use always a blade and micro scissors. Using one blade of the scissors to elevate the arachnoids. Here I am cutting the arachnoids. I elevate the arachnoid. I use the blade of the scissor to elevate the arachnoid to then safely cut. I continue dissecting the AVM. I am opening the arachnoid. I am separating the AVM of the normal brain. I need to stay in the arachnoid plane. If I lose this plane, I enter in the nidus and I provoke the bleeding. The bleeding occupy the subarachnoid and superior space, and I can provoke the injury of the normal tissue. Here I am in the deepest part of the nidus. I identify the main feeder at the bottom. In this case, I find it useful to put a temporary clip to reduce the flow to then coagulate and cut. Now I am coagulate and cut. Look, the surgical bed is clean. Here I am removing, I am coagulate the early drainage vein. I am removing the AVN. Look, the surgical bed is clean. The principles of AVM surgery. Study MRI is very important for the plan. And the end of the procedure, the difference of color between arteries and vein is clear. Surgical case. In this case, we can see the AVM in the insula lobe. The insula lobe is located in the middle of the M2. The AVM is located in the middle to the M2. We can see the AVM in the lateral surface of the brain. Identify the limit insula. The limit insula is the anterior sylvian point. In the the anterior sylvian point is the very important point. Where is the middle cerebral? The M1 turns to M2. You can see here. In this first case, I operate in this the interesting insula AVM. As you see in the MRI, the patient had a previous hemorrhage leaving a hematoma cavity. This is an insula AVM. On the angiogram, the AVM is located between the superior and inferior trunks of the MCA. We can see the anterior cerebral artery, internal carotid artery, the middle cerebral artery. We can see the bridging veins cross the sylvian fissure. Here we can see the early drainage vein and the normal drainage vein. Both is the superficial middle cerebral vein. Now I am opening the sylvian fissure. We can see the M2 and the superior and inferior trunk of the M2. We can see aneurysm. This aneurysm provoke the bleeding. Now I start the skeletonization of the AVM. I am coagulate and cut. The same step. I dissect, I coagulate and cut the AVM. We can see the color in the drainage vein change as I disconnect the shunts. I am removing the AVM. I am removing. And the AVM is removed as one piece. And the final, the ICG shows no early drainage of the vein. And the post-operative MRI and the angiogram confirms disconnection of the AVM shunts, the AV shunts. The other case, The angiogram shows the feeders from the lateral part of the P2P. The P2P is located on the hippocampus sulcus. The hippocampus gyrus is located lateral of the PCA, and the midbrain is located medially from PCA. The lateral view shows the AVMs in the parahippocampus sulcus. Here we see the terminal branch of the PCA and the early drainage vein from the nidus to Galen vein. The angiogram shows that the carogal artery doesn't supply the AVM. The nidus can be seen in the posterior part of the parahippocampus gyrus. This lesion is located in a place with difficult access because of the tentorial shape. The coronal T1 shows that it's impossible to reach this lesion by the subtemporal approach because a great retraction of the temporal lobe would be needed. We have to remember that the vein of Labe is in the area of the lateral surface. The sagittal T1 shows the nidus under the pulvinar of thalamus. The thalamus, the roof of this lesion. We can see the parahippocampus gyrus and the uncus. The uncus is the anterior part of the parahippocampus gyrus. We can see the P1, P2A, P2P, P3, P4. We are seeing the P2P related with the pulvinar of the thalamus. It's seen of PCON. We can see the P2A, P2P, the collicular point. Where is the collicular point? The collicular point is represented the isthmus of the cingulate gyrus. Here we can see the fourth nerve. The fourth nerve is the landmark point of the posterior fossa for us. Upper to the fourth nerve, the quadrigeminal plates. Superior and inferior colliculus. The lateral mesencephalic sulcus, the lateral mesencephalic veins. Inferior to the fourth nerve, we can see the superior cerebellar peduncle, the superior medullary velum. It's an important landmark of the posterior fossa. Here we can see the supracerebellar transtentorial approach. We can see another video. In this case, the hippocampus sulcus AVM, which is recently published in operative neurosurgery. The initial CT showed an intraventricular hemorrhage. The MRI showed a posterior hippocampus sulcus AVM extend to the pulvinar and opening the quadrigeminal cistern. I am looking for the fourth nerve. I find the fourth nerve. The fourth nerve is the most important landmark of the posterior fossa for us. Superior for the fourth nerve, the quadrigeminal plate. The superior, the lateral mesencephalic sulcus. The lateral mesencephalic vein. Now I am opening the tentorium. Where I open the tentorium, I needed to see the point that the fourth nerve touch the free border of tentorium. In this part, behind this part, I can remove all the tentorium. Anterior this part, I can't remove all the tentorium. I needed to preserve the free border of tentorium, but it's an important landmark. Why is the important landmark? Because the superior this point, lateral geniculate body, anterior this part, uncus, posterior this part, parahippocampus gyrus. Here, we can see when I needed to remove the parahippocampus gyrus. Why? Because the hippocampus sulcus is located between the dentate gyrus and the parahippocampus gyrus. When I remove the tentorium, I needed to remove the parahippocampus gyrus to see the parahippocampus sulcus. The hippocampus sulcus, where is located this AVM? Where is the superior limit of the AVMs? The pulvinar of thalamus. So I removed the where I see the pulvinar of thalamus. I removed all the AVM. See the MRI, the angiogram, that we remove completely the AVM. So we can see that another case, the AVM is the tonsil. The tonsil is located behind the medulla. We can see the both pica. The pica is the most important artery in this case. Here we can see the lateral. We can the tonsil, the middle surface of the tonsil. In this case, we can see AVM localized in the left cerebellar tonsil. The angiogram confirmed it was supplied by pica and ica arteries. After intraoperative embolization, she was planned for surgery. The patient was operative in semi-sitting position. A medial suboccipital approach was performed. We can see the superficial location of this AVM. And the ICG demonstrates the early drainage through the inferior vermen vein. Also, we can see the embolized part here. I started the surgery dissecting the AVM at the arachnoid plane. I'm coagulating, cut some small feeders while I advance in the circumferential dissection. In the deepest part of the medial side, I found some perforators, recruited vessels, and onyx material from the embolization. Now we remove the lateral part. It's important to stay as close as possible to the AVM plane in a circumferential fashion, taking care not to coagulate the main drainage vein until the finish, the disconnection of all the feeders. I am disconnecting the AVM. I am cutting the vessels. Now we can see the fourth ventricle. I'm removing the lateral part of the tonsil. I extend my resection plane until the lateral superior lateral resects. We can see the fourth ventricle, the lateral resects, the superlateral resects. We can see the fourth ventricle here. I am removing the inferior part of the roof of the fourth ventricle. I repeated the ICG, confirmed the AVM is no longer with flow. You can see the AVM, the postoperative MRI and angiography demonstrate no evidence of the AVM. Here is another case, the AVM of the pulvinar ophthalmos. This is a video of AVM, a thalamic AVM. A front parietal craniotomy was performed. The superior posterior sulcus splits into two rami, the angular ramus and the occipital ramus. I open the angular ramus, which is the posterior limit of the supramarginal gyrus. The sulci of the lateral and the inferior surface of the brain point to the ventricle. I use the neuronavigation to orientate myself to the atrium. I open the atrium and drain the CSF. I find the choroidal plexus, which is fixed at 2 points, the tinea fornis and tinea thalami. Remember, the thalamus is the head of the brainstem, and the lateral ventricle surrounds the thalamus. Anterior to the thalamus is the frontal horn. Superior is the body of the lateral ventricle. The posterior of the thalamus is the atrium and the posterior horn. And the inferior of the thalamus is the temporal horn. If you find the thalamus, you find the fornix. You find the fornix. If you find the thalamus and the fornix, you will find the choroidal fissure and the choroidal plexus between them. If you see the choroidal plexus above the thalamus, you are in the body of the lateral ventricle. It's posterior to the thalamus, you are in the atrium, and the inferior, you are in the temporal horn. I open the choroidal fissure by moving the choroidal plexus from the fornix. I remove the hematoma and create the space and remove the choroidal plexus. Why do I do this? Because I believe the anterior choroidal and the posterior lateral choroidal arteries supply the AVM. We can still see early filling of the draining vein on the ACG. I follow this vein to reach the AVM. I complete the circumference of the section and disconnect the vein. I removed the AVM in one piece. The final ICG confirmed the disconnection of the shunt. Here, the post-operative, the CT scan, the MRI, and the angiography show this. And the last case is in the neurosurgical focus, is the AVM located in the choroidal fissure and the body of the corpus callosum. Where is located is the choroidal fissure, is the choroidal fissure in the body of the lateral ventricle, the atrium of the lateral ventricle. Is the craniorum, the patient is the prone position. I'm opening the callosal cistern, I am opening the corpus callosum, and I find the AVM located in the body of the choroidal fissure. This patient was embolized previously in the atrium. The part of the AVM located in the atrium was embolized previously. I am opening the tinea fornix, and I am removing the part of the AVM located in the choroidal fissure. I am removing the AVM located in the choroidal fissure. The post-operative angiogram demonstrates the complete resection of the AVM. Located in the brainstem, in the midbrain, located in the midbrain, supplied by posterior thalamus perforating arteries. I use the supracerebellar infratentorial approach. I am identified the best landmark of the posterior fossa is the fourth nerve. The fourth nerve. Identify the fourth nerve superior. Above the fourth nerve, we can see the quadrigeminal colliculus. Quadrigeminal plates, the superior, lateral mesencephalic sulcus, lateral mesencephalic veins. Inferior to the fourth nerve, we can see the superior cerebellar peduncles, the superior medullary velum. We separate the isthmus of the parahippocampus gyrus. I'm opening the quadrigeminal cistern. We can see the pericentral cerebellum, the vein of the cerebellum mesencephalic fissure. Here we can see the embolized vessels, and I am moving the parahippocampus gyrus to wide expose of the lateral part of the midbrain. So we can see, I am coagulating the vessels of the goes to the quadrigeminal plates. You can see the ICG, show the early drainage vein. And I am entering in the midbrain, inside the midbrain. I'm removing the AVM. I'm dissecting. And I reach the cerebral aqueduct. And I'm removing the AVM in one piece. The final aspect, the AVM, is a big AVM for the middle frame. The ACG, conservative ACG, no, the ACG showing the completely section of the AVM. You can see the angiogram and the MRI are showing the complete section of the AVM. Here are some papers I published in AVM, and this is my book again, Macroanatomy and Surgery. I teach how you use the anatomy in surgery. Thank you very much for your attention, and I am very grateful for the opportunity to participate in this event. Thank you so much. Thank you, Professor Cato, for the invitation. It's a very honor for me. It's in my hospital and my lab is open, are open for you and all people from Asia. Thank you so very much. I wait in Brazil. Hi, Sachin.
Thank you. Thank you very much, Dr. Perez Cheddard. Yet again, another
Hi.
wonderful session. The second time I'm listening to your session, but believe me, every time I see it, the approaches and choices you've taken to resect those AVM are fantastic. And slowly, I've started understanding your concept of anatomy.
Oh, thank you. My secretary taught me it will be tomorrow. I received your mail now. Yes, sorry. The people is entering now. Thank you so much. It's a pleasure to speak about AVM. Thank you, Dr. Cato, for the invitation. For me, it's a great pleasure to participate in this a great event. Thank you so much.
Thank you very much, Professor.
Paris, thank you very much.
Hi, Professor.
Hi, thank you. It was a great talk. Thank you so much. Just I have one question for you. So the deep-seated AVM, even small one, can you hear? So it's sometimes quite difficult for younger generation. I think. Do you believe the radio surgery? How do you think about the treatment of radio surgery?
Yeah, Professor. What's the deep AVM? Okay, the deep AVM is located in the central part of the thalamus, in the internal capsule, in the lentiform nucleus. When the deep AVM, for me, is the area that I can access for surgery. Okay, when I can't to remove the AVM with a surgery, a microsurgery, I indicate the radiosurgery. In this situation only. In this situation, small with the AVM degrade C, I indicate the radiosurgery. Where is the AVM degrade C? Location in the basal ganglia, in the center of the basal ganglia, step in the lateral surface of the thalamus, in the corpus callosum, in the insula lobe, in this area, in the quadrigeminal plate. The quadrigeminal plate, for me, it's not a deep AVM because I have a direct access for the AVM. For me, the deep AVM is the AVM that I can't to access. In this situation, I indicate the radiosurgery. The other situation for me is surgery or combining embolization or radiosurgery, but after that, the surgery. I finish the treatment with a microsurgery.
Thanks. Because sometimes the surgery, if we have such a confidence to remove the all nidus, but sometimes the latter half of the surgery, it's kind of the small vessel become very gorgeous because of the hyperemic. Sometimes in the eloquent lesion, sometimes we make an injury or make some complication. So sometimes we are very afraid of that. So of course, your hand is perfect, I think. But sometimes for some teaching of the younger generation, I think sometimes we should consider. Thank you so much for your nice talk. Thank you very much.
Thank you, Professor. For me, it's a great honor for you. Great honor for me. I will send my book for you. Thank you so much.
Thank you. Thank you very much. Thank you so much.
Thank you.
Thank you. Dr. Sachin? Sachin, unmute, please.
Okay, thank you very much, Professor Perez Cheddard. We'll have the discussion at the end. We still have 3 talks from this session of cadaveric and neuroanatomy workshop. Dr. Marcos Costa is there, I can see him. Professor Sveres, I'm still not able to contact Dr. Ricardo Silva Centeno
No.
and
Ricardo
Dr.
Silva
Sergio.
is entering now. He's entering now.
Okay, very good. And Dr. Sergio Cavallero. So if you could contact him to enter now, it will be great.
Yeah.
Yes.
No,
May
I contact him because most of
Sure.
I thought that my class will be tomorrow. My secretary notice tomorrow. No problem. Marcos, give me a class now. Okay?
Sure. So may I request Dr. Marcos
will be Ricardo, will be Cavallero after that. Okay?
Sure. Thank you, Prof. So, Dr. Marcos, can you please share your screen and start your talk, please?
Hello, everybody. It's a pleasure to me being here. I'm very glad with the invitation to participate in this event, and I'm showing my screen here. Let me see. Can you see my screen?
Yes, doctor, we can see it. That's your PowerPoint, Cerebellum.
Yeah, great.
Yes.
So,
yes, perfect.
For me, it's a great pleasure being here, and I'd like to talk about the microanatomy of cerebellum and fourth ventricle. Here at my university, we have the opportunity to be taught anatomy by Dr. Feres Haddad. So we all are passionated for anatomy, and there's no other way to see the neurosurgery for me without thinking in neuroanatomy. So I would like to give you a view of the cerebellum and fourth ventricle as you use it during the surgery, and I hope you enjoy the presentation. So and the main point of the cerebellum is that we need to understand the three surfaces that we have. Okay, and these surfaces can vary the way you approach the cerebellum also. So we have a tentorial surface, that is this one, that usually we can go by a median suboccipital craniotomy or even in an infratentorial approach. We have a petrosal surface, that is this face, this anterior face of the cerebellum, where we find the CPA mainly, and we have the anterior view from the cerebellar peduncles, and we have the suboccipital surface, that it's usually the most common surface that we see during surgeries in the posterior fossa tumors, when the tumors are inside the fourth ventricles, for example. So those are the three surfaces from the cerebellum that we need to understand, and this is the place where the cerebellum is seated, is the posterior fossa and cerebellum, fourth ventricle, and the brainstem are structures inside the posterior fossa, and the posterior fossa is limited superiorly by the tentorium, and this is one point very interesting. But when we look in the sagittal view, that the tentorial is not a rectified structure. It's like a oblique structure that goes from posterior to anterior and from inferior to superior, has this direction, and it plays an important role when we need to operate it on patients, for example, in the tentorial surface, because, for example, when we want to use the gravity in our favor, and you want to widening the corridor to this surface, you need to move the head in the position that, for example, we usually flex the head to put the tentorial parallel to the ground, and then the gravity pulls down the cerebellum, creating a very wide corridor to this portion of the tentorial surface, and also to other structures as the pineal gland or pineal region, for example. Okay, this sagittal view also, it's important for us to understand that going by a posterior approach, you can see the suboccipital surface, but the anterior surface is more anterior, and then we are going to need more lateral approaches to see from anterior to posterior, for example. The tentorial surface is the surface that we have the contact with the tentorium, sorry. And there is a very important feature here, is the cerebellum mesencephalic fissure. It's part of the pineal region and the anatomy of the pineal region, and also it is a place where we are going to find one of the most important peduncles of the cerebellum, the superior cerebellar peduncle. We are going to see in the next slides. It's a surface that it's oblique because it's parallel to the tentorium, so it goes from inferior to anterior and from inferior to superior and from posterior to anterior. So it's important to understand this direction of the superior, the tentorial surface when you manage the approaches to reach some lesions. As we said before, we were going to find the cerebellum mesencephalic fissure here, that it's a very important structure where we're going to find the superior cerebellar artery, and we are going to see also the precentral cerebellar veins. These are veins that comes from this fissure and went to the vein of Galen, but for when we need to approach the pineal region, is this type or this veins that we can cut. We can coagulate and cut those veins that goes to the cerebellum mesencephalic fissure. And it's important to note, recently we have also published a paper that studied the approaches that we need to use to reach the interpeduncular sulcus, and that position, the interpeduncular sulcus, is very important to understand the relation with the superior surface, the tentorial surface of the cerebellum, because many times we need to remove part of the quadrangular lobe here to approach the interpeduncular sulcus. The interpeduncular sulcus is a continuum with the lateral mesencephalic sulcus, but it's inferior to the fourth nerve. When you find the fourth nerve and we go below, we are going to see the interpeduncular sulcus. And the interpeduncular sulcus is inside this cerebellum mesencephalic fissure. So sometimes when you need to widen the exposure, we need also to remove part of the quadrangular lobe to expose this structure. The suboccipital is one of the biggest surface in the cerebellum. Is that surface that we usually see when you do a median suboccipital approach. And then it's the mainly access to hemispheric tumors or hemispheric lesions in the cerebellum. Here we can see this suboccipital surface giving a view for the fourth ventricle, and the petrosal surface. It's the most anterior surface of the cerebellum. It's related to the middle cerebellar peduncle, and here it's the surface that it's totally anterior, so it's called petrosal approach because the relation with the petrous bone, the petrous portion of the temporal bone. So this surface is seen by looking from anterior the peduncle, the cerebellar peduncle. So we need to understand that for exposing this petrosal portion of the cerebellar hemisphere here, you need to propose the approaches that are more lateral. We can't see the petrosal surface of the cerebellum by doing a suboccipital approach. So in this situation, we need to use or the heterosigmoid approach or the far lateral approach that we are going to see more, try to see from an anterior view. Okay, this is another view where the brainstem was removed, and we can see here the superior cerebellar peduncle in the middle cerebellar peduncle, giving a view for the fourth ventricle. Okay, and then here we can see the superior portion of the fourth ventricle and the inferior portion of the fourth ventricle in anterior view. Here is one of the most important anatomical relation that we need to understand in the petrosal surface of the cerebellum. This is the flocculum, and the flocculum here has a direct relation with the 9th and 10th. It has a direct relation with the 7th and 8th nerves. So when you see here in the petrosal surface, we expose the flocculum and the choroid plexus here in the exit of the fourth ventricle in the luxia foramen. When you see these nerves here related to the flocculus, it's a very important landmark to you to understand that those nerves are the complex 7th and 8th nerves. So this is a very important tip when you are operating on for example on a heterosigmoid approach, and most of the time we need to have landmarks for each portion that you are working on. So to many people, So many surgeons, it's so difficult to differentiate all the cranial nerves, but when you have specific landmarks to do that, it's very important. So here, always, when you see the flocculum, and we're going to be sure that those nerves directly related to flocculum are the 7th and 8th nerves. So, and then actually the flocculum, it's a very kind of easy structure to recognize in the cerebellar-peduncular angle, and also because it's directly related to the choroid plexus. That's a very different structure from the cerebellum actually, and you can't don't recognize this during the surgery. So when you see this relation here, it's very important. You are going to be sure that, okay, I'm seeing the choroid plexus, I'm seeing the flocculum, so these are 7th and 8th nerves, okay? Then we can understand and you can recognize all the other nerves, because you're going to remember that when we go more medially, you're going to find the 6th nerve, and when we go superiorly to the middle cerebellar peduncle here, we're going to find the 5th nerve. So this is a very important landmark. And then obviously when you go below more for the medulla oblonga, we're going to find the 9th, 10th, 11th, and the hypoglossal nerves. Another structure that is very important for cerebellar anatomy is the dentate nucleus. The dentate nucleus, it's a deep nucleus in the cerebellum, and in which we have a very specific outlet for the dentate nucleus, that is the superior cerebellar peduncle. The superior cerebellar peduncle, together with the medial cerebellar peduncle, the inferior cerebellar peduncle, they hold the cerebellum in the position. So it's important to the cerebellum, these peduncles, and the superior cerebellar peduncle is the main outlet from the dentate nucleus. That is the most important cerebellar nucleus. So here it's another section showing that the dentate nucleus they have their fibers exiting the cerebellum by the superior cerebellar peduncle that is in the roof of the superior portion of the fourth ventricle. Is the superior portion of the roof of the fourth ventricle. And we can find that by dissecting the petrosal surface of the cerebellum. We have also neurovascular structures related to the cerebellum and their peduncles. We have 3 main arteries that are related to these surfaces that we said before: the superior cerebellar artery, the ICA and PICA. Those arteries, each one has a specific relation with each one of the surfaces that we showed, and then come from the vertebral and basilar artery from anterior position. So all these arteries come from anterior to posterior, and here we see how these arteries irrigate the cerebellum. In the most superior portion, we are going to see the superior cerebellar artery. In the tentorial surface and in the petrosal surface, we're going to find the ICA. And in a suboccipital surface, we're going to find the PICA artery. So each one of the surface has a relation with one of these 3 arteries. So here we see the superior cerebellar artery here, going around the midbrain, and here the superior cerebellar artery goes posteriorly to the cerebellum mesencephalic fissure, and it gives branches to all the tentorial surface of the cerebellum. So it's important to understand that relation, because when you see when you are working on the tentorial surface, automatically you should remember that you are going to deal with branches from the superior cerebellar artery. In the same situation, when we go to the petrosal surface, we need to remember that we are going to deal with branches from anterior inferior cerebellar artery, the AICA artery. So here we can see in the tentorial surface branches from the superior cerebellar artery, but here you also see that the anterior inferior cerebellar artery will irrigate the petrosal surface. It's all important to remember, because the superior cerebellar artery will have more relation with nerves that are going to say related to the petrosal surface of the cerebellum. Always remember that when we think in the superior cerebellar artery, we need to think in the third, fourth, and fifth nerve. So, and when we are working with the anterior inferior artery, you are going to work with the sixth, seventh, and eighth nerves. And then pica will have a relation with the lower cranial nerves. So this is an anatomical division that help us to remember what type of artery we are going to find in the approaches that we are designing for our patients. So here's another view for the ICA, going to the petrosal surface and giving branches for all the petrosal surface of the cerebellum, and having a direct relation with the sixth, seventh, and eighth nerves here. And in the other side, the superior cerebellar artery have a direct relation with the fifth nerve, the fourth nerve, and the third nerve more superiorly. So this is another view. Here again, we are looking for the choroid plexus. So when we see the choroid plexus here and the flocculum here, it's another important landmark to remember that these are 7th and 8th nerves, and then down below we are going to find the 9th, 10th, and 11th accessory and the hypoglossal nerves. So this is what I talked about previously. When we find this relation, the flocculum and the choroid plexus, and then you are going to be sure that in a more medially position, you are going to find the 7th and 8th nerves. And also, when you see, for example, the lower cranial nerves, you need to remember that this it will be the pica artery, the posterior inferior cerebellar artery, that's related to the lower cranial nerves, and then to the suboccipital surface. Here, the section showing the ICA in the internal canal here. These are other sections, and here it's another view showing the posterior inferior cerebellar artery. it's go around the medulla oblonga, and then it goes posteriorly to give branches again to the suboccipital surface of the cerebellum. So all three arteries has a direct relation with one of each surface of the cerebellum. So the pica, the posterior inferior cerebellar artery, will be the main artery to irrigate the suboccipital surface of the cerebellum. So this is a very beautiful view of the posterior inferior cerebellar artery, showing all the cortical branches to the suboccipital surface of the cerebellum. It's another view showing here the posterior inferior cerebellar artery going around the brain stem here, going around the medulla oblonga, and then giving branches to the suboccipital surface. So when we remember this relation, we are going to when you remember this relation, and we are operating on a patient that, for example, it's a hemispheric lesion in the suboccipital surface, you automatically remember that we are going to deal with branches of the posterior inferior cerebellar artery. So it need to be automatically, I would say, thought when we think in these three surfaces. So the petrosal surface is the superior cerebellar artery, the tentorial surface is the superior cerebellar artery, the petrosal surface is the ICA, and in the suboccipital surface is the posterior inferior cerebellar artery. The fourth ventricle, it's a structure that it's present in the posterior fossa, is one of the most important ventricles in the brain, in the encephalon, and it's between the brainstem and cerebellum. It has a pyramidal shape like this, or a triangular shape. I'd like to say a pyramidal shape because it's a 3D structure. It's not a plane structure as a triangle. It's a pyramid. So it has a base, and then it has an apex here, and we have a superior portion and an inferior portion that has different structures that you need to understand. And the fourth ventricle has three main outlets. That is the Luschka foramen, when you are going to have the exit of the choroid plexus here, and here you're looking for the tonsil. It's a very interesting relation here because the superior pole from the tonsil has a direction, has a relation with this structure here that is going to be the dentate nucleus, that is also has his outlet here, the superior cerebellar peduncle. So it's very important to understand this anatomy because we are going to deal many times in the posterior fossa tumor with the tonsil and the fourth ventricle, and we need to always remember that this relation to avoid lesions or to avoid reaching the dentate nucleus because of the possibility to give mutism for patients. So this is another view from the outlet of the fourth ventricle. Is the tonsil was removed. You can see again the dentate nucleus giving his outlet fibers to the superior cerebellar peduncle. Here is in this side, and here you see the lateral recess, that is the Luschka foramen outlet from the lateral outlet of the fourth ventricle. Here is a superior view where we are looking for the fourth ventricle between the two superior cerebellar peduncles. Here is the cerebellar peduncle here and another cerebellar peduncle here, and we're looking to the superiorly to the fourth ventricle. Here is another view. It's a external view from the Luschka foramen, where we see the tila and the choroid plexus here, and the flocculum, and always remember the relation with the 7th and 8th nerves. And you see flocculum and choroid plexus here in the lateral outlet of the fourth ventricle. And down below, we are going to find the lower cranial nerves. So this is a view for the posterior portion of the roof of the fourth ventricle, where you see the tila, and this is the view when we go to the suboccipital craniotomy, medial suboccipital craniotomy. When you're going to enter the fourth ventricle, is one of the most common pathway to go to the fourth ventricle, actually. And then we need to dissect this tonsillar medullary fissure and to open the tila to give an access to the fourth ventricle. Is another view where the tonsil was removed, and then we can see from the imagine di foramen to the Luschka the relation from the tila here, that we can widen open to have access to the fourth ventricle. And like here, when you go in, we need to expose the fourth ventricle to remove, for example, tumors inside the fourth ventricle. Here is another view. When you remove the tonsil, we see the tila, the relation of the tila in the lateral recess here, and it's imagine the foramen, then all the tila covering the inferior portion of the roof of the fourth ventricle. Here's another dissection, and widened dissection, where the left tonsil was removed, and all the tila was removed also, and you can see the entire fourth ventricle in a nice view. And superiorly, you are going to find aqueductus mesencephalic aqueduct, and this is it's a type of view and the final view when you operated on tumors in the fourth ventricle. And here is the floor of the fourth ventricle. The floor of the fourth ventricle is the posterior portion of the pons. That's very important structure to us to understand, because the floor of the fourth ventricle, it's portion, it's a structure that you need to recognize structures, and also we can enter the posterior pons by opening specific entry zones here to operate on intrinsic brainstem lesions. So these are the structures that I would like to show, the anatomy, and I don't know if someone would like to make any question.
Thank you very much, Professor. That was indeed very informative and very nice cadaveric dissection specimens you showed. We could understand the anatomy and various approaches very clearly, but I would like to just request you that if you could keep discussion part at the end, because we've still got one more talk by Dr. Ricardo to go, and we're short of time. So I would request Dr. Ricardo to please deliver his talk, and then we'll come back for the discussion. Dr. Ricardo. We're able to see your screen, Doctor. I think you're muted. Yeah.
Are you hearing me?
Yes, we can
Yeah.
hear you. Please go
We
ahead.
can see.
Okay. Yes. Good morning or good night, everyone. It's very nice to be here from Brazil to Japan. Thank you so much for the invitation to take part of the World Young Neurosurgeon Congress 2022. Thanks for the invitation, Professor Yoko Kato and Professor Ferry Shada. Are you hearing me? Ferry?
Yes, I can hear you.
Yes.
Are you hearing me? Yes. Okay.
Yes, Ricardo.
So today I'm going to talk a little bit about the neuroanatomy of mesial-temporal surgery. I am Dr. Centeno. I'm a Chief of Epilepsy and Functional Neurosurgery, Division of Neurology and Neurosurgery at the Federal University of São Paulo, Brazil. And I'm going to show some landmarks. It's very important, anatomical landmarks to this type of approach. We have four surfaces: the temporal lobe, the lateral surface, the superior surface, the inferior surface, and the mesial surface. And the most complex surface is the mesial surface. And I'm going to show some aspects of this mesial surface of temporal lobe that are very important for us to understand, to approach the temporal horn. So one of the most important things is to say the mesial structures are those that are mesial to the collateral sulci, basically amygdala, hippocampus, and parahippocampal gyrus. And it's very important during the surgery to put the hippocampus parallel to the floor. So I put 45 to 60 degrees from the floor. Try to put the hippocampus parallel to the floor. This is the head position. I did a question mark, like a question mark, and I expose the center of the craniotomy is the upper part of the escamous suture of the temporal bone. So here you have the craniotomy, the upper part of the escamous suture, and I use it to expose the temporal and the part of frontal lobe. So the inferior frontal lobe, the sylvian fissure, superior temporal and medial and inferior temporal lobe with this kind of opening. I opened the dura by a double Y incision, and I can approach the temporal horn by a selective approach or a corticoamygdaloid compactomy that I will call a standard approach. The selective approach is something like 2 or 3 centimeters in the mesial temporal lobe. The posterior part of this incision, the corticectomy, is 4 centimeters on the tip of the temporal lobe. Here is how I make the incision. I use it to make 4.5 centimeters the posterior corticectomy from the tip of the temporal lobe, and something like 2 to 3 centimeters in the medial temporal gyrus. So I go through the medial temporal gyrus through the temporal horn. One anatomical landmark that's very important is the sulci, the temporal lobe. The sulci pointed to the base of the temporal lobe, the sulci of the base, and the sulci in the lateral aspect of the temporal lobe. They pointed all of them to the temporal horn. So all the approaches that you make through the ventricle, one important landmark for us is the orientation of the sulci. All of them send us to the inner part of the temporal horn. So this is the microscope aspect of hippocampus that was opening. We have the choroidal plexus. The first thing when you open the temporal horn is to looking for the inferior choroidal plexus, the inferior to choroidal point. So anterior to the inferior choroidal point, you have the head of the hippocampus. Posteriorly, you have the body of the hippocampus, and when it's started to be thinner here, and it goes to the posterior and go through the posterior part of the pulmonary of thalamus. And in this situation, the plexus choroides goes over the tail of the hippocampus. And in this position is very important because it's here when I make the posterior resection of the hippocampus. So the anterior portion, when I have this kind of view, I have the hippocampus head, the choroidal plexus, the inferior choroidal plexus, the choroidal point, and the amygdala. And in this situation, I need to go through this situation. This situation is the end of the resection. When I want to have this kind of view in the MRI, when I resect the anterior part of the uncus, the posterior and the tip of the uncus, I need to have in the operation this kind of view. When I see by the pia, subpial aspect of the nerves and the veins, it's very important to know the anatomy of the uncus. So the uncus is divided into two parts: the anterior uncus, the posterior uncus, and the apex of the uncus. And there is a relationship between the anterior uncus, the posterior uncus with some vascular and nerve structures. And so the tip of the uncus is related to the oculomotor nerve. So I have another view here that I can see that the anterior segment of the uncus, there is a close relationship with the carotida and the medial cerebral artery. The posterior segment has a relationship with posterior cerebral artery and Rosenthal, basal vein of Rosenthal, and anterior choroidal artery. So there is a vascular bundle that you can, it's very important for us to see through the pia, and these structures make sure that you have resected all the components of the uncus and have an MRI with this aspect. That is very important. And I think that's the most important part of the most difficult part of the surgery to be done. Another view here, you can see the basal vein of Rosenthal. We have the posterior cerebral artery. We have the relationship of the carotida and the medial cerebral artery, the anterior part of the uncus. The relationship of the oculomotor with third nerve with the apex of the uncus. And these relationships are very important for us. The superior limit is very important for us also, because there is no limit between the amygdala and the GPI. So we have some vascular landmarks that are very important. So during the surgery, it's very important for us to see the anterior choroidal artery. The anterior choroidal artery goes from the carotid artery and pass through the anterior part of the uncus and go up, and in the posterior component, it's go through the inferior choroidal point. So the choroidal is a very important landmark between the upper part of the amygdala and the GPI. Some authors also say that there is a point, you have a virtual point, a virtual direction between the anterior choroidal artery and the bifurcation of carotid. The other landmark that you use as a superior limit of the resection is the optic tract. So the optic tract also is very important for us. So optic tract or the anterior choroidal artery, both are very important for us to say that is the limit of the superior resection of our mesiotemporal structures. The lateral resections, we use the collateral eminence. The collateral eminence is an eminence into the temporal horn. It is an eminence of the collateral sulci. This is lateral to the lateral sulcus, of the ventricle. So it's a very important landmark for us because it's the lateral aspect of our resection. This is an intraventricular view of the temporal horn, the hippocampus, the inferior choroidal plexus, the choroidal plexus, the head, the body of the hippocampus, the tail of the hippocampus, and we make a resection. The lateral resections is lateral to the lateral sulcus of the ventricle and over the collateral eminence. It is our lateral landmark to resect the temporal structures. The posterior resection, we use this point here when the hippocampus goes posteriorly and turn medially in direction to posterior part of the thalamus, the plexus carotidis go over the tail. So in this portion, we try to put our posterior resection, and by this way, we can resect the 2.5 to 3 centimeters of the hippocampus as a whole. And the mesial resection is very important for us to know this relationship between. Here I'm seeing the temporal horn, the collateral eminence, the hippocampus head, the body, the tail. You have the fimbria, and then you have, and below you have the perihippocampo gyrus. When you push this, the fornix, you can see between the perihippocampo gyrus and the fornix, the dentate gyrus. This relationship is very important.
I'm extremely sorry to interrupt you, Professor. It's an excellent presentation, but we're just running short of time. Our next session is going to start in 5 minutes. So
5 minutes. Okay.
Yeah. Yes, Prof.
Okay.
Thank you very much.
Okay. So the relationship with the three-edged cantor is very important. So the mesial limit of this resection is done lateral to the choroidal plexus. It's very important for us to know to make the tenia, to have the tenia fornix, the tenia thalamic. Every time you need to make a dissection in the tenia fornix, not in the tenia thalamica. I'm going to show you very fast here a film. Felipe? Okay. I wanted to finish my presentation. It's 3 minutes, please. So I did a resection in the medial temporal gyrus. The posterior limit is 4 centimeters from the tip of the temporal lobe, 3 centimeters in extension. I use the collateral sulci to reach the temporal horn. Here I open the temporal horn, okay. I have the hippocampus, the uncal recess. I am going now to looking for the chordal plexus and the inferior chordal point. It's very important for us. So here, the inferior chordal point. Here we have the collateral eminence, the lateral ventral sulci. I am resecting the lateral portion of the mesiotemporal structures. I'm going through the collateral eminence. So I'm going to see the tentorial and the free edge of the tentorial, the lateral aspect. The posterior resection, I go through the pia, subpial, and I see here the mesial limit is the posterior cerebral artery. Now I'm going to resect the anterior portion. And the anterior portion that I'm going to show you, I have to see I'm resecting in front of the inferior chordal plexus that I have intralimbic gyrus. Below the intralimbic gyrus, I'm going to expose the anterior chordal artery. Lateral to the free edge of tentorial, I have the posterior cerebral artery. So I have the posterior cerebral artery, the third nerve, and the superior cerebral artery, and the posterior communicant, the choroidal arteries. And then I put the hippocampus, I pull side the lateral, the hippocampus, over the free edge of the tentorial, and I have the hippocampus artery, the Ushimura arteries, and I coagulate and resect these arteries, and after that I resect and block the hippocampus. So these landmarks are very important to resect and block, very safe. This is mesial temporal structures. This is the hippocampus in black. So
I'm extremely sorry, Professor, but we're starting our next session.
So, okay, this is the end of my. This is indeed we published
thank you very much, Professor.
this paper.
That was an enlightening session.
Sorry, we published this paper with BNI. All these landmarks we have published in
Ben,
this
are you
paper.
there?
Thank you very much.
Ben?
Thank you.
By Yashar. It has been widely used to treat the most of the anterior circulation and some posterior circulation cerebral aneurysms. The need to minimize unnecessary frontal and temporal bony open, temporal muscle dissection and brain exposure gave the search for variants like mini craniotomies. Interhemispheric mini craniotomy described by Fukushima, supraorbital craniotomy, lateral supraorbital described by Professor Ernest Niemi, and the mini terminal craniotomy that was described by my professors in Mexico, Natal and Gomez Amador. Figueiredo et al. Described it with some modifications 2 years later and termed this procedure like mini-terminal approach. This is the original description of the spinal right keyhole approach that was supported with, by good results in 85 patients. Then the description of the Figueiredo that was comparing with the terminal standard approach, and both show comparable surgical expose and comparable surgical expose. There are many papers showing the or comparing the mini craniotomies for aneurysms, including the supraorbital, the lateral supraorbital, and mini-terminal approach. And all of them demonstrate that the mini-terminal approach is better when the lesions need to make an wide dissection of the sylvian fissure, and also when we need a more lateral exposure. However, on despite of these findings, the mini-terminal approach is used only in a 16% of all of the mini craniotomies. For this reason, we want to demonstrate that this mini craniotomy is a good option in these safe and elective cases. We need to keep in mind the relationship of the terion with the sylvian fissure, and because the center of this approach is in the sylvian fissure, that is enough to reach the most of the aneurysm in the MCA, PCOM, anterior carotid artery, carotid bifurcation, or in the complex of the anterior communicating artery. Like I will show you here, aneurysms in the PCOM segment and the bifurcation, and inclusive in the paraclinoid area, in the MCA bifurcation, and also in the anterior communicating artery complex. The technique is centered in the terion, and we need to follow the sylvian fissure projection by craniometry. It's necessary to establish the frontozygomatic point, but in a more easy way to plan the skin incision. However, a more simple way to plan the skin incision is to center the incision in the posterior aspect of the bony depression of the temporal area, beneath the temporal muscle, always under the hairline. We made an incision of 5 centimeters, and then the subcutaneous tissue is dissected, and then the superficial temporal fascia and muscle are cut in the same direction as the skin incision, and after a subperiosteal dissection of the muscle, self-retractor is positioned. We make a burr hole in the more posterior area of this position, and then a craniotomy of 3 centimeters is made. Here are pictures demonstrating the difference between the standard terional approach and the mini-terional approach. The dura is open in a semicircular fashion, and the sylvian fissure is split in the usual way. Here, for demonstrating the third technique, the skin incision, then the cutting in the superficial temporal fascia, the muscle is included, and then a burr hole is made with the craniotomy. Once the bone flap is elevating, the dura is opening in a semicircular fashion, and we can see the sylvian fissure in the center of the exposition. Once the sylvian fissure is dissected in the usual way, we can reach the MCA bifurcation, in this case with the bilobulated aneurysm. We are applying a clip and then we can explore the entire bifurcation. A small residual is closing by another fenestrate clip, and then the aneurysm is completely obliterated. When to use a mini-terminal approach? We need favorable location like MCA, PCOM, anterocoroidal artery aneurysms, or the complex and the anterior communicating artery. When the size of the aneurysm is small or medium, or in some cases in big aneurysms. Absence of the hematoma, severe edema, or hydrocephalus, and in the patients with good neurological congestion. I will show you some illustrative cases. Here is a case of MCA bifurcation aneurysm. This is the approach. Looks the dura opening less of 2 centimeters. After the sylvian fissure splitting, the aneurysm is in the center of the exposition. We need to put 2 clips to obliterate this aneurysm completely. This is the postoperative image showing this result, and the cosmetic result is favorably to the patient. Here another cases of anterior communicating artery aneurysm. We use the same technique. This is the aneurysm. We need in this case to aspirate some of the gyrus rectus to see all the dome of the aneurysm, and put a pilot clip. After put this clip, we can see the contralateral I2, and then I put definitive clip in the neck of the aneurysm, conserving all the vessels around this complex. CT scan postoperative demonstrating the complete obliteration of the aneurysm. Another case of MCA aneurysm, the same exposition. This is a big aneurysm. This is the superior trunk of the MCA, the inferior trunk. 2 clips were necessary to close this aneurysm. The postoperative image showing the complete resection of the aneurysm. This is the size of the craniotomy that we don't need to put any material of fixation for the bony. Only we need to put the bone flap there. Another case, this is a case of PCOM aneurysm. It's in a young lady. The exposition is the same, and I am applying the clip to show the aneurysm. This is the results, the cosmetic results, and this is the showing the size of the craniotomy. Another case of MCA aneurysm, the same result. This is a bigger one aneurysm in the right MCA bifurcation. I will show you a video to demonstrate that the entire anatomy is showing. This is the inferior trunk of the MCA, and the superior trunk of the MCA. This is the aneurysm, and I applying the clip to obliterate the aneurysm. I will go. So look, the clip of the aneurysm is now closed totally. For this reason, I applying a second clip to show that the aneurysm is closed. We need to keep in mind the inferior trunk of the MCA, and then to put some hemostatic material in the sylvian fissure, and I will show you the size of the craniotomy that is enough to clip this aneurysm. Look, less than 12 centimeters of dura opening in this case. The postoperative control. Finally, a message for young neurosurgeons. Today, there is a false perception that the treatment of cerebral aneurysm only advanced with the advent of the endovascular techniques. However, the open aneurysm surgery also progressed to improve patient outcomes. The open vascular neurosurgery is still necessary in cases like intracranial hematoma requiring evacuation, aneurysm morphology unsuitable for endovascular management, failure of the endovascular therapy, of absence of the endovascular operator. Hard work and do the best. Visit great neurosurgeons, see live surgeries, see a lot of videos, record your surgeries, evaluate your own work, and go to the lab. Remember this phrase: if I hear, I forget. If I see, I remember. If I do, I understand. Our result with this technique in about 70 cases, we have a complete overiteration in 97% of the patients. The operative time is reduced, and also the length of the stay in off-rotor aneurysm inclusive range from 1 day to 4 days. Conclusions: the miniatural approach is safe and effective. Correct selection reduces the length of the stay and cost of the hospitalization. Familiarization with this approach will increase its use over time. Thank you very much for your attention.
Hello, greetings to all. I am George Salazar, neurosurgeon from the Ecuadorian Society of Neurosurgery. I am very honored to share this lecture with you all at the first World Young Neurosurgeons Congress. I would like to thank especially to Professor Yoko Kato, President of the ACNS, the organizing committee, and Dr. Sachin for inviting me to participate on this great event. I congratulate the World Young Neurosurgeons Organization for providing assistance through courses, meetings, webinars to develop and increase the neurosurgical knowledge of anatomical, surgical, and research skills. I think it's vital to assist young neurosurgeons to improve their careers, providing better educational sources, fellowships, and mentoring programs. I completed my neurosurgical residence training in Spain. I work as an attending neurosurgeon at Quito, my city, at the Metropolitan Hospital, where actually I am the chief neurosurgeon. I have been a professor of neuroanatomy for more than 20 years at Catloc University of Ecuador. My special interests include brain and spine tumors, trauma, and neuroendoscopical procedures. The craniovertebral junction, it is a complex transitional region between the base of the skull and upper cervical spine. It is formed by the occipital bone attached to C1 and C2 vertebrae, by the atlanto-occipital and the atlantoaxial joints, forming a dynamic region made of articulations, ligaments, and muscles that contains very delicate neural structures like the brainstem, cranial nerves, vertebral arteries, venous plexus, and visceral elements. A clear anatomical knowledge is necessary to perform safe surgical access, preserving stability. I present some key points to remember when operating on the CV junction. The CV junction is formed by maturation of the pro-atlas and first cervical sclerotomes. Malformations like clival segmentation, basilar invagination, condylar hypoplasia occur between the 4th and 7th weeks of gestation due to failure of cementation or fusion or hypoplasia. Acquired diseases can be caused by trauma producing bone and ligamentous injuries or by chronic lesions with instability like osodontoideum, rheumatoid arthritis, infections, metabolic genetic diseases, and tumors. On the occipital bone, the inion shows the torcular heterophyly. The superior nuchal line localizes the transverse sinus. Insertion of semispinalis capitis muscle is a landmark for the confluence of the sinuses. At the foramen magnum, we identify 5 elements: squamosal dorsally, basal or clival anteriorly, the condylar part that articulates with the atlas. The posterior margin foramen magnum is the ophisthium, and the most anterior midline portion is the bastion. The atlas, the first cervical vertebrae, has bilateral masses that connect both arches and a superior and inferior articular facets. These synovial joints are very powerful. The atlanto-occipital joints limit rotation and are caudally oriented. The atlanto-axial joints are cranially angulated. The anterior arch articulates with the ends of the axis. On the axis, the odontoid process projects cephalad from the body and articulates with dorsal surface of anterior arch of atlas. On its dorsal surface is a groove for the transverse ligament of atlas. The axis has a large bifid spinous process that can be palpated during surgery. Radiological elevation is very important. On the AP view, we have to evaluate the body of the axis, the odontoid process, lateral masses of the atlas, symmetry, and atlanto-axial articulations to search for instability. On the lateral view, we should evaluate the distance between the dens and the anterior rig of the atlas. Other important marks are the bastion, the ophisthium, the posterior margin of the hard bolate, the anterior arch of the atlas, and the posterior margin of the atlas. The most important ligaments ensure the stability of C1-2 joint are the transverse ligament, which is the strongest and maintains stability, locking the odontoid process against the anterior arch of C1 and forms part of the cruciform ligament. The alar ligaments are major stabilizers of atlanto-axial joint space. It holds the dens upright in close conjunction with the skull base and anterior arch. The apical ligament attaches the tip of the odontoid process to the bastion. The anterior atlanto-occipital membrane helps to prevent hyperextension of CV junction. The tectorial membrane firmly adheres to the dura posterior to the clivals, helps to prevent ventral cord impingement with neck flexion, is one of the major stabilizers. Posterior atlanto-occipital membrane helps to prevent hyperflexion and impingement of the atlas on cervicomedullary junction. The mechanical properties of the atlanto-occipital joint are linear motions of translation, flexion, and extension, primarily determined by bony structures with 23 degrees of motion. The atlanto-axial joint produces axial rotation with angular motion, determined by ligamentous structures with 23 to 38 degrees. Kinematics of the atlanto-occipital and atlanto-axial segments helps to differentiate the normal versus injured and stable spine. Injuries to the atlanto-axial complex may be described using the concept of major injury vector. To design a surgical strategy for CBJ abnormalities, we must consider some things. Is the lesion reducible? Is acute? Is chronic? Where is the zone of the encroachment? Is stability necessary? Will require decompression and fusion? Is there a chance for radical resection? Will need radio or chemotherapy. In order to facilitate the anatomical recognition of key landmarks and improve diagnosis and surgical treatment, multiple lines, planes, and angles have been characterized to assess the relationships between the structures of the CBJ. These craniometric lines should be used according to each specific case for diagnosis and solutions at this region. Chamberlain line extends from the hard palate to the ophisthium. The odontoid tip is usually below or just tangential. If the tip is more than 2.5 millimeters above, basilar invagination should be suspected and confirmed if it's more than 6.6 millimeters. McGregor's line extends from the hard palate tangent to the undersurface of the occipital bone. The odontoid should be less than 4.5 millimeters above. McRae line extends from the basin to ophistium. The odontoid should not project above this line. In Chiari malformation, tonsils descend lower than 5 millimeters of this line. This is an example of hypoplastic basi-occiput and maxillar invagination. On the left, 4 cases of hypoplasia basi-occiput. The tip of the odontoid process and the anterior arch of the atlas are above the Chamberlain's line. On the right, Ehlers-Danlos syndrome with severe atlantoaxial subluxation and severe compression of the medulla oblongata. Vertebral artery identification within the suboccipital triangle is a key anatomical landmark to avoid injury during placement of screws and breast fixation. The third segment of the vertebral artery can be found in the occipital triangle, which is defined within the rectus capitis major muscle, the obliquus capitis superior, and the obliquus capitis inferior. The vertebral artery is divided into 4 segments. The V3 segment extends from the exit of the C2 foramen to the point where the artery pierces the dura, and the V4 segment is intradural portion. Due to anatomical variations of these segments, V3 and 4 are likely to be injured. In angiotac, it is advised to document their locations before surgery. For a safer exposure and accurate placement of transarticular screws, verify the correct entry point and trajectory. Location and state of the lesion are the major determinants influencing selection of the appropriate approach. The CBJ can be approached from 3 directions: anterior, laterally, posterior, alone, or in combination. The surgeon should select the most appropriate approach to allow the most direct operative field with the lowest rate of morbidity. Anterior approaches may be used to reach tumors of the atlas, axis, and clivus for resection and fixation of the odontoid process, for decompressing bony malformations that squeeze the brain stem, such as basilar invagination. The trajectory and angles of the endonasal approach, transcervical approach, transoral approach, and common surgical areas are depicted on these different colors. For anterior cervical approach, several neck structures serve as landmarks to identify the approximate cervical spine levels before skin incision is made. The mandible angle is as the C2, hyoid bone C3, thyroid cartilage C4, cricoid cartilage C6, carotid tubercle of Cassignat C6, suprasternal notch T1-2, clavicle T4-5. Anterior cervical approach useful landmarks are anterior border of the sternocleidomastoid muscle, carotid artery, longus colli muscle, anterolateral to medial dissection from the skin, platysmal muscle, anterior border of the sternocleidomastoid muscle, blunt dissection of the cervical fascia to find the carotid artery that is retracted laterally and alar fascia retracted medially, the esophagus, region the prevertebral fascia, longus colli muscle, and vertebral disc. This is an example of a cervical disc approach for a C4-5 discectomy and fusions, where you can see all these steps. Anderson D. Alonso fractures type 2 or rostral type 3 are indication for odontoid screw fixation by the anterior cervical approach. The first part of dissection is the same as for anterior C4 discectomy. When the anterior plane of the cervical spine is reached, a self-retaining cradiocaudal blade retractor is positioned in a rostral direction, and the vertebral plane is followed until the inferior border of C2 is plated. Then a guide wire is directed with neuronavigation or X-ray control for placement of the odontoid screws. To access the high cervical region, several incisions can be done, horizontal or vertical. You can start with a medium zone C4 approach with X-ray guidance and then go upwards First, the patient with cervical dextrination on the upper row, and the second patient with Forestier disease with a huge block of bone spurt that compressed the esophagus, producing total dysphagia. Cervical exposure was done from C7 to C2, and decompression improved patient complaints. To approach an upper cervical spine lesion, a submandibular skin incision, C-volute type, of about 8 centimeters long, from the angle of the mandible to the midline near hyoid bone is done. Previous steps for lower levels are followed. After exposing the platysma, a subplatysmal flap is developed to expose the superficial layer of the cervical fascia and identification of marginal mandibular branch of facial nerve. At this stage, useful landmarks are the gastric muscle, sternocleidoid muscle, facial vein, submandibular gland, and great auricular nerve. With retraction of the gastric muscle, we expose the facial and lingual arteries and hypoglossal nerve. Below the hyoid bone are the superior thyroid artery and superior laryngeal nerves. Once you have identified and preserved these key structures, the final high cervical spine step is performed safely. The transoral approach provides direct midline access to the craniovertebral junction and is most suitable for extradural lesions such as chordomas, chondrosarcomas, giant cell tumors, and rheumatoid panels. The location of the hard palate relative to the CBJ limits superior view, whereas the mandible and base of the tongue limit the inferior exposure. The extent to which the patient can open the mouth limits line of sight in superior and inferior trajectories. Mouth opening should be at least 5 centimeters between upper and lower teeth. Access can be obtained from the inferior clivus to C2. The surgical procedure can be performed by retracting the soft palate and tongue without incising soft tissue structures of the mouth. Extended transoral approaches involve additional incisions and facial osteotomies like transmaxillary Lefort maxillectomy with midline palatal split or transpalatal and median labiomandibular glossotomy. An incision divides the midline of the soft palate. Pharyngeal mucosa is open on the midline, and the longus capitis and longus colli muscles are reflected laterally. When the lower clivus is open, it shows four vertebral arteries, basilar artery, pica, ica, abducens, and hypoglossal nerves. Removal of the anterior arch of the atlas exposes the edontoid process. For the transverse maxillary Lefort osteotomy, a superior exposure of anterior face of the maxillae and anterior piriform aperture is performed. Depending on the location of the lesion, several options are available to perform a combined endoscopic transnasal transoral approach. Some steps include soft palate and uvular retraction, the oral cavity and tongue are retracted in the standard fashion, the endoscope visualizes posterior wall, and a pharyngeal midline incision reaches the C1-2 area. The anterior longitudinal ligament is dissected periostally until the C1 arch and C2 body are identified. The longus colli and longus capita muscles are mobilized laterally and held in place with retractors. Microsurgical tools are used for removal of the pathology and decompression. Additional removal of C1 arch plus odontodectomy, removal of the transverse ligament and ectorial membrane may be required to gain better view. Alar ligament failure results in increased axial rotation and atlantoaxial instability. The effects of transoral odontectomy when the dense transverse ligament are removed are increased rotational movements and highly increased translational movements with instability of the CB junction. The endoscopic endonasal approach requires general anesthesia, patient in supine position, oral intubation, head lightly extended, oropharynx packed, bilateral approach to the nostrils, elevation of nasoseptal flap for closure, bilateral maxillary antrostomy, ethmodectomy, middle turbinate resection, posterior septectomy, and a wide sphenodectomy. The sphenoid sinus septation and mucosa removed. Both above pituitary gland is removed, and the outer layer of dura mater is structured laterally. The intercavernous sinus is exposed and coagulated if required. The upper and middle portion of the clivus is removed with a drill. The exposure is completed as expanded axis with removal of dura, anterior arch of the atlas, and odontoid process. The yellow triangle represents the view of exposure with the endoscopic and the nasal approach. The nasopalatine line in red represents the most inferior limit of the approach. You cannot access the C2-3 discs or do a C2 correctomy. The entire clivus is located above the level of the hard blades. It can be accessed through the nasal cavity and nasopharynx. The upper cervical carotid and stachyon tube form the lateral limit of the exposure of the lower clivus, and the junction of the petrous and cavernous carotid limits the lateral exposure of the upper clivus. In a classical supraoccipital approach, a vertical line of skin incision is made from the external occipital protuberance to C2 and a vascular plate, and the muscles are retracted laterally. It is advised not to do a lateral retraction more than 2.5 centimeter on the occipital crest to minimize injury to the greater occipital nerve, and also behind the arch of C1, only 12 millimeters of the midline to avoid injury of the vertebral arteries. Remember that these arteries are contained within the suboccipital triangle. The C1 and 2 joints should be identified, and the great occipital nerve posterior to C1 and C2 joint is covered by the venous plexus. Exposure of these facets joints is necessary to allow for fusion and safe placement of screws. The muscles of the craniocervical junction are organized in cervical various levels, and the jugular process serves as an important landmark to keep in mind. Exposure after hand removes the dorsal rib of the foramen magnum and partially drill the occipital condyle, and your tubercle can be appreciated. In a straight line, view the anterior rib of the foramen magnum, and to the anterior surface of the neuraxis is obstructed by the lateral rib of the foramen magnum. The posterior condylar emissary vein and portion of the atlanto-occipital joint are drilled, and they can expose what it needs to be taken. In the far lateral approach, the main objectives are management of the vertebral artery, management of the occipital condyle, and subsequent occipital cervical fusion. As a take-home message, I would like to say to young neurosurgeons, meet your patient and be sure of his needs. Don't hesitate to ask for help and assistance of experienced colleagues. Know your patient's anatomy. Often review anatomical surgical landmarks. Take your time. Do not rush on your surgery. Laboratory and hands-on courses are essential. Thank you very much for your attention.
Greetings, dear friends. My name is Byron Salazar. I am the president of the Ecuadorian Society of Neurosurgery and neurosurgeon-in-chief of the military hospital in Quito. I would like to thank Professor Yoko Kato, president of the ACNS, and all the organizers of this fine event, and I really appreciate this invitation to the first World Young Neurosurgeons Congress. In this occasion, I would like to talk about the principles for meningioma surgery, because I think this is the kind of surgery that is the first pathology that residents want to operate and is one of the most gratifying when successful. Professor Al-Mefti published in his book the main steps for meningioma surgery: devascularization, detachment, debulking, and dissection. And I believe it is my duty to try to encourage the new generation, the young residents, the fellows, and the young neurosurgeons to understand the disease and prepare in advance all the steps that are required for successful meningioma surgery, and to try to avoid any improvisation during surgery. All these 16 steps, my own dear rule for meningioma surgery, can be applied to every meningioma case, and it becomes a good exercise to review the principles, the important steps, and some tricks for each type of location. As a first step, the diagnostic radiology. A necessary component of the preoperative workup of meningiomas includes imaging. MRI, with and without constraints, is the gold standard for diagnosis and evaluation of meningiomas. it allows us to get a precise anatomy of tumor location. Edema might predict increased tumor aggressivity and PL invasion. We can also see the degree of encasement of the vessels, like in this case where the ICA can be displaced or totally encased by the tumor. An angio MRI can give us information about the arterial branches involved in the tumor, as well as the venous drainage that is truly important to determine the number of tributaries to reach the sagittal sinus, to evaluate the patency of the sinus, to visualize the trilar and Lavie vein, and of course, preoperative planning for parasagittal meningiomas, falcine, and tentorial meningiomas can be assisted by MRI venography. Of course, an angio-CT can also be useful when it correlates with the 3D reconstructions to facilitate the understanding of the bone deformity and its blood supply. CT scans provide information about the extent of bone involvement that is not well appreciated on MRI, like hyperostosis or osseous destruction. Intralesional calcifications is the most significant predictable factor of slow tumor growth, and hyperostosis adjacent of the skull is highly suggestive of a benign meningioma. Removal of the hyperostotic bone provides a more complete resection and leads to a lower recurrence rate. Another step, the DCA devascularization, which means early preoperative embolization. The debate concerning preoperative embolization of meningioma continues. Even though the main indications for embolization are ECA dominant blood supply, no clinically or statistically significant difference between blood loss, operative duration, gross total resection, postoperative complications, postoperative mortality are available. So as we see here, in large tumors invading the bone that have large hypertrophied feeders that are not reachable for an early coagulation after the craniotomy, can be very well treated by preoperative embolization. Of course, there are some controversies regarding the material, the size of the particles, and the timing for embolization. Another step, drain, the lumbar drain. It is recommended in some cases, like parasagittal meningioma or posterior fossa meningiomas. However, the lumbar drain should be opened simultaneously when opening the dura, especially in posterior fossa tumors, to avoid risk of foraminal herniation. Another basic step, the drawing, which means incision. The main steps for planning an incision are to perform sufficiently wide incisions and cutaneous flaps to avoid of excessive edge and retractions, to care and preserve myofascial and pericranial structures integrity, and preserve the vascularization of cutaneous nerves. The incision must preserve both superficial vascularization of the skull and its innervation, mainly in the anterior, lateral, and posterior groups. The bicoronal incision is useful for unilateral or bilateral fronto-basal portions to treat olfactory groove meningiomas, like in this case. And of course, a more posterior placed skin incision facilitates harvesting a longer pericranial flap. Of course, this question mark incision is used to access the temporal lobe, including the tip, may be used to gain access to the middle and posterior temporal lobes. So the base of the incision should be wide enough, and we should try to preserve the superficial temporal artery, both of its branches. For example, a C incision or a horseshoe incision should have a base twice the size of the height to avoid ischemia. For Fox meningiomas, the skin incision should be carried across the midline so that the superior sagittal sinus may be exposed over the length of the bone flap, allowing to mobilize the sinus. A vertical linear incision, like in this case, involves less trauma to overlying muscles, may be easier to get watertight closure, and it is useful for small lesions in which there is no need to do a big duroplasty. We have different types of incision that can be applied to the retrosig approach. We have a curved retromastoid incision, of different sizes, a modified reverse U, we have a straight line incision, or a lazy S. Of course, be careful to preserve the fascial branches when you perform your incision. According to the article published by Campero, he describes the zygomatic facial triangle, which is formed on the upper border of the zygoma anterior to the border of the tragus, 26 millimeters below this point and 18 millimeters in front. In this triangle, it's a safe zone of dissection. But if the incision is outside this triangle, like in this picture, there is a great risk of damage of the facial nerve. Another step, design, which means craniotomy. Boreholes can be placed over the sagittal sinus by controlled drilling, or can be placed on one or on both sides of the sinus. Bone flap elevation can be done in one stage or in 2 stages. The exposure of the craniotomy should expose an area of 3 centimeters around the margins of the tumor. And in some cases, like parasagittal meningiomas, the craniotomy can cross the midline, like in this case, or just could expose the border of the sagittal sinus, like in this case. The elevation of the bone flap can be complicated, but engorged diploic anastomosis. So in cases of severe tumor-induced hyperostosis, the craniotomy flap can be planned around the tumor by placing multiple burr holes, like we see here, and connecting them by rongers or curves and punches, and a central portion of the bone can be left attached to the tumor. For depilation, like this intraventricular meningioma, we can use craniometric points and confirm with neuronavigation and plan a smaller craniotomy, like in this case, the intraparietal sulcus, to approach the lesion. For many meningioma surgery, we need to drill the bone to get to the tumor. So this is another important step, drilling. In clinal meningioma, once the craniotomy is established, we proceed with the extradural work that leads to the removal of the anterior clinal process. After that, the optic canal is drilled and decompressed. So the dural layer over the optic canal is opened along the optic nerve. So this allows to access the tumor, extending into the optic canal. For vestibular meningioma with auditory canal invasion, we first drill the posterior wall of the canal up to the fundus, and we identify the intracanal tumor and proceed to dissect it from lateral to medial, dissecting from the vestibular, the 7th and 8th cranial nerves. For school-based approaches have been developed to improve the access to clival and petroclival meningiomas by drilling the different portions of the petrous bone, such as anterior or posterior petrosectomies. The next step, devascularization, but early transoperative devascularization. Early interruption of the blood supply is critical in minimizing blood loss during tumor surgery. During parafalcic meningiomas, like here, for small meningiomas, early devascularization can be achieved opening the interhemispheric fissure to allow to access the base of the tumor adjacent to the fox. Sphenoid meningiomas receive their main arterial supply from middle accessory meningeal arteries. So to get an early devascularization, we can use extradural approaches to the anterior third of the middle fossa. In convexity meningiomas, coagulation of hypertrophied and tortuous branches of the meningeal arteries are performed easily after the craniotomy. For clinal meningiomas, they get their blood supply from the posterior ethmoidal branches, anterior dural branches of the middle meningeal artery, as well as the meningoorbital branches. In this case, an olfactory groove meningiomas, anterior and posterior ethmoidal arteries can be surgically divided early in the procedure. Our next step, the durotomy. we can find microscopic and microscopic nodules at a distance of 1 to 3 centimeters from the site of the attachment of the meningioma. So a dural incision is made circumferentially around the tumor, approximately 2 centimeters margin from the construct enhancing component of the lesion. So the dura is then coagulated and resected with the tumor. In parasagittal or Fox meningiomas, a semilunar dural flap along the sinus is elevated. And of course, in some cases, we can use patties and a small dural incision to start opening the dura and then debulk the tumor. Of course, we can do it with a knife and with small incisions depending on the size of the tumor. There are a few variations to open the dura in the retrosic approach. We can do it in a semicircular fashion, a straight fashion, or in this like C-way fashion. The next step is the delimitation. During initial dissection, we try to identify the presence or the absence of an arachnoidal plane between the meningioma and the adjacent brain tissue. The next step, disassemble, the art of breaking the tumor. In some cases, there are huge meningiomas that protrude the bone. This extracranial component needs to be addressed first. Of course, sometimes in calcified tumors, we will need to break the tumor in a piecemeal fashion, using sharp blades with traction and contratraction maneuvers, like we are doing right here. The next step is the debulking. For lesions bigger than 3 centimeters, internal debulking with ultrasonic aspiration must be performed to facilitate dissection of the tumor capsule. You can also use your scissor or blades to initiate the debulking of the tumor. Another way to debulk the tumor is to use cautery burners. The next step, arachnoidal dissection. We can see here in this video taken from the Almefti collection, we can see how the arachnoid plane must be maintained such the arachnoid is dissected from the tumor and not from the brain, with this peeling away movement done with traction and contratraction maneuvers. Of course, in parasagittal meningiomas, bridged veins must be preserved in the interhemispheric approach for removing large Fox meningiomas. This maneuver of taking all the arachnoids from the veins, it's called the Sujita-Kobayashi maneuver. If the tumor has violated the pial surface, gentle dissection and bipolar coagulation is done to separate the capsule from the brain tissue. The coagulation of the capsule can be done to shrink the tumor and to create a wider arachnoidal plane. There are some reports about vacuum-assisted in-block resection technique. This can be done in medium to large convexity meningiomas. Another dissection technique is the water dissection technique, an effective method to open the cleavage plane between extra-parenchymal masses and the adjacent brain. This was taken from the Professor Yuha's neurosurgery videos collection. We have to think about the tumor mobilization. The tumor capsule is separated from the tissue, respecting the arachnoidal plane towards the resection cavity. So we can move forward, backwards, or side to side, always in direction to the cavity. The next step is the disconnection, in-block versus piecemeal disconnection. The main advantages of in-block resection or removal appear to be a lesser bleeding and shortened operative time, but this is important in small meningiomas. A piecemeal resection is mandatory in situations where an in-block procedure is difficult to obtain safely, like in medium to large meningiomas or meningiomas of the skull base. The next step, we have to think about the dura implantation. We have to think that tumor cell infiltration of the dura tail is quite common and may be found in more than 2/3. So to accomplish a complete resection of the dural tail, the craniotomy should be approximately 1 centimeter larger than the dural tail, prompting a significantly larger craniotomy, requiring maybe a larger skin incision a more extensive dural reconstruction flap, and a more prolonged operation brain exposure in some cases. But that is why I personally like to perform bigger incisions to get a larger pericranial flap. Of course, we have to pay attention to the dural implant and try to remove it as possible. If the tentorium is in the tentorium, for example, an attempt to dissect the tentorium is made, or the grade 0 meningiomas for Fox meningiomas, like Professor Almefti has already published, and we can see here in these surgeries. The next step is the duroplasty. Regarding duroplasty, it can be done with pericranium, fascia lata, fascia temporalis, bovine pericardium, or synthetic material. In petroclavial meningiomas, it's not possible to perform duroplasty. For this reason, it is necessary to perform a vascularized gallio-fascial flap. So this flap can be directed and cut lengthwise so that the tip of the flap can reach the petrous apex. The next step, deformity, the bone defect, which means cranioplasty. It is fundamental to have all the different materials so we can perform a cranioplasty in our intent to make a Simpson 1 resection. Affected bone must be discharged. What will be my take-home message for young neurosurgeons? The learning curve is hard. The best surgeons focus on the patient and not the disease. Operate slow but think fast. Be patient and prepare the surgery before going to the OR. Good results will come in time, and work with desire, devotion, and discipline. Thank you very much for your attention.
Thanks for your invitation. Thanks for coming. My name is Carlos Arias. I am a neurospine surgeon and work in Ecuador, South America, in a city named Cuenca. I work in the Hospital Universitario del Rio and perform only spine surgery. I don't have any disclosure. Okay, the traditional surgery is classic, proven, operating with many surgical benefits, such as a directal neural decompression, ability for multiplanar reduction, dorsal instrumentation, anterior column support, and some disadvantages too, such as require large exposure, extensive blood loss, significant soft tissue injury, muscle ischemia, and the iatrogenic muscle injury is the most important problem in the classic surgery. We have many papers that support that the minimal invasive techniques is growing and has many advantages in many patients, in many procedures with a less blood loss and early recovery in the patients. The objectives of the minimal invasive surgery is a maximum access with a minimal disruption. Use an anatomical natural corridors, no muscle or ligament injury, minimal disruption on spinal segmental architecture, preserve the spinal stability, and decrease the postoperative pain and blood loss, and then a quickly recovery. We have many approach to the cervical spine. If you have a lateral pathology, you need a lateral approach. And if you have a central pathology, you need a central approach too, in one level or multi-level. We start with a foramen stenosis. The typical foraminal disc herniation is a ventral root compression, or such this case, we have a facet hypertrophy, making a posterior foramen compression. In both cases, we can use a cervical foraminotomy. A minimal invasive procedure is very important. The patient positioning, make a good neck flexion. This is our goal, and make a little incision, 1.5 centimeters paramedian incision. We use serial dilators, and we use this minimal invasive platform. This is a Maxes retractor above invasive. We can see the lamina, and we can use the loops, or we can use the microscope too. This is our goal, and then you start the foraminotomy. We can see the nerve root at the bottom of the images. This is the CT scan post-op and the cosmetic result. Is usually this type of procedure is a surgery day. The surgery was performed at morning, and the patient go to the home at afternoon in the same day. Okay, if you have a posterior pathology, we prefer to make a hemilaminectomy, uniportal hemilaminectomy. In this case, we can see a cervical stenosis. And if you can see in this image, in the axial view, you can see a right flavum hypertrophy. And then make a hemilaminectomy and have a good decompression. This is our cosmetic result, and the patient go home to the same day. When we have a posterior pathology with a posterior bilateral compression, we prefer to perform a paramedian biportal approach. In this case, you can see a dorsal compression on the spinal cord with myelopathy. This is a high intensity signal in this T2 MRI. We have two incisions, a paramedian incision, 1 centimeter lateral to the midline in both sides. In this type of patient, it's very important to check on the CT scan the depth muscles to planning your approach. In this image, you can see the first one to the left exposing the hemilamina, and then resecting the flavum ligament, and you can see the full decompression, the dura mater on the right side. This is final results on CT scan, a good laminectomy, and the MRI. If you make a comparison, the pre with the compression in the post is look great, and the patient look great too. This is a mid surgery, a day surgery too. Go home in the same day. When we have a multi-level pathology, principally with a posterior compression with a ligamentum flavum hypertrophy, we prefer to use some hemilaminectomies, alternate this type of procedure. And you can see in this one an hemilaminectomy, and this in the lower level, in the other side, other hemilaminectomy, and then in 4 levels, we can make this type of decompression. In your CT scan, you can see our final results. And this day surgery too, and the patient go home in the same day. This is the CT scan, a 3D. You can see our final result too. The minimal invasive spinal surgery had two advanced indications like intradural extramedullary lesions. This is a posterior compression, a cyst, a neurocystic sarcosis, and C2, C3 dorsal compression. We can use our minimal invasive platform, make a 2 hemilaminectomies, exposing the dura, open the dura, take out the cyst, and make a standard fashion dura closure, a watertight dural closure without fistula, without leaks. This is another case with a ventral compression. This is a neuroentheric cyst on C1, C2 ventral compression. We can see the positioning, our retractor, and exposing the dura mater on the one side. We can make a durotomy and put the sutures in our device. This is a plastic device that we perform to make a tension on the sutures and open your file, your work file. We can see C2 dorsal nerve root, and this is the cyst on the ventral part, on the ventral aspect of the spinal cord. We take out the cyst, and this is our watertight suture of the dura in our final cosmetic result. This is an MRI pre and post-op. You can see a successful decompression. This is another clinic case, a female 65 years old with 6 months of cervical pain and 3 months of quadriparesis with pyramidal signs and gait disturb. We can see in this MRI a lesion, intradural extramedullary lesion, like a possible meningioma, make a compression on the spinal cord. We can use many strategies, maybe anterior surgery, corpectomy, and fusion, or maybe a huge posterior surgery with fixation too. But in our case, we decide just to make a uniportal approach and make 2 hemilaminectomies and put our serial dilatators, our minimal invasive platform, and you can see all the tumor can take out and make a dural closure. This is our final result. In CT scan, you can see 2 hemilaminectomies without instability. We can preserve all the posterior muscle and ligamentous band, such as facets. And you can see the final MRI, pre-op and post-op. We can take all the tumor and make a good decompression too. This is a patient, this is a cosmetic result, and discharged 21 hours post-op. Our conclusions: the mid-cervical approach has effectiveness. The preservation of the muscle ligament posterior band is very important. Avoid infusion with less blood loss, early discharge, less 24 hours, and return to the daily activities. Thank you very much. This is my city, Cuenca, Ecuador.
So hello, professors. So we have finished 4 lectures for the Latin American section, and thank you so much for the really excellent presentations. So may I open the discussion to the floor to see if there is any questions from the floor?
So can I ask Dr. Salsa? I'm Dr. Kato. So thank you very much for the father and the son, Professor Salsa from Ecuador. Thank you very much. Can you hear?
Yes, Dr. Kato, it has been an honor to be in this program, this great Congress. Thank you very much for your invitation. Let us participate.
Thank you so much. So I think that I want to ask both of you. So just to the father at the beginning. So I think Shibuya Junction is quite difficult for especially the young doctors. I think your recommendation is to learn the anatomy first, and also especially the anatomy of the vascular area again. And so what is the most important tips for treat of the CV junction? Just let us know.
Yes, for young neurosurgeons especially, I would like to tell them that they should know the anatomy first and their patient's anatomy, because every patient is different, and they should review all the x-rays, MRIs, and examinations. And also during the preparation of their training, they should have laboratory training and hands-on courses, which are very useful. And they should have a tutorial to help them to learn this. Has special steps that should be learned, and the landmarks should be remembered because they are very useful. So that would be my first advice to young surgeons.
So much. And I want to ask both, what about recent treatment with the endoscope? So endoscopic treatment for such a small lesion. And I want to ask both Professor George and Byron, both. Thank you, Byron. What a wonderful talk. Thanks so
thank
much.
you. Thank you very much, Professor Kato. It's really an honor to be here with you. And I guess the issue with endoscope is that we have to know the pathology. For big meningiomas, always it's difficult to perform a big surgery within a small hole. So I guess it will depend on the location of the meningioma. It would depend on the size of the meningioma, and of course the experience of the surgeon. I guess not everyone like yourself has it's a master in this fine endoscopic techniques, so it's a learning curve. And I guess for young neurosurgeons, I think they have to first to learn the anatomy, to learn the disease, to know about the natural history of the disease, and start big. We know big incisions, big craniotomies, and when they get a little bit of more experience, they can get to smaller craniotomies and use these new devices like endoscope that will perform, and will be a good advantage for their development as a neurosurgeons.
Okay,
thank you very much, Professor. Once again, thank you very much for your invitation.
Can I ask a question? Yeah, and can I ask a question to both Professor Salazar? And thank you for your lectures concerning the tumor approach. I see that in your slides, seems your center have some tumor embolization, And also, you mentioned some scalpel approach to, from behind. I think they are very useful for the young neurosurgeon. I have a question about the glomus tumor. So it's not commonly seen, but when we talk about glomus, we'll think of a preoperative embolization and also the subsequent surgical excision. Is there any experience on the timing for the preoperative embolization? Any tips? And also, what surgical approach would you choose for the glomus tumor?
Yeah, thank you very much, Professor Ben. I think the issue about embolization is that regarding all the wide articles reviews, we know that there is still no level 1 evidence that it will be useful, regarding time, regarding percentage of embolization tumor, and of course the hemorrhage rate. So I guess it will depend on the institution guidelines. For myself, I guess sometimes we follow Professor Almefti's guides that he says that we should, if we are going to do an embolization, we should do it in the OR with the hand already open, in a hybrid OR, so we don't have the issues about ischemia and edema. And of course, we all know that for some embolization meningiomas, we have to do it, if not before the 72 hours, before the 3 days. I myself, when I have to do an embolization, I try to do it to the next day or 48 hours, I don't try, I guess if you left more than 72 hours, you will have, once again, all the vessels will be open, so it won't be as inadequate as it should be. And there are a lot of complications about embolization still. I guess the size of the particles also has been an issue with so many reviews. If are big and big particles, they won't be, as good as the small particles. The small particles can migrate and can have their nerve pulses. So I guess it's fine to have all the equipment, all the possibilities, and of course to analyze what kind of tumor are we going to treat. If I can do a craniotomy and have a proximal control and a pre-embolization intraoperative without any DCA or embolization procedure, but it will be the best. Thank you, Professor Ren.
I see. Thank you so much. So is there any questions from the floor?
Sachin, any question to them? I think it's a very interesting of the day surgery, because it's getting popular in Japan also. So a few hours or 1 day stay is a very limited time for the patient. I think. What exact you mean a minimally invasive treatment? Just let me know. What is the criteria in your field? I think maybe the speaker or the spine cases. Thank you. Excellent talk. Thank you very much.
Okay, Dr. Kato, can you hear me?
Yes, very clearly.
Okay. Okay, thank you for your invitation, and congratulations too. I think that the minimal invasive spinal surgery is a growing technique. Have some advantages, but it's very important to think in minimal invasive technique every day, and all the procedures is very keep in mind that is successful but this technique, in not try to make an open with a little complication, is very important. The learning curve and they keep on the technique every day, every patient with good results.
Okay. So do you use a very special instrument when you do the minimally invasive?
Yeah, maybe the minimal invasive platform to work throughout the tube, but we can use the loops, we can use the microscope with a microsurgery technique without problem. But it's very important to preserve all the muscles of the normal anatomy. It allows the patient can go to home on same days or the next day of surgery is the quickly recovery with this type of technique.
Okay, so do you get almost the same the results in between the minimally invasive or a normal surgery?
Yeah, I think that we have some advantage, lot of blood lost, but early discharge and the early return to the daily activities with the goals of the surgery is the same with the traditional surgery. Take out all the tumor, make a good decompression, maybe have a advantage like avoid instability, some segments, or avoid fusions, screws, plate, cage, etc.
Thank you. So can you do sometimes a local anesthesia or general?
No, it's a general anesthesia. Some procedures, maybe 1 hour, 2 hours, but it's a general anesthesia is better for us.
Mm-hmm. Thank you so much. It's a very nice talk.
Thank you, Professor Cato.
And Professor Carlos, and there is a question in the Q&A box and concerning your lectures. So the question is raised by Elham. The question is it safe to perform the decompression laminectomy on cervical spine without doing the stabilization?
Yeah, if you take out just a lamina, preserving the facets and preserve all the muscle and ligamentous posterior band, you can make, sorry, you can make instabilization of the spine. If you take out facet, if you retracting the muscle, if you can make a instability and need to make a fusion, but when you work throughout the tube, preserving all the muscles and all the articular process, you preserve the stability of the spine.
So do you also do the minimally invasive pedicle screw? Do you use navigation or?
Yeah, in the cervical spine, no. But just on C1, C2, we can put the screws throughout the tube. But in the facets, in the cervical spine, now it's better to the traditional technique. But in the thoracic and lumbar spine, we can use the percutaneous traditional minimal invasive technique to put the screws. It's very safe and quickly too.
I see. Thank you, Professor.
Thank you.
So it seems Professor Cato want to speak. Yeah.
So Sebastian, thank you very much for your nice talk related with the aneurysm cases. So your minimally invasive, especially the mini-terminal approach. So the mini-terminal approach, and also do you do the supraorbital approach for the certain some aneurysm cases? Please unmute, please.
Okay, thank you, Professor Cato, for the invitation, and congratulations for all your work for the neurosurgery community all over the world. And I prefer the mini-terminal approach because you have more lateral exposure than supraorbital craniotomy, and also is more easy in my hands to dissect the sylvian fissure. And in this time, I never use the supraorbital craniotomy. I use the mini-terminal in especially in cases in unruptured aneurysms, but in some cases in grade 1 subarachnoid hemorrhage is also a good condition for clip.
One more question. Can you do the anterior temporal approach with the mini-terminal approach? So it is easy to approach the posterior circulation aneurysm.
Is exclusive, I think is exclusive for anterior circulation aneurysm because the size of the exposure is very limited to go for the posterior circulation. And this time that the craniotomy has evolved, we will learn some words from Professor Mura from Chile. He's doing an extradural mini-terminal approach, and he's going to the posterior fossa lesions in this time, but at the moment in my hands, my experience is limited only for the anterior circulation aneurysms in selective cases.
Okay. So this final question is any pitfall when you do that mini-terminal approach? Any complication or pitfall?
Okay. Yes, you can have complications like the usual pterional approach. In some cases, some perforators are very adherated for the dome. And in our series, we have maybe 3 or 4 cases of lacunar infarcts, but I think it's not for the size of the craniotomy, but most for the morphology of the aneurysm. But the results in generally are good because the key point is the good selection of the patient. If you go in this craniotomy for patients with hematomas or hydrocephalus or severe edema, I think is not a good option in the complications. Is too much for that.
Thank you very much.
Thank you, Professor Cato.
We learned a lot from your lecture. Thank you. Ben?
Thank you.
Thank you.
Yes, and thank you so much. And I think most of young neurosurgeons really learn a lot from this series of lecture. Maybe shall I let Professor George Alessa to conclude the session, to say some few words to the young neurosurgeons?
Well, in the first place, I would like to congratulate Professor Yoko Kata, Dr. Sachin, and all Dr. Ben, and all the equipment that works in this great Congress, and also to the team that has represented the Ecuador Society of Neurosurgery. They all have given excellent lectures, and we are learning a lot. All of we are participating and learning at the same time. So I would say to all young neurosurgeons to keep learning step by step. Every day you have to practice, every day you have to apply your knowledge and never stop in this process of learning. Thank you very much to everyone.
So thank you so much. So the next session would be the medical student and neurosurgery resident presentation session. And Dr. Hira, who is here, will also chair the session later. Maybe we have a 5-minute breaks before the start of the next session.
Thank you. Bye-bye.
Thank you. Thank you very much, Professor Cato. Thank you very much, Ben.
Thank you so much.
Congratulations to all.
Thanks.
Bye.
Hello?
Dr. Hira, are you here?
Yeah, I'm here. Can you hear me?
Yes, yes, I can hear you. So, the next session would be chaired by Dr. Hira. So maybe I'll let Dr. Hira to chair the session and introduce the session on the medical student and neurosurgical resident presentation section.
Thank you so much, Dr. Ben. I am very thankful to you, Dr. Sachin, for coordinating this really well. And I'm most thankful to Professor Yoko Kato, who provided this platform for neurosurgical medical students and residents. And they will be able to talk on this platform and share their abstracts. And I mean, it's a great opportunity for them to be speaking to mentors. I would like to call the first participant, Syed Shahan Heather from Canada. He's a medical student and will be giving a brief overview of brain tumors and their management.
Hi everyone, my name is Shahan Haider. I'm a first year medical student at the University of Toronto, and the focus of my presentation will be on providing an overview of brain tumors and their management for an entry-level trainee in neuro-oncology. I don't have any disclosures to make. At the simplest level, a brain tumor can be defined as an abnormal growth in the brain. These are usually a very heterogeneous group of tumors, and one way to think about them is where they started. So if they start from tissue inside of the brain, we usually refer to those as a primary brain tumor. On the other hand, if they arise from tissue outside of the brain, we usually refer to those as metastatic brain tumors. This would be in a case for lung cancer that could metastasize and go to the brain. In this presentation, we will focus predominantly on the primary brain tumors. As I mentioned previously, brain tumors are a very large and heterogeneous group of tumors. The most common type of brain tumors, primary brain tumors, are meningiomas and gliomas. Meningiomas, which arise from the lining of the brain, comprise approximately 35% of primary brain tumors. They're usually benign or grade 1, but they can be of a higher grade and malignant. Gliomas, on the other hand, are tumors that arise from the glia, the supportive cells of the brain, and they comprise approximately 30% of primary brain tumors. And by far the most common type of glioma, which most people have heard about, are the glioblastoma, which comprise approximately 50% of gliomas. The current 2021 World Health Organization classifies approximately over 150 brain tumors on the basis of histology, molecular biology, genetics, and immunohistochemistry. This article is an excellent resource for entry-level students to get a better understanding of brain tumors. The common type of adult brain tumors that are encountered in the clinic are astrocytomas, oligodendrogliomas, which are of a lower grade, as well as a higher grade glioblastomas. In children, however, we see ependymomas and medulloblastomas, which won't be the focus of this presentation. Oligodendrogliomas are, as I mentioned, low-grade gliomas that develop into a higher grade. They start off as often being a grade 1 and they develop into a grade 3. They usually never develop into a grade 4 glioma, which is why they're often termed as one of the most benign gliomas. And their median age of diagnosis is 43 and survival is approximately 15 years. The definite diagnosis is on the basis of the IDH1 or 2 mutation, as well as a chromosomal arm 1p19q co-deletion. These tumors respond usually very well to radiotherapy. On imaging, on CT, they're usually invisible unless they calcify. And the lower grade ones do not enhance, while the higher grade ones do. Astrocytomas, on the other hand, they also develop into a higher grade glioma, but they start off as being a slightly higher grade than oligodendroglioma. The grades are 2, 3, and 4. Their median age of diagnosis is around 38 and survival is around 10 years. And they're characterized by, again, that IDH mutation, but they do not have the 1p19q co-deletion. On imaging, T1 imaging, as we go from a lower to a higher grade, what we see is increased in enhancement, mass effect edema, as well as the loss of definition. Glioblastoma are the high grade 4 gliomas, and their median age of diagnosis is 65. Their median survival is around 15 months with appropriate treatment. And their median survival is around 5% at the 5-year mark. Their management entails surgery, chemotherapy, and radiation. And an important point to note is that we recently underwent a small change in terminology, where previously we had a secondary glioblastoma, which could develop from an astrocytoma with an IDH mutation, but that no longer exists. And all glioblastomas are now defined on the basis of having a wild type IDH gene. Other important points to mention about genetics is that there's a lot of genetics plays a major role in neuro-oncology. Developments in molecular biology, genetics, and genomics have really revolutionized neuro-oncology. For example, very recently, researchers in Toronto used genomics-based data to actually classify meningioma patients who will have a better or worse prognosis, which is very important for clinical decision making. Another important point to talk about is the MGMT hypermethylation. And the hypermethylation here usually confers a better prognosis and response to radiation and medical therapy. The treatment planning often requires tissue diagnosis, and the final goal of therapy for the management of brain tumors is to reduce the size of tumor such that it can be handled by the immune system. For brain tumors, however, that is quite difficult, and the likelihood of a cure is small, and the risks to the brain are quite large. And in order to improve this therapeutic ratio, usually a multimodal approach is taken, which comprises of neurosurgery, radiotherapy, as well as chemotherapy, which is where neurosurgical oncology comes into play. So neurosurgical oncology is the treatment of patients with both benign and malignant tumors of the central and peripheral nerves using surgical approaches. And it's predominantly done for two big reasons. One is for biopsy, which guides the diagnosis, prognosis, as well as the management of the tumor. And secondly, of course, for the resection of the tumor. The common approaches that neurosurgeons take are a craniotomy, where the skull is open, in addition to a more minimally invasive or endoscopic approach. And throughout these approaches, imaging studies, MRI, CT, they always guide the surgical approach and determine the extent of resection that is possible. The extent of resection is a very important point to talk about in neurosurgical oncology. And it is largely dependent on where the tumor is situated in relation to another patient's anatomy. While some tumors might be very accessible, other ones might be surrounding important structures. And in neurosurgical oncology, the aim is always to resect the maximum amount of tumors while maintaining normal functionality. While cytoreduction through other approaches can be helpful in doing that, there are other approaches that neurosurgeons take that can improve and make those challenging areas a bit more accessible. For example, intraoperative MRI, in which MRI technology is used to obtain accurate pictures of the brain during the surgery and guide the resection, is one approach. Another approach is using fluorescent guides, such as a 5-amino-levulinic acid, which kind of causes the malignant glioma cells to fluoresce, and can be very helpful to find the margins of the tumor and resect as much of the tumor as possible. And of course, there are many other agents that are helpful to tackle these more eloquent regions, such as laser ablation, confocal microscopy, brain mapping, more recent ones like Raman microscopy, which are on the horizon. So in summary, brain tumors are a very large and heterogeneous group of tumors, and meningiomas and gliomas are the most common type of tumors. Current management involves chemotherapy, radiation, and neurosurgery. And neurosurgery plays a very important role in the management of these tumors, and it is a field that is embedded in technology and genetics. And with that, I conclude my presentation, and thank you so much for listening.
Hello, everyone, and thanks for the opportunity to present work titled Effect of Supportive Educational Climate on Learners in Endovascular Neurosurgery, a pilot project. Before I start, I'd like to thank Dr. Leo DaCosta and Dr. Ashish Kumar, both personal and professional mentors who heavily supported this work. I aim to explore gaps in endovascular neurosurgical exposure during Canadian residency training, further to evaluate trainee willingness and interest to pursue endovascular training in junior residency, and to assess the efficacy of a dedicated endovascular training pilot program. My name is Arman Malhotra, and I'm a current third-year neurosurgery resident at the University of Toronto. So some background on the topic. Most residents pursue endovascular fellowship after residency if they are interested in interventional training. Neurointerventional exposure for residents is limited during neurosurgery residency. And as a result, an in-depth knowledge of neuroangiography and cerebrovascular disease becomes difficult. This is a diagram sort of showing some problem and gap heuristics. So you can see residents and faculty, and I'm not sure if my pointer comes across, but what you have is knowledge that's known by yourself, knowledge that's known by others, and mechanisms through which you proceed through this diagram are very important to understand. So for us to get exposure to this blind area, we need to ask and have didactic knowledge to move into this category. Now, to move into the category of things that are unknown to others, so area that your staff might not be known about, is sort of the area that we talk about in terms of research and more sort of further down the road of professional development. So we're really talking about taking residents from being in this area of knowing certain aspects about vascular neurosurgery and moving them to an area that's well known by others and staff, but not well known by residents. So there is a problem of lacking firsthand exposure to endovascular neurosurgery. And in particular, limited exposure might generate a false bias in management of vascular pathology. This really speaks to the importance of being a hybrid neurosurgeon. And no formal regulation is currently in place by Canadian licensing bodies to mandate endovascular training in neurosurgery. So what that means is you can actually become a fully qualified neurosurgeon and never have done an angiogram in your life. So the research question we pose is a mandatory curriculum change would require formal buy-in from the Canadian licensing body and regulatory committee. So we hypothesized an enriched and supportive and educational climate in endovascular neurosurgery would likely engage the residents, expose them to endovascular techniques, and generate interest through experiential learning. The methodology for this project, so we took 7 neurosurgery residents who were recruited over a period from February 2021 to October 2021, and they were invited to participate in supplemental endovascular procedures during a general neurosurgery rotation, each of which lasted 3 months. Pre and post rotation surveys were administered, and during the rotation, residents were exposed to an enriched endovascular neurosurgery learning atmosphere. And we can see here this Maslow motivation model. You really need to have this cognitive need fulfilled before you can kind of get to the higher levels of knowledge acquisition. Enriched education environment. So what that meant, this is sort of detailed here. I won't go through every point, but there were weekly neurovascular rounds in which angiography and patient cases were discussed. Residents scrubbed and joined angio cases, so about 10 procedures in that period of time. They were informed about basic hardware, and there was formal didactic education about how to use different techniques. And there was a hands-on femoral puncture workshop as well under supervision. There was an opportunity to be guided through navigation of the femoral artery up to the aortic arch, and one-on-one discussions about what you think you need to know and about unperceived needs about what you might not know. These are some pre-rotation comments that were picked from some of the feedback. So for example, some of the goals from residents were to understand neurovascular anatomy and reading DSA and CTA, and to learn basic techniques about navigating angiograms. Some other pre-rotation comments, so to become comfortable with femoral puncture and groin closure and learn fundamentals of hardware used in endovascular cases, and beginning to select supraaortic vessels. So the results from the project, some baseline knowledge done on the pre-rotation surveys. So have you ever done an angiogram before? That was 100% no. Would you like to perform an angiogram? Yes, in 100% of cases. How comfortable are you reading a cerebral angiogram? And this was sort of mixed. So there was some more comfort maybe with anterior circulation. Some residents felt comfortable reading both, and most of them felt they were at the novice level. And again, you can see the responses to knowledge of basic hardware and about how to operate a biplane angio machine was, the majority was no. I have the overall post-rotation feedback here. Hopefully you can see that on the recording. Now, the areas that I wanted to highlight are, so how important do you think endovascular rotation is for your education as a resident? So most residents felt like this was moderate to high importance. What is the extent of your current exposure? So post-rotation, there was improvement to sort of more observation, some of them with participation. how many punctures have you done? So now the numbers have sort of been more favorable. So you can see most residents got 1 to 5 punctures after this rotation. And how comfortable are you? So some people, 71% were comfortable to do it with supervision. So limitation of this pilot project, few number of residents, 3-month rotation is a brief period of exposure, and there wasn't dedicated angio time. So the residents recruited were balancing the general neurosurgery commitments and a full OR, and plus the other neurosurgical staff were operating as well. So we had to cover those cases. Now, this is a picture of the team. So this pilot project appraisal explored learners' needs, provided our learners with hands-on experience and emphasized experiential learning. Now, post-rotation feedback was generally positive, generally great rotation, only wish there was more time to spend in the angio suite. And so there were a few closures, 1 supra-aortic vessel navigation, and the comfort level was generally increased. So the next steps, ultimately, we need to do a formal needs assessment study on a larger scale, identify barriers and continued efforts to eliminate them. And ultimately, we aim to take this pilot project to do a larger project to inform residency training sites in Canada. So the next step will be to do a large national survey about this gap. I know I'm out of time, so thanks so much for your attention. And really, it was a pleasure to be involved in this conference. Thanks for having us.
Hello, everyone. My name is Ann Manser, and I'm a 4th-year neurosurgery resident and a PhD student in Dr. Ivan Radovanovich's lab at the Krembil Research Institute in Toronto. Thank you so much for inviting me to present our work entitled Genotype-Targeted Therapy with MEK Inhibition for a Severe Facial AVM in an Adult Patient. We have no disclosures to present. As we all know, AVMs are high-flow shunts between arteries and veins without an intervening capillary network. These fragile vessels are prone to hemorrhage and can cause neurological deficits, pain, deformity, and ultimately significant morbidity and mortality for our patients. The traditional treatment paradigm of surgery, radiosurgery, and embolization is often insufficient to treat many complex AVMs, leaving many patients with significant residual disease and ultimately poor quality of life. This now raises the question of, can we add targeted oral medications to our treatment armamentarium? In order to tackle this question, we must understand the biology of AVM pathogenesis. A small subset of AVMs are familial in nature and caused by well-researched germline mutations that have since been targeted with various commercially available drugs shown here. However, 95% of AVMs are sporadic in nature. In fact, in 2017, our lab found that an overwhelming majority of sporadic AVMs are caused by activating KRAS mutations in nidal endothelial cells. The KRAS pathway is well studied and is involved in cell proliferation, migration, angiogenesis, and vascular remodeling. Its activation causes downstream ERK signaling in the wall of the nidus, increased VEGF and Notch signaling, and enhanced cell migratory behavior. These deleterious downstream effects were reversed with in vitro inhibition of a downstream effector in the KRAS pathway called MEK. And we see that here. Since then, we now have an ample body of knowledge confirming the role of activating KRAS mutations as the driver in the molecular biology of sporadic AVMs, and various studies showing that MEK inhibition reverses these aberrant activities in vitro. The next logical question is then, can MEK inhibition be used in vivo for reversal of AVM pathogenesis? Trametinib is a commercially available MEK1 and 2 inhibitor by the company Novartis that is approved for various KRAS-positive oncological states, including melanoma and non-small cell lung cancer. Given the common KRAS molecular pathway, trametinib was applied off-label to 2 pediatric patients with extracranial AVMs in the past couple of years, including a patient with metameric Cobb syndrome. These patients did not benefit from other oral therapies like sirolimus shown here, but within just 6 months of daily oral trametinib use, they showed a significant reduction in the size as well as the deformity of the lesion, as well as a significant reduction in the blood flow to the lesion with no serious adverse events. With this isolated novel pediatric experience, we decided to offer trametinib to our patient with a palliative facial AVM under compassionate use. Our patient is a 56-year-old woman in the performing arts who had a significant enlargement of her right facial AVM, as you can see between A and B, despite multiple targeted embolization attempts. This lesion was too complex to be amenable for surgery and would pose significant risk to her facial nerve, which the patient would not tolerate. Over a decade, as you see between B and C, the lesion grew even further, and at this point, unfortunately, no further treatments were amenable. In light of our recent knowledge of AVM biology and the preliminary success with trametinib, the patient opted to proceed with daily oral trametinib at 2 milligrams dose under compassionate use. As you can see, within just 6 months between C and D, there is significant reduction in the size, deformity, and you can see here even reduction in the redness of her lesion cosmetically. The patient reported improvements in her tinnitus, her hearing, as well as her pain. Radiologically, there's also a reduction in the size as well as the vascular proliferation. She had few minor side effects that were conservatively treated with no serious adverse events. These positive effects were sustained after 1 year of trametinib use. She's now being considered for other possible conventional treatments, which is quite exciting. Given our remarkable preliminary success and high volume of patients with severe palliative AVMs, we have gained approval for more patients to receive trametinib under compassionate use. We have recently employed a novel mechanism of sampling the plasma from the efferent vein of the AVM and testing the cell-free DNA for targeted KRAS mutations. This is similar to what is called a liquid biopsy. We know that the KRAS is not positive in the peripheral venous sample since it is not detected at high enough abundances. However, when we see the efferent vein samples, we see positive droplets in the KRAS mutation compared to wild type controls. This patient is now going to receive trametinib given their positive KRAS mutation. And we are planning to validate this novel liquid biopsy method in the near future. At this time, we feel poised to embark on a prospective cohort study and pilot trial of trametinib for patients with AVMs. The implications of this drug could open the door for novel targeted therapeutics in this complicated disease. We anticipate the administration of trametinib will be well tolerated with few to no serious adverse events, as is seen in the pediatric as well as our own experience, and that the administration of trametinib will confer a positive effect on the patient's symptomatology as well as the AVM size and angio architecture. At this point in time, I would like to thank my supervisor, Dr. Ivan Radovanovic, as well as my co-supervisor, Dr. Vitor Pereira, our colleagues, Dr. Warren Mason from Princess Margaret Hospital, who administers the trametinib to our patients, Dr. Joanna Shafsma, our vascular neurologist with expertise in clinical trial work, as well as our lab members, including Sandra Fatiska, and partners at Novartis and SickKids Genomics Core Lab for support with this project. I thank you for your attention, and at this point in time, I'm happy to answer any questions. Thank you.
My name is Ying. I'm a neurosurgery resident at the University of Toronto, Canada. Thank you for the opportunity to talk about my research on therapeutic focused ultrasound. I have no disclosures for this presentation. I work with a group at Sunnybrook Hospital in Toronto, led by Dr. Lipsman. He's a staff neurosurgeon and scientist in focused ultrasound. We also work with collaborators who are pioneers in ultrasound and functional neurosurgery, Dr. Isabel Albert and Dr. Clerval Hinnanen, who have pioneered a lot of this work in the preclinical space in focused ultrasound. And Dr. Kulman Hamani has also guided a lot of our projects in functional applications. So there are several advantages to using focused ultrasound in clinical applications. It can be non-invasively applied and is relatively safe, cheap, and versatile to use. Ultrasound had several biological effects on tissue depending on the acoustic pressure and frequency applied, including the use of it for surgery, for thermal ablation, for neuromodulation, for blood-brain barrier opening, and imaging. Over here is a picture of neurosurgeons with use of ultrasound decades ago in applying to the brain. One of the problems with delivering ultrasound to the brain is the inability to penetrate bone, which encompasses the brain. But since the development of image guidance and acoustic correction, engineers and scientists have been able to deliver ultrasound accurately into the brain through the intact skull, which has led to a significant rise in the number of clinical applications and research involving focused ultrasound for neurological diseases. On the right are some images of the clinical devices that are currently under investigation. This is the Exablade device made by Insight Tech. It's a helmet lined with thousands of ultrasound transducers, and this is a transcranial device that focuses the ultrasound in discrete spots in the brain, and it's also coupled to an MRI for image guidance. This is a SonoCloud device made by Carthera. This device is a transducer that's implanted past the bone such that it would allow direct penetration of ultrasound into the brain. And other devices have been looked into as well that combines with existing neuronavigation systems. So again, there are different applications of focused ultrasound that have been investigated, thermal ablation being probably the most well-established method of using therapeutic focused ultrasound. The blood-brain barrier disruption uses lower intensity ultrasound with combination of microbubbles to open the blood-brain barrier and allow drug delivery into the brain. And neuromodulation also uses lower intensity and frequency ultrasound to change the neuroactivity in select spots transcranially. So my research has focused more on the disruption of the blood-brain barrier for drug delivery. Specifically, the blood-brain barrier, it prevents molecules from passing into the brain, and this prevents a large therapeutic challenge for patients and is a pervasive problem for drug delivery, drug development for neurological disorders. The importance of allowing greater penetration of advanced therapies into the brain is not only dosing and reducing cost, but also reducing off-target effects that might be important for the higher doses that are required to penetrate the brain without any addition of focused ultrasound. So how does focused ultrasound induce blood-brain barrier opening? It does so by oscillating microbubbles that are injected into the vessels at the same time. These bubbles, they oscillate at very high frequencies and basically massages the blood-brain barrier and temporarily disrupts the barrier. The advantages of this technique is that it is non-invasive. It can be image guided using different devices, and is very specific in terms of the targeting. And furthermore, it doesn't require any further modifications of the drug of interest for delivery. So this technique has been tested in multiple animal models. Here's an example of the testing in a primate model where gadolinium is injected to demonstrate increased permeability of the blood-brain barrier to gadolinium in these different spots that were sonicated. And the extent of blood-brain barrier opening can be controlled by various parameters, such as the microbubble dose, the ultrasound dose, as well as the intrinsic tissue properties, which is something that we cannot change, but it can affect the quality of blood-brain barrier disruption. Our initial studies to investigate the safety and feasibility of MR-guided focused ultrasound using the Exablade device were done in patients with Alzheimer's and patients with high-grade gliomas. We used this transcranial device to show that we can indeed increase the permeability susceptibility to gadolinium in discrete areas of the brain, in the right frontal lobe, in the area around the tumor in patients with brain tumors. And 1 day after the study, the barrier is recovered, demonstrating that this is a transient process performed by focused ultrasound. All patients tolerated the procedure well without any serious adverse events, and these data have successfully led us to perform more studies in patients with other neurodegenerative disorders such as amyotrophic lateral sclerosis. In this study, we combined focused ultrasound with functional imaging to further demonstrate the specificity of the targeting, where we can open an area in the primary motor cortex in a very discrete region in the brain of these patients. The next question was whether disrupting the blood-brain barrier has any effect on the drug concentration. And for this study, we were investigating whether trastuzumab, which is an antibody that's about 140 kilodalton, can be significantly enhanced in the area where focused ultrasound is applied. So we radio-labeled trastuzumab with indium-111, which can be shown to light up in SPECT studies. And here is a patient who had the scan without focused ultrasound. And after focused ultrasound, we see that these areas that were targeted, and this is the heat map that demonstrates the ultrasound delivery, we can see a significant increase in the drug concentration levels. And for due to further quantitative analysis, we can target different regions in the brain, including areas in the cerebellum close to the brainstem, other areas of the cerebellum, and occipital lobe. And we show that focused ultrasound delivery is not really only limited to the center part of the brain, but can be delivered anywhere in the brain and can have significantly large coverage, such it could be practically applied to patients with brain tumors. So the future directions along this line of investigations demonstrate the efficacy of our technique on clinically relevant outcomes to achieve regulatory approval. An area of interest for me is the application of gene therapy using focused ultrasound and the effect of focused ultrasound on immunomodulation in cancer patients. So the future of the device include making more efficient and automated devices that can deliver ultrasound, acoustic monitoring to replace MR image-guided ultrasound, such again to improve the efficiency and tolerability of the procedure, and patient-specific arrays that will one day populate the clinics on an outpatient basis. So again, I'd like to acknowledge my mentors and collaborators. Thank you.
Hello everyone, my name is YN. Thank you for this opportunity for me to present my audit on time to surgery and patient selection criteria for decompressive cranectomy in ischemic middle cerebral artery stroke. This is the outline of my presentation today, starting with introduction, followed by objectives, methodology, results and discussion, and ending with the conclusion. Massive middle cerebral artery infarction, also known as malignant MCA stroke, can be life-threatening due to expanding cerebral edema and increasing intracranial pressure, which can lead to brain herniation and death. Decompressive cranectomy is a surgical approach where part of the cranium is removed temporarily to relieve the raised intracranial pressure within. Studies show that early decompressive cranectomy significantly increases the survival rate, but unfortunately, the patients have higher probability of living with moderate severe disability. Thus, careful patient selection for the procedure is crucial to identify those who may actually benefit from it. This audit aims to evaluate two components. First, time to surgery, and second, patient selection criteria for decompressive cranectomy, comparing the performance of Hospital Sultanah Aminah Johor Bahru HSA-JB to the standard, which is the NICE guidelines. The NICE guidelines recommends decompressive cranectomy to be performed within 48 hours from symptom onset and in patients who satisfy all these three criteria. First, stroke severity, measured by NIHSS score more than 15. Second, decreased consciousness, with score of 1 or more on NIHSS item 1A. Third, evidence of infarction involving at least 50% of the MCA territory on the CT scan. And depending on the results and outcomes, we aim to identify areas for improvement. In this audit, 42 patients were identified from the surgical list. Out of this, 38 patients met the inclusion criteria of having decompressive cranectomy in 2017 to 2019 for ischemic MCA stroke. Patients were excluded if they had hemorrhagic stroke, stroke involving non-MCA territories, or presence of other coexisting neurosurgical conditions. Data was obtained from the medical records. Unfortunately, only 16 patients had complete documentation of time to surgery, and only 11 patients had data on patient selection criteria. Time to surgery is defined as time of symptom onset to time of surgery performed. Functional outcomes within 18 months post-operation were also analyzed in correlation with time to surgery. Modified Rankin scale was used, where scores of 0 to 3 represent favorable outcomes and scores of 4 to 6 as unfavorable outcomes. As for patient selection criteria, the three criteria listed in the NICE guidelines were used. However, due to NIHSS scoring system not being routinely applied in HSA-JB patient assessment, Glasgow Coma Scale of 8 or less was used in place of total NIHSS score of more than 15 for stroke severity. All data were analyzed using Microsoft Excel. In terms of time to surgery, 75% of the patients underwent decompressive cranectomy within 48 hours. Among this, only 25% achieved good functional outcomes post-surgery. Majority had poor functional outcomes, and there was one patient with no related data. As for those who had surgery after 48 hours, we can see that no patients achieved favorable post-surgical outcomes. 75% had poor functional outcomes, and there was one patient with no related data. Therefore, majority of ischemic MCA stroke patients in HSA-JB underwent decompressive cranectomy within 48 hours, in line with the NICE guidelines. Despite a large number of poor functional outcomes, decompressive cranectomy within 48 hours demonstrated general increased likelihood of survival and relatively positive functional outcomes compared to the other group, thus reflecting current literature evidence. However, time to surgery should not be the sole limiting factor in decisions for decompressive cranectomy when the clinical context is evaluated to be favorable. On the other hand, for patient selection criteria, only a minority of 18.2% met all three patient selection criteria of stroke severity, decreased consciousness, and radiographical evidence. 54.5% satisfied 2 out of 3 criteria, where among this 16.7% missed radiographical evidence and 83.3% missed stroke severity criteria. Lastly, 27.3% only satisfied 1 out of 3 criteria, where all of them missed the criteria of stroke severity and decreased consciousness. Therefore, majority of MCA stroke patients selected for decompressive craniectomy in HSA-JB did not satisfy all three criteria listed by NICE guidelines. Stroke severity was the most commonly missed criteria, followed by consciousness level, and lastly, radiographical evidence. To sum it up, time to surgery in HSA-JB was in line with NICE guidelines, while patient selection criteria was not. However, one major limiting factor of this audit is the lack of documented data, which comprised of more than half of the original sample size, thus introducing bias. Recommended improvements include more detailed patient assessment on admission with proper documentation to keep up with the current practice of time to surgery and to outline clear patient selection criteria as local hospital guidance. Implementing change and re-auditing in 5 years will be very useful to ascertain change. These are my references, and thank you very much. I'm happy to take any questions.
Good morning and good day to the audience and the participants. Thank you for giving me the opportunity to discuss a case today. My name is Zaitun Zakaria. I'm a neurosurgical trainee from the Department of Neurosurgery, Hospital Sultanah Aminah, Johor Bahru. The title for today is an extra-axial cerebellopontine angle medulloblastoma mimicking a meningioma. Medulloblastoma is histologically considered a CNS WHO grade 4. 70% of the cases occurred in children under the age of 10. In adult, medulloblastoma is rare, which accounts for less than 1% and commonly occurs in the cerebellar hemispheres. According to 2021 CNS WHO classification, medulloblastoma are divided into molecularly defined or histologically defined. If we use the histologically defined, then they are divided into 4 groups, which are classic, desmoplastic or nodular, medulloblastoma with extensive nodularity, or large cell anaplastic. So today I'm going to discuss a case of a 24-year-old male who presented to our department with a 1-year history of a generalized headache. As the pain score increases, he started having non-projectile vomiting. Soon the dizziness developed, causing him to unable to do his daily activities. 6 weeks prior to presentation, he developed a double vision on far distance. He then preferred to lie down rather than doing his activities as his walking became unsteady. However, he denied any history of a seizure or any history of fall. On examination, the systemic examination was unremarkable. Neurological examination for the eye exam revealed a visual field defect with finger counting on the right side. He also had bilateral papillary edema. On extraocular eye examination, there is a horizontal nystagmus with a fast face to the right side. Other positive findings of the cranial nerve include a right facial asymmetry with no sparing of the forehead muscles. He also had a right sensory neuronal hearing deficit. The motor and sensory examination was normal. On the cerebellar examination, there is a horizontal nystagmus with a fast face to the right side. There is also positive finding on the right side for the pass pointing, dysdiadochokinesia, and heel to shin test. The gait assessment was unable to perform at that time as he was very dizzy. This is a non-contrast CT brain on presentation. The CT brain revealed a right CP angle lesion causing an obstructive hydrocephalus and displacement of the 4th ventricle to the left side. The patient was then subjected for a right frontal ventriculoperitoneal shunt. After he recovered from the surgery, he then had an MRI brain with contrast. On the axial view T1 weighted MRI scan, there is a right CP angle lesion measuring about 4.3 times 4 times 3 cm. The lesion itself is iso-intense on the T1 weighted It is hyperintense on T2 weighted, and on the MRI brain with contrast on the axial view, it is heterogeneous enhancement post-gadolinium. The tumor itself seems to arise from the tentorial age. This causes a displacement of the fourth ventricle to the left side and displacement of the right cerebellar hemisphere. The prior CT brain on the bone window, which was not shown in this presentation, showed no widening of the right internal acoustic meatus. The radiological report was consistent with a right CP angle meningioma. The patient then underwent a right suboccipital retrosigmoid craniotomy. For the orientation, this is the right transverse sinus, and this is the right sigmoid sinus. Upon the dura opening, the tumor is visualized at the edge of the transverse sigmoid junction. The tumor itself was soft to firm in consistency with an area of a fibrous tissue. The plane between the tumor and the brainstem was identified and protected prior to the piecemeal removal of the tumor, starting from a central debulking. The tumor itself seems to adhere to the tentorial edge. This is the intraoperative during the central debulking. After the central debulking, we proceed with the piecemeal removal of the tumor. The postoperative CT brain non-contrast reveal a postoperative changes, and the fourth ventricle has opened up. The vessel cistern is open. The patient was then discharged home a few days later. The histopathological finding: for the H&E staining, there is an evidence of a small round blue cell that is arranged in a pale nodules at the variable sizes. The tumor cell itself has a monomorphic small hyperchromatic nuclei. The cell itself are embedded in the fibrillary matrix as shown in the arrow. There is a dominant population of undifferentiated cells with a high nuclear to cytoplasmic ratio and mitotic figures activities. The tumor itself are negative for the EMA, which are usually stained for meningioma, CD45, AE13, S100, which is usually stained for schwannoma, but it can also be positive for either tumors, CD99, and also SALL4 stains. For the reticulin staining, there is a dense intercellular reticulin fiber network. The GFAP showed a focal positivity. The INI1 showed an intact or retained nuclear expression. The Ki67 is high, which is about 40 to 50%. The histopathological diagnosis was inconsistent with a desmoplastic or nodular medulloblastoma. Briefly, for the medulloblastoma, It is a favorable outcome as compared to other histologically defined. Desmoplastic nodular medulloblastoma is estimated to occur for 20%. It tends to arise laterally in the cerebellar hemisphere. The aim of the treatment is for the maximum safe surgical resection combined with either adjuvant radio and/or chemotherapy. The CP angle medulloblastoma has been reported in literature before. It tends to arise as an extra-axial masses, which raises a preoperative radiological diagnosis. The differential diagnosis can be either a meningioma or a schwannoma. The age of the presentation also varies, as we know that medulloblastoma tend to arise in children. For our cases, the patient is a 24-year-old. In pediatrics case, pediatrics patient with CP angle medulloblastoma had worse outcome as compared to adult patient. Thank you very much for your time.
From the University of Hong Kong, I would like to share a research on the clinical and perfusion results of surgical revascularization for monomer angiopathy in 86 affected cerebral hemispheres to demonstrate the feasibility of a bypass first paradigm. So for the background, as you all know, monomer disease is a progressive steno-occlusive vasculopathy of the supraclinoid, ICAs, and their proximal branches. The potential advantages of a direct or combined bypass can be harvested only if it is not outweighed by the perioperative morbidity, like perioperative stroke. Direct bypasses for the pediatric subgroup has long been less utilized because of the smaller vessel calibers, and also the pediatric patients have inherently more robust angioplasticity. The objectives of the study is to evaluate the clinical and perfusion imaging outcomes of revascularization for monomer disease or syndrome. And we would dichotomize the patient into direct or combined revascularization versus isolated synangiosis. We would like to evaluate the feasibility of a liberal direct bypass first paradigm in both the adult and pediatric cohorts. So this is a retrospective cohort study, and we included patients with monomer disease or syndrome by established criteria, and the study period, the recruited patients had the operations between the year 2000 and 2020, and we evaluated their clinical and angiographical follow-up. The indication of treatment were ischemic symptoms with corresponding cerebral hyperperfusion on hemodynamic studies, and for hemorrhagic monomer patients, they would have reasonable neurological recovery, and also asymptomatic patients with radiological hypoperfusion after discussion with the patient about the risk and the patient fitness. The outcome measures were the cumulative transient ischemic attacks probability, the functional outcome by modified Rankin scale, but the bypass patency, and also the CT and perfusion scans in terms of the cerebrovascular reserve capacity. The inadequate CVRC was defined as less than 10% increase in regional cerebral flow after acetazolamide. So for the general results, there were 53 patients and 86 hemispheres, including 39 adults and 14 pediatric patients. We can see that most of the patients had modified Rankin of 0 to 2 before operation, and most of them had monomer disease, and only a few of them had monomer syndrome. The general outcome for our cohort was quite optimistic in terms of the radiological outcome. In terms of the perfusion, adequate CVRC was achieved in around 3 out of 4 patients, and there was a high graft patency rate, And good clinical outcome defined as modified ranking of less than or equal to 1 was achieved in more than 80% of the patients. So in terms of the major outcomes, patient outcomes associated with the type of surgery, the restoration of adequate cerebrovascular reserve capacity was significantly greater in the direct or combined group by a significant p-value of 0.015. Other outcomes in terms of perioperative stroke, delayed stroke, and overall modified ranking of less than or equal to 1 did not demonstrate a significant p-value. However, if you compare the preoperative and postoperative modified ranking for both the indirect and the direct surgical cohorts, each of the patients belonging to each cohort had significant improvement in their functional outcome after surgery. And so for the Kaplan-Meier curve analyzing the proportion of patients free from TIA, direct or combined surgery had a significantly greater probability of being TIA-free at 5 years comparing to the indirect isolated synangiosis subgroup. And by log-rank test, the p-value was 0.038, again a significant result. And this is a table summarizing the result from a stepwise univariate and multivariate logistic regression analysis. And I would like to highlight the result from the column on the right, demonstrating that adequate cerebrovascular reserve for the factors associated with adequate cerebrovascular reserve with internal control, the direct or combined operation had a was a significant predictor for this good outcome in logistic regression analysis. We then performed the subgroup analysis on the pediatric cohort, which included 14 patients with 22 revascularized hemispheres, with direct bypasses done in almost half of the hemispheres. And 80% of these subgroup of patients achieved a good clinical outcome defined as modified ranking of less than or equal to 1, and also restored cerebrovascular reserve capacity with internal control was more commonly achieved in direct or combined surgery, although not reaching statistical significance due to the small sample size. So for the discussion, we demonstrated that direct combined surgeries were superior in restoring CVRC post-acetazolamide with high cumulative probability of TI freedom. Crucially, there was no excessive perioperative morbidity in the pediatric cohorts. CVRC has been used as an objective criterion to reflect the ability of the brain to maintain adequate cerebral blood flow in decreased perfusion pressure, and it has been demonstrated to correlate with stroke risk. Direct or combined surgical modality that was demonstrated to be superior in CVRC achievement by internal control via logistic regression analysis. And this echoes the previous study by Sabanka in 2011, where they performed a one-step bilateral revascularization with the clinically leading hemisphere undergoing a combined bypass and the other hemisphere with isolated synangiosis. So with this form of internal control, only the combined surgery led to significant improvement in the CVRC. In the pediatric group, they were traditionally thought to harbor greater angioplasticity, and hence direct bypasses was less commonly performed and also limited by the vessel caliber. We chose patients with their donor and recipient vessels greater than 1.5 millimeters, and we were able to demonstrate a numerically higher achievement of adequate CVRC in these patients. There were comparable perioperative and delayed stroke risks as demonstrated by these figures. So in conclusion, direct combined revascularization for Moyamoya disease syndrome was proven to be superior in TIA freedom rates and also adequate CVRC achievement. Direct bypasses in children were demonstrated to be safe, and our evidence substantiates the feasibility and safety of a liberal direct bypass first strategy in both the adult and pediatric cohorts. Thank you.
Assalamu alaikum warahmatullah and a good day to everyone. My name is Dr. Aiman Ashraf, a medical officer in neurosurgery in Hospital Sultanah Aminah, Johor Bahru, Malaysia. I'll be presenting on my case report entitled Adult Medulloblastoma Mimicking Tentorial Meningioma. Medulloblastomas are rare intraaxial primary brain tumors in the adult population as compared to the pediatrics. The incidence in Malaysia is about 1% of all adult primary brain tumors over the past 20 years, and they are more commonly located in the cerebellar hemispheres in the adults. However, there has been an increasing number of case reports on medulloblastomas mimicking other extraaxial tumors, for example, having dura tails of imaging, in locations such as the cerebellar hemispheres, the cerebellar pontine angles, and extraaxial midline tentorial lesions. Here, I present one such case with its intraoperative findings. A 22-year-old Sarawakian female with no previous medical illness presented with a 7-month history of progressive occipital headache associated with vomiting with a tendency to fall to the left when walking. Neurological examination was significant for papilloedema on fundoscopy with intact lower cranial nerve examination, a tendon gap with a left-sided instability in absence of left-sided weakness, and negative cerebellar signs. Initial CT brain showed a midline hypertense cerebellar lesion with obstructive hydrocephalus. Here, the MRI imaging shows a midline infratentorial mass appearing slightly hypointense on T1, slight hyperintense on T2 with perilesional edema. There was heterogeneous contrast enhancement with a broad base along the left cerebellar tentorium with a dura tail and CSF cleft. The fourth ventricle, pictured here, appears distant from the lesion and was compressed and distorted. The imaging features were suggestive of an extraaxial primary brain lesion with the initial differential diagnosis of a tentorial meningioma. We subjected the patient for suboccipital craniotomy and tumor excision via the infratentorial supracerebellar approach. Here in this image, the retractor blade, visualized here, is holding the transverse sinus superiorly, and the suboccipital surface of the left cerebellum is in full view. We noted during surgery that the tumor had two different parts, of which can be seen on this image. The first part of the tumor, at the end of this retractor plate here, was noted to be solid whitish grayish in color, soft in consistency, and was arising from the left tentorium with a clear brain tumor interface over the anterior and lateral portions, but poor brain tumor interface over the medial and inferior portions of the tumor. The second part of the tumor, which is visualized here at the tip of the suction head, had a plaque-like appearance, hard in consistency over the medial and middle aspect of the tumor, densely adherent to the tumor, with no clear margin between the tumor and the cerebellum. This part of tumor was extremely adherent to the tentorial midline. The tumor was overall highly vascular with multiple arterial feeders arising from the tentorium. Histology showed dense packed hyperchromatic cells surrounding pale reticulin poor nodular areas containing tumor cells exhibiting variable neurocytic maturation. They stain diffuse positive for synaptophysin and CD56, but negative for GFAP, EMA, and S100, and they had a high Ki67 index. The histological features were consistent with a desmoplastic nodular type medulloblastoma, WHO grade 4. Molecular assessment, however, was unavailable. According to the latest WHO 2021 classification of tumors, medulloblastoma has 4 principal molecular groups: the SHH, WNT, Group 3 and Group 4 molecular groups with multiple new subgroups under each principal molecular group. These molecular groups and subgroups were found to be associated with specific radiological and morphological patterns. For example, the desmoplastic nodular type is associated with the SHH molecular group, generally in the cerebellar hemispheres rather than in the midline, more frequent in adults and infants as compared to children, and interestingly, more commonly associated with extraaxial tumors as compared to other molecular groups. For our patient, the tumor imaging of our patient showed an extraaxial midline tumor with a dura tail and broad base along the infratentorial border. Surgery, however, noted that there were extraaxial and intraaxial portions of the tumor, and the diagnosis based on histology was medulloblastoma consistent of a desmoplastic nodular variant. The broad-based appearance of the tumor and the enhancing dura tail was likely due to a large surface area of infiltration of the tumor to the cerebellar tentorium, causing the tumor to be extremely adherent, as was found during surgery. Detweiler et al. Once proposed that the dura tail sign in cerebellar medulloblastomas are probably due to tumor vicinity, angiogenesis, and inflammation, and our intraoperative findings most likely confirm to this proposal. A similar case to ours was previously reported by Doan et al., of which they presented the first reported case of SHH medulloblastoma that is not located in the cerebellar hemisphere. Treatment, however, follows generally the same principle, aims for maximal safe surgical resection, followed by radiation therapy with or without adjuvant chemotherapy. Surgery alone leads to high recurrence on poor survival in adult medulloblastoma, but with radiation therapy, 5-year disease control rate is reported to be as high as 70 to 90%. Addition of chemotherapy to the treatment regime can also give a 5-year-old survival of around 60%. There is, however, no consensus on the optimal chemotherapy regime, and this remains open for study. In conclusion, although rare, medulloblastoma should be considered as a differential diagnosis in posterior fossa dura-based tumors in young adults, as there has been an increasing number of cases reported of such incidents. Treatment should include microsurgical resection, followed by histomolecular diagnosis and radiation therapy to improve outcome. Many thanks. These are my references. Thank you.
Good morning and good day to the participants and the audience. Thank you for giving me the opportunity to discuss a case today. My name is Aitun Zakaria. I'm a neurosurgical trainee from the Department of Neurosurgery, Hospital Sultanah Aminah, Johor Bahru. The title for today is The Ventriculoperitoneal Shunt, the Shunt Tract. Ventriculoperitoneal shunt is a common neurosurgical procedure for CSF diversion. The procedure itself involves a parieto-occipital or the precoronal frontal borehole for ventricular catheter, an abdominal incision for implantation of the distal catheter into the peritoneal cavity, and a subcutaneous tunneling of the peritoneal catheter. Despite being a common procedure, complications remain a significant source of morbidity and mortality. So today I'm going to discuss a case of a 72-year-old male with a known history of a left CP angle schwannoma. He initially presented at that time with the raised ICP symptoms. A non-contrast CT brain revealed an obstructive hydrocephalus. Hence, he underwent a right frontal ventriculoperitoneal shunt. After that, he underwent a surgical debulking of the schwannoma. He recovered well from these 2 surgeries and been fully independent since then. 10 months after the VP shunt insertion, he presented to us with a 5-day history of itchiness over the right anterior chest wall. He has been scratching those areas and the area become red. On the day of presentation, he noticed a white tube sticking out from the wound site. Hence, he pulled out the tube himself. When he arrived to us, we performed an X-ray of the shunt series. On the left side is a skull X-ray showing a continuity of the proximal catheter with the distal catheter. The X-ray on the middle revealed the shunt tubing is still in situ. However, the X-ray on the right side, which is an abdominal X-ray, did not show any evidence of a shunt tube. A non-contrast CT print was performed showing the proximal catheter is in situ, which is within the right frontal horn of the lateral ventricle. This is the video when he first arrived to us, showing an exposed distal catheter. There is still CSF flowing from the tube, suggestive that the shunt is still functioning. The photo on the left side revealed the shunt tubing sticking out from the wound area, and the photo on the right side revealed the redness and erythematous area where the shunt was exposed. On the same day, the patient was brought to the operating table. After the wound area was cleaned, we can appreciate about 5 centimeter lacerated wound area. This area was then primarily opposed. The photo on the right side reveal the scar that was previously used for the insertion of the frontal shunt. The scar itself was reopened, and after the CSF sample was taken, the shunt tube was then removed. The patient was kept in the hospital for a few days for the antibiotic treatment and was then discharged home. In summary, we presented a case of a 72-year-old male with an exposed VP shunt at the right anterior chest wall. We believe that education to the patients and family members are important, not only for the cranial and the abdominal area, but also along the shunt tract. For the operative procedure, the tunneling should not occur too close to the skin to minimize the risk of shunt erosion or skin penetration. In summary, education to the patients and carer about the shunt care is crucial. Extra care is needed along the peritoneal catheter tract, and we should advise the patients to come to the hospital early if there is a clinical evidence of a shunt malfunction or shunt infection. Thank you for your time.
Good morning, senior and colleague. I'm Jenny Yuan from Princess Margaret Hospital from Hong Kong. Today, I'm going to share with you the early outcome after transpenoidal surgery for management of hormonal secreting pituitary adenoma in our center. Transpenoidal surgery has been used to treat hormonal secreting pituitary adenoma as a polytinoma. In this study, we will review our surgical outcome. Our primary outcome focuses on biochemical remission rate, and secondary outcome will focus on complications like CSF leak and hypopituitarism. This is a retrospective cohort study reviewing patients undergo transpenoidal surgery for functional pituitary adenoma in our center from 2016 to 2021. Over this 5 years, 100 transpenoidal surgery were performed for pituitary adenoma. 21 surgery were performed for hormonal secreting pituitary adenoma. This includes 19 patients, while 2 of them have repeated operation. 13 of them are female. The age range from 34 to 67 with mean of 50. Post-op follow-up duration range from 3 to 58 months with mean of 28 months. Majority of them are having acromegaly. This is followed by Cushing disease. 1 has TSH secreting tumor. To our surprise, a few patients with polytinoma also require surgery. We will perform subgroup analysis for different types of tumor. This includes a tumor characteristic followed by primary outcome and secondary outcome. There are 11 patients with acromegaly. 10 of them have macroadenoma. 9 were located in natural site of gland, and 7 of them have cavernous sinus involvement. None of them have previous radiotherapy or surgery. We will define biochemical remission according to the 11 acromegaly consensus conference in 2017. This will normalize IGF-1 according to ACNS. 8 patients achieve biochemical remission by surgery alone within 7 months. 2 patients has reoperation for residual disease. However, they have persistent high IGF-1 after reop. 3 patients need to take dopamine agonists. All of them have IGF-1 normalized 2 months after medication. None of them require adjuvant radiotherapy. In summary, 73% of patients achieve biochemical remission with surgery alone. 100% achieve biochemical remission without radiotherapy or SRS. 1 patient has CSF leak requiring surgery. This made up 9% of lead weight, which is higher than 4% in non-functional microadenoma in our cohort. One patient has permanent DI, required DDA repeat. One patient needs regular steroid and 2 need PRN. One patient has diabetes resolved after surgery. As we reported that post-op day 1 morning growth hormone can predict biochemical outcome. So we have checked post-op day 1 morning growth hormone level in our cohort. We found that in patients cured by surgery alone, the value ranged from 0.41 to 2.5 with mean of 1.3. In patients requiring adjuvant medication for hormonal control, the value ranged from 2.4 to 9.3 with mean of 5. There is a statistical significant difference between them. We propose post-op day 1 morning growth hormone of 2.5 as empirical cutoff to predict biochemical remission. We have performed a literature review and found a case series of 214 cases in Turkey. They suggest that day 1 post-op growth hormone level less than 2.33 and larger than 50% decrease in IGF-1 level 1 month post-op prediction of cure. And we have similar finding with them in terms of growth hormone level. However, the 1 month post-op IGF-1 decreased by 50% is not applicable in our cohort. It is specific but not sensitive because among 6 patients with less than 50% decrease in IGF-1 in our cohort, half of them have biochemical remission. We will focus on Cushing disease. 1 out of 4 has microadenoma. 3 were located in natural side of brain. 2 of them have galvanized sinus involvement. 1 of them have radiotherapy 6 years before operation. None of them have previous surgery. We will define biochemical remission of Cushing disease according to the published Endocrine Society clinical practice guideline. This will take a normalized serum morning cortisol level. 3 achieve biochemical remission by surgery alone within 2 months. 2 of them require regular hydrocortisone after surgery. 1 requires adjuvant radiotherapy at 6 months post-op. He is able to off mitaroprone at 27 months post-radiotherapy. Now he is on PRN hydrocortisone supplement. In summary, 75% of patients achieve biochemical remission with surgery alone, and the remaining require radiotherapy. No patient has CSFP. 3 patients has transient DI. 1 of them have permanent DI. We must note that all of them have secondary hypothyroidism before surgery. 1 patient has diabetes resolved post-op. Here's an interesting finding. 1 of the patients suffered from pseudocytoma instead of adenoma. Pseudocytoma originates from specialized glial cell in neurohypophysis and infundibula. Cushing disease is an uncommon presentation. Maximal safe resection is treatment of choice. Recurrent is uncommon, and normal ligament transformation or cerebrospinal dissemination has been reported. 1 patient has TSH secreting pituitary adenoma. It is a microadenoma centrally located with kypher involvement without cavernous sinus involvement. She did not have radiotherapy operation before our operation. Operation was uneventful. Post-op there was residual tumor and she ran to Taiwan for proton beam therapy, 1.5 year post-op. Now it's 2 years after proton beam therapy. She is still on octreotide. TSH rebound upon trial of octreotide. We have also identified 3 patients requiring surgery for polyethyloma. They were operated because of visual deterioration due to apoplexy. 1 of them presented with apoplexy upon diagnosis. The other 2 developed apoplexy after medical treatment. Of note, the polyethylene level were as high as 100,000 upon presentation. All of them are microadenoma, measuring up to 7 centimeters. They are very extensive with cavernous sinus involvement. None of them have previous radiotherapy or surgery. All of them have improved vision after surgery. They are keep on dopamine agonists after surgery. Dopamine level are normalized in 2 patients. Operation was uneventful. 2 patients required regular hydrocortisone and thyroxine supplement. Other medication is first-line treatment. Surgery is still needed for patients with apoplexy that cause visual impairment. CSF during medical treatment for micropolyethyloma was described in literature, but in our series, such as apoplexy, During medical treatment is the more common indication for surgery of adenoma. In summary, surgery is the treatment of choice for functional pituitary adenoma. Surgery can achieve 73% biochemical remission in the acromegaly. Post-op day 1 modern growth hormone level less than 2.5 can be the biochemical cure. Pituitary may present with Cushing disease. Polyclonoma may develop apoplexy during medical treatment that may require surgery for vision preservation. Here are my references. Thank you.
So that is the end of the medical student session. Sachin, are you there?
I'm there. There was a wonderful session. I'm really happy to see so many enthusiastic medical students and residents actually presenting such a wonderful, and some of them were really difficult.
Yes, it turned out to be great. Thank you so much.
Level, even I could not understand so much.
Thank you so much for coordinating. I'm finally able to join the meeting now. So we do have some of the presenters here as panelists. If there are any questions or just any comments. Maybe we can have Professor Kato.
Are you there, Ben? You would like to ask any question too?
Yes, and congratulations to all of the speakers. So my question. Yes, hello, Professor Kato. You want to share?
Hi, hello, Mira. Thank you very much. Hi, how are you? Thank you so much. Yes, 10 medical student lectures were so excellent.
Thank you so much.
I already sent an email to you because there some construction of the paper and also the content. Everything is very nice, and also it's quite difficult to who is the winner or not. So some student is I think much better than the neurosurgeon sometimes. So I think that is part is the highlight of our Congress. I think my congratulations because of your leadership of the teach of the young neurosurgeon and also medical student is I think very expecting in the future, our future I think. I really thank you very much. So there's some judges is now considering who is the top 3 papers. Yes, thank you so much.
We will announce that. May I request all the participants who are there, the students, to just show up yourself in the video and so that we can take a picture, a screenshot maybe. Sachin, can you do that for us because I'm logged in from the phone,
I'll do that.
so I can't do that. Yeah,
if any of the presenter is in the attendees, you can just raise the hand. I can promote you to the panelist and then we can take a picture.
Yes, it will be a memorable thing for all of us.
So 1, 2, 3. Very good.
Thank you.
Try
Thank you
one
so
more.
much. Thank you. So we have all the panelists here, and I would like to thank you all on behalf of AMSRS to join us, and we look forward for you all to participate in our future events. And it's been great, and so to see so much enthusiasm from young residents, medical students even, and neurosurgeons. So on the last day of this conference, which is May 8, we will be announcing the winners of this session. So you're already going to be judged now, and then all of us have done a great job, and it's just a matter of who gets to win this session. So I'm thankful to Professor Kato. Thank you so much again for your help and cooperation, and we look forward for more future sessions like this.
Thank you. My congratulations to hear yourself. I think you are now is the mother of the 2 children.
Yes.
So wish you a very great successful. No time for sleep, I think maybe. So, but please don't give up. Please go for it. Thank you very much.
I'm trying my best.
Yes. Thank you so much.
Thank you.
Sachin, is it the time for a snap?
Yeah, I've already taken a snap.
Yeah.
Okay, one more.
Sure.
One, two, three. Perfect.
Thank you, Sachin. You can just WhatsApp me this
Thank
picture.
you. Thank you, Hira. I actually wanted to congratulate you. Look like, in the previous form, earlier pre-COVID era, after a long time, I'm seeing you on the screen and talking with you. We hope to see your active participation in the future again. Thank you very much.
My youngest one is now 9 months old, so I think I'm in good shape now.
Is he with you now or no?
No, he's sleeping. He's sleeping. It's 1 a.m. here.
Sorry for that. I think you haven't changed at all.
Thank you. Thank you. That's a compliment. Thank you so
best
much.
regards to your colleagues. Thank you very much.
Thank you, everyone. I'll just get off and I'll go to sleep now.
Yes,
Okay.
of course, please. Thank you. Thank you very much.
Thank you. Bye-bye.
Thank you.
Bye, everyone.
Bye now. Yes.
Bye.
Bye here.
So our next session is going to be the collaboration of continental YNS committees, but that will be starting after half an hour. So I think we'll take a small break, but since morning all of us we are on the computer. We'll take a small break, a tea break. We'll come back after half an hour. Till then, have a break and enjoy our promotional videos. Would that be okay, Professor Kato?
Yes, Sachin. Hello.
Yes, we'll take a small break because our next session is starting at 4:30. It is 4 o'clock now. After half an hour, we'll start. So we'll take a small break and then come back.
Yes. Okay. So maybe lunchtime for you, I think.
Yes.
Thank you. Thanks so much.
Thank you.
So far, nice. Thank you.
I would like to thank the organizer at ACNS for giving me this opportunity. I'll
Hello, Ignatius. Ben, are you there, Ben?
Yes, can you see it now?
Yes.
Hello, everyone. Good morning and good evening. I'm honored to be a speaker in this grand meeting. I would like to learning, sharing, and collaboration with this international big family. My topic is where should I start? How to develop research questions. Firstly, let me introduce myself. I'm MD and PhD graduate from Shanghai Jiao Tong University School of Medicine. I was a general surgeon before I worked as a neurosurgeon. My experience include pediatric and adult neurosurgery. When I was working for postdoctor, my research direction is targeted and immunotherapy for brain tumor. I was a visitor scholar in City of Hope. I achieved the GCSRT program certification in Harvard Medical School. In this program, I learned how to do clinical research and trial. As a member of SNO and IACI, I fortunately attended many international workshops and conferences. In those fantastic meetings, I met many world-class masters. What's the clinical research? It refers to all research carried on human beings, healthy or sick people. It focuses on improving knowledge of disease, developing diagnostic methods and a new treatment or medical device to ensure better patient care. It is very framed and respects a precious study protocol and is only realized under certain conditions. It must have the goal of increasing medical knowledge, be carried on by competent persons, take all necessary measures to protect those who lend themselves to research, obtain regulatory approvals, and take all the necessary legal and ethical steps, and collect the consents of those involved in research. In a bigger concept, clinical research including clinical trial, observation studies, case report, quality improvement, and improving workflow. There are two main types of clinical studies, observation study and interventional study, as also it calls as clinical trials. Observation studies include a cohort study and epidemiology. They improve the knowledge of the disease and its evolution over time. They are carried out within the framework of the follow-up of the patients in the reference centers. They also contain the natural history studies. Interventional studies provide scientific evidence of the efficacy and safety of a new drug, or a new care device, or a new management in the context of illness. This is a necessary step for a new molecule to become a drug or a medical device to be marketed. Before we start everything, we should ask ourselves, what do I want to achieve in clinical research? Just like everyone has a dream and own life pathway. So we must consider where do we want to be in the future 5 or 10 years. We must identify our own niche, such as surgical approach, or new technique in surgical, or improved surgical device, or to be a specialist on treatment of GBM, or melanoma, or other tumor type. We should ask ourselves, do I like to do study on diagnostic process, biomarker, or correlative markers, or if I like to develop a treatment modulated, such as immunotherapy or targeted therapies. All of research are initial from unreserved question. Researchers always work around with exploring the mechanism, cause of disease, better therapy, better survival outcomes. How can we fund the research question? Listening is very vital. Collect information from everywhere. The research question came from your daily life or daily work. If you have brain tumor board in your hospital, pay attention what does it discuss more, such as pseudo progressing or radiation strategy, therapy for unknown brain tumor type. Or maybe you can pay attention on the question from referring colleagues, trainees, or staffers. Then we could thinking about what kind of workflow could be optimization. Even the question from patients is also good, such as question, will my disease pass on my children? When we have the first step with questions, the second step is getting into the door. We need to strong network with all kinds of resources. Identify a mentor who has experience for running clinical trials, attending the international meetings, such like this grand meeting. Contact with the industry is also a good approach to be a PI in clinical research, clinical trial, or getting support in IRT project. Another point is access to bigger database, tissue bank, and epidemiology database. The third step is identify your research team. This could be anyone. If you are working in hospital, your colleagues, nurse, research staff all can build a team with you. If you do not have a team, you can set up one. Share the resource together and hire your own team by funding. Finally, analyze the important resource that we need. It including research team, time, and finance. As a young neurosurgeon, we are really very busy, but we must make a decision and set aside some time to do the research. Make a schedule and stick it. The budget usually including lab assays, imaging studies, and pay team members, which could from national or local government grants or industry support and donation and so on. Before we started the project, we needed to do literature search, think about the study design, meet a statistician before the beginning, or at least early stage. Discuss with your peers or mentors what's the best strategy to investigate the research question. Of course, publications are very key, so please plan the paper early on. We often can already draft the introduction, methods, discussion section. Do not wait to the end of the project finish. At last but not least, clarify authorship based on individual devotion in this research work. Thank you for your time. I'm happy to answer any question.
So, Sachin, can you share? It's time for your talk.
So Ben, what is this time? Q&A time?
Sorry, can you repeat again, Professor?
Yeah,
Yeah, can you hear me, Ben?
Yes, I can hear you, Sachin.
Yes. So I welcome you all. Thank you very much, Dr. Chen, for that wonderful presentation. first of all, and then I welcome you all for this special session called Collaboration of Continental YNS Committees. Now we've got different continents, and different continents got different neurosurgical societies, and these neurosurgical societies have got their subcommittees, YNS subcommittees. So we thought it'll be a great idea if all of us, all the committees come together and discuss their issues. Basically, all of us, we've got the same issues, and how we can discuss together and maybe come up with some more better understanding of how to go ahead. So for that, I welcome Dr. Ignatius, who's the chair of WFNS YNS, and Dr. Ernest, who's the vice chair of WFNS YNS, and Dr. Angelos, who's not yet joined, but we hope he'll join soon, who's the past chair of WFNS YNS. Dr. Marisa and Dr. Laura from the ENS YNS, Dr. Enku Bailo from the Young African YNS, Dr. Fad, who's the chair of WFNS YNS Award Committee, and Dr. Elizabeth, who's also a member of WFNS YNS. And of course, Dr. Chen, who's the member of ACNS YNS. Now, with that short introduction of the session, may I request Dr. Ignatius first, who's the chief of the WFNS YNS, to kindly tell us and take the podium ahead, please. Dr. Ignatius.
Sachin, thank you so much for giving me the honor to be here with you this morning. I'll just briefly talk about the WFNS Young Neurosurgeons Forum, what our activities are all about, so that young neurosurgeons in Asia can be able to join the group and participate in our activities. Well, these are the members of my team. Well, they are issued from all the continents in the world. And you can remark here, these are members from Asia, with Sachin here, who is the chair of the Asian Young Neurosurgeons Forum. And I want to really congratulate him with Professor Yoko Kato, who is our mentor, for putting together such a very wonderful congress, which is occurring for the first time in the history of neurosurgery, and it's led by the Asian Young Neurosurgeons. There is no conflict of interest, and a young neurosurgeon is defined as someone who is has finished his training in neurosurgery, and it's within 10 years after training, might be a resident, might be a fellow, or somebody who is doing a fellowship somewhere. And the goal of having the WFNS Young Neurosurgeons Forum, as was created by Professor Majid Saimi, was for the young neurosurgeons to represent and promote the interests of young neurosurgeons worldwide in the domains of developing the surgical skills, help them in becoming good educators, in training future generation, and in assisting them to become good researchers in what we call the academic neurosurgeon. The WFNS Young Neurosurgeons Forum, well, there's a chair and a co-chair, and they are members with a secretary. And we tried to have members from each of the continents of the world so they should be well represented. We work in collaboration with, we ensure that all the committees work in collaboration, like what we are seeing today, which is a collaboration of continental young neurosurgeons committees. We also work in collaboration with other WFNS committees, because the WFNS Young Neurosurgeons Forum is not a technical committee per se, it's just a committee for advocacy. So we need to collaborate with the technical committees to be able to promote the activities of neurosurgery to improve on patient care. So what is the role of the young neurosurgeon, and what are our activities? The big picture of what we try to do is to develop what we call academic neurosurgeon. Somebody who is not only involved in providing neurosurgical care to the patient, but somebody who is involved in education and training and research. And quite recently, we've added the concept of global neurosurgery. So for a young neurosurgeon who is thinking about the future, for you to be useful in your community, for you to be useful at the patient level and at the community level, you need to engage in these 4 activities. You need to be actively involved in patient care, actively involved in training of medical students, residents, and even fellows, and should be actually actively engaged in conducting research. But we know this picture is totally different from what we see in the high-income countries and low-income countries. This concept is well understood, like in Japan, for example, in Asia and other countries in North America and Europe. You find doctors who try to apply this concept. They spend a lot of time treating patients. They have a laboratory where they learn basic surgical skills and endoscopy skills. They are affiliated to universities where they're actively involved in training and education. But this is not what we see in the LMICs, because, first of all, our number is very limited. So you find a neurosurgeon who's alone for a very huge population. So you spend almost more than 80% of your time in the theater consulting, and there's little time left for you to be involved in training and research. So this is what we're trying to change. We're trying to move the picture from the right to the picture on the left. So, but we try to work following an evidence-based methodology. We need to, first of all, need to understand what the barriers or what are the challenges of young neurosurgeons across the world. So we did a survey, because as always mentioned, to be able to, to carry out good neurosurgical policies, you need to apply the principles of evidence-based neurosurgery. To be able to provide optimal care to the patient, you need to apply the principles of evidence-based neurosurgery. So from this survey, which has been published, we already analyzed the data for Africa, and now we're looking at the data from Asia and the other continents and other subgroup analysis. We're able to come up with some results to understand what the young neurosurgeons themselves find as challenges, what they need, because you cannot provide a solution to something, to somebody who is not in need of what you want to give to the person. So one of the problems we've discovered was the problem of workforce. The problem of workforce is not very rampant in the high-income countries, but you find that in Africa, especially sub-Saharan Africa, in Southeast Asia, Latin America, where about 70% of the respondents identify that there's really a deficiency or an inadequate workforce. So this explains why you find most of them overloaded with work and with little or no time for research and training. Infrastructures too are a very big issue. Okay, most neurosurgeons don't have access to good diagnostic facilities like the MRIs. Some of them work just with the CT scan. It makes it very difficult to be able to offer good surgical care like neuro-oncology and vascular surgery without all these facilities. Service delivery is also not very optimal in the LMICs. For example, most of them don't have specialized neurosurgical units. Okay, you just have a hospital where maybe neurosurgery is just part of the general surgery. So it's difficult for you to be able to make some good decisions without the interference of the general surgeons. In LMICs, there's a problem of payment. I mean, in my ward at the moment, I was just talking to my director. There are about 10 patients awaiting surgery, even patients with emergency situations with extradural hematoma, for example, who is not able to pay, but the patient has been there for 48 hours with the deterioration of conscious level. So because of no insurance, it's difficult to be able to provide neurosurgical care because neurosurgery is a very fine specialty and it requires early intervention. And for us to be doing this, patients should be able to pay. And when there's no insurance, it makes it very difficult to be able to do this. To do research, you need a good filing system. You need to be able to collect data. And in most LMICs, there's lack of electronic databases. It's still paperwork. For example, in my hospital, I'm trying to develop an electronic database for my own patients. But in the hospital as a whole, there's no electronic database. It makes it very difficult for people to be able to conduct good research. So when we did the survey, we realized that the most important needs of young neurosurgeons that were identified by young neurosurgeons were they wanted to go for fellowships, to get subspecialties. Okay, most of them complain that they don't have access to educational facilities. Most of them don't even have a good grasp of research and therefore cannot conduct and publish in neurosurgery. And the most identified challenge of young neurosurgeons was the inability for young neurosurgeons to have access to research facilities and therefore conduct research. And this was very high. For example, young neurosurgeons in LMICs, up to 60% of them identified this as a problem, although in HICs, just about 1/3 of them identified this as a major problem. As you can see from this map, the problem of research is crucial. Okay, you see up to 75% of research in the world comes from high-income countries. You see Asia, despite having a very huge population, for example, India and China, I mean, they go to billions, but they produce just about 20% of research output in the world. Whereas North America and Europe, they produce up to 75%, Africa, 0.3%, Middle East, excluding North Africa, 3%. So it's actually an issue, and that's why we've been focused on this. We try to train young neurosurgeons and to provide solutions to this. And this becomes a very critical issue. For example, if you take traumatic brain injury, which is a public health problem, which is a global health problem, most of the TBI cases, up to about 70% come from LMICs, but more of the evidence comes from high-income countries. So even if the studies are internally valid, it's difficult to extrapolate the result to low-income countries because the settings is different. So you need to be able to have research data from low-income countries to incorporate them into the guidelines. For example, the guidelines produced by the Brain Trauma Foundations, if you look in the reference list, you find very few studies from low-income countries. So we're encouraging young neurosurgeons in LMICs to be able to publish their work. It's true that they may have difficulties, but need to provide data so that these guidelines could be developed, incorporate our local settings. And we demonstrated in this paper with Professor Keeper that high-income countries also need to assist low-income countries. We see most of the studies even published in global neurosurgery. The first and the last authors are most of the times from high-income countries. So, and low-income countries researchers are sandwiched in between them. This is not what we intend to have. We're hoping that in the next 5 to 10 years, this situation should change. That's why we collaborate with the WFNS Global Neurosurgery Committee to work on this aspect. So we need to advance relevant research, because there's no way you can develop a country, there's no way you can develop medicine without education. There's no way you can develop medicine without research. Research is a very vital tool, because to be able to provide optimal patient care, you need to apply the principles of evidence-based neurosurgery. And this, you need good data and good research. So we did some training courses, started here in Africa. This is one of the courses which we did in Kinshasa. Here we invited Professor James Ruka, the editor-in-chief of Journal of Neurosurgery. And we have a course which we already carry out in Africa, and very soon this course is going to be extended to other LMICs. We had a course with Professor Benzel, and I want to announce that a few days ago, there was a special issue published in the World Neurosurgery on research methods. And this is a very huge success for us, because we realized that most of the research articles published were flawed. And when you have flawed data to apply on patient care, it's not going to be optimal. So we very congratulate Professor Benzel for carrying out this initiative, and we're encouraging other journals to be able to do the same. Asia has the Asian Journal of Neurosurgery. In Africa, there's no African Journal of Neurosurgery. There's a journal in the Latin America, but which is not very regular. So when we encourage build capacity, and know how difficult it is to publish in North American journals, we know how difficult it is to publish in European journals. So it makes it very difficult for us. Very difficult for us to be able to assist young neurosurgeons. That is why we developed the Journal of Global Neurosurgery, which is an open access journal, no paywalls. We assist young neurosurgeons in the process, study design. We help them their statistics. We help them even in the language, so that young neurosurgeons are able to publish their research. And this is an article which was led by my friend Kobile from Africa, where we emphasize that young neurosurgeons need to collaborate with each other in a symbiotic approach. They need to collaborate. We need to be able to have multi-center studies between Asia and Africa. We need to have multi-center studies between North America and Europe, so that we're able to look at the differences and similarities and see how we can improve on our work. Apart from what we just mentioned, the need for fellowship, research, and education, many young neurosurgeons also talked about journal clubs. Journal clubs are very important when you select key papers, discuss them, and see how you can apply them to patient care. So we need to improve on this. Many young neurosurgeons don't have access to cadaveric studies. And that's why we are supporting our friend who is actually a revolutionary, Dr. Federico from Italy. He actually developed settings. I mean, when I was in medical school, I participated in the cadaveric course maybe twice. So it makes it very difficult for us to be able to have hands-on. So that's why we also need to move to new technologies to be able to improve on patient care. Most neurosurgeons are interested in spine surgery. They're interested in neuro-oncology and neurovascular surgery. Trauma is not always a problem, because during our training residency, we have very good exposure to neurotrauma. So we need to be able to, WFNS need to look for ways to be able to assist young neurosurgeons to get into fellowships in those specialties which they actually want to specialize in. Most young neurosurgeons, about 60% of them, reported they have never attended a WFNS conference. So most it's very expensive. For example, I had to travel to Bogota last time and had issues with visa. So sometimes you see the barriers are there, preventing young neurosurgeons from participating in meetings. First of all, the flights are expensive. Getting visas are also difficult, especially if you have to move from LMICs to HIC. So WFNS need to create a policy to be able to facilitate the movement of young neurosurgeons, so that they're able to learn, return to their countries, and provide a good optimal care to their patients. So to conclude, aside the classical practice by young neurosurgeons have a role to play in advocacy and the promotion of neurosurgery. And I'm very happy to see that most countries now have young neurosurgeons forum. Before that was not the case. We created the Young African Neurosurgeons Forum in 2018, and we've contributed very much to supporting the senior neurosurgeons in the continent to develop neurosurgery in our continent, because young neurosurgeons have a bit of time. They are knowledgeable about the new technology, so they can assist the senior neurosurgeons who have the surgical experience to improve on patient care. There are challenges, of course, but we are counting on our seniors to be able to make things easy for us, to be able to build our careers, to be able to get good skills in patient care, education and training and research. Thank you so much for your kind attention. As I always say, the future of neurosurgery is in the hands of young neurosurgeons. So we need your support. I want to thank Professor Yoko Kato, who is an advocate, who is a mentor, and who has been supporting young neurosurgeons in Asia and across the world. I met her so many times in Africa. Thank you so much, and thank you for inviting me to participate in this Congress of Young Neurosurgeons.
Thank you. Thank you very much, Dr. Ignatius. It's always a pleasure to have you. And I must congratulate you for the work which you have done, especially in the field of research for young neurosurgeons. It's phenomenal. You, Ernest, Angelos, and of course, Dr. Key Park, you're doing a phenomenal work. Please keep that up, and thank you very much for having you. We'll have you at the end of our session for the discussion. We can definitely talk about a few issues for which we can collaborate different YNS committees and work together. Now, after that, may I request Dr. Fahd, who's the chair for WFNS Young Neurosurgeon Award Committee, to kindly say a few words and give a message for the young neurosurgeon. Over to you, Dr. Fahd.
Thank you, Dr. Sachin. For good morning or good afternoon for all our colleagues present. Thank you for the kind invitation, you, Dr. Sachin, Professor Kokato, and all the organizing committee for this brilliant idea, but also for the kind invitation. It was a really pleasure to hear the talk of my friend Ignatius, and I want to congratulate him for this huge effort to promote research for a young neurosurgeon. We had the pleasure, me and Ignacio, to collaborate together in different committees, especially the Young Neurosurgeon Forum, and it's always a pleasure, but a learning time for us as young neurosurgeons to work in team for global neurosurgery goals, if I can say that. So I had the pleasure also to work with other colleagues that who are in this flyer. Ernest, Angelos, you, Sachin, we still working together at the same committee. Marisa, Laura Lipa, and Kobil, and and also we working. I had the chance to work with other colleagues in other young neurosurgeon committees in Arab. For Arab countries or for French-speaking countries, and for in the Maghreb. So through there, you can imagine that we have a few examples. We shared some with together. So the first is this great experience for any young neurosurgeon is the WFNS Young Neurosurgeon Forum, and you can just go to the website and you can understand how it is rich. It is as experience. We organized webinars years ago, and also we had publications, and what the most important is we shared ideas, we discussed ideas. We were not agree about everything, but we all agreed that we need more efforts. I don't know if you can see my slides.
We can see, Dr. Fahd, you can go ahead, but you can do the full screen. You can play the PowerPoint.
Okay. Let me share again my slides. My desktop. Go for not this one. Oh, it's okay. So I was saying that it was a great experience for all of us at this forum, and during also at the Young African Neurosurgeon Forum, we had like an example this Dr. Jeff Ntalaja, who organized National Congress of Congolese Society of Neurosurgery, and also WFNS course in Kinshasa in November 20, in November in Kinshasa. And then I had we had to meet the president of WFNS, we met the president of CAS, and we discussed about many other goals that that we do not reach yet, and we ask to for this organization to do more efforts to support us and for new ideas. And it's just like that we discuss, and we together we put ideas, and we try to have the support and to fulfill our goals. So another experience is the collaboration between members in the Young Neurosurgeon Forum, WFNS Neurosurgeon Forum, and we were monitored by our leaders in WFNS and World Neurosurgery. And here we had the opportunity to collaborate with the Ab surgeon and Federico Nicolosi, who is a great friend of many of us. And we had this the global training project with the large impact on residents and young neurosurgeons in Morocco, and who are trained in Morocco for neurosurgeon and residents and neurosurgeon from Morocco and from low and middle income countries, trained at the WFNS Laboratory Reference Center. And they had the chance to train about many approaches in one day in this cadaverless training program. And just it was the beginning of a new adventure, a new journey for to establish a cadaverless lab. I met Federico in the YNS last week, and we discussed about new prototype to offer for our colleagues who are trained in Morocco, neurosurgeon in Morocco. And also this I think he told me that it was the first lab for cadaverless training in the continents, and we will be happy to welcome, as always, and offer scholarship for a young neurosurgeon to come and get this opportunity to be trained in this new philosophy, new way of training, and resolve what SN tell us during his presentation, the problem of access to training on cadaver. So communication also important, and you can see the WFNS World Young Neurosurgeon Forum website, the African Forum Facebook and Twitter, and every way of social media communication. And here Khalil Qadasi, who is a member of our committee, who is one who are charged of communication in collaboration with many other young neurosurgeons, including me, at the Pan-Arab Neurosurgical Society, and it's helped us to establish a bridge between different generation of neurosurgeons, and also between different young neurosurgeons around the Arab world. So I was chosen to be chair of the Young Neurosurgeon Award Committee. The past chair was Paulo Pereira, and he's a great friend of mine, but also a great teacher in neurosurgery. We had the pleasure to discuss about this committee, and to have his experience, and it's just amazing to know that many different awardees had great opportunities after this, after having this prestigious award from young neurosurgeon. So I had the responsibility to create to ask members to join the committee. So we decide as recommended by the WFNS president and WFNS committee's coordinator. We had to include 12 members, and we decided. I preferred to have all continents present and all regions present, and have different generation of young neurosurgeon in the committee to share experience and also to reflect the need and the goals of every region and every generation. So it was real continental collaboration, and we had in this committee Professor Fadi Shabel, well-known vascular neurosurgeon and inventor, Alexandra Golby. She is the principal investigator at the Harvard Medical School of the Golby Lab. Sachin Shimat, he is with us and he's very active. Yoreki Shimizu from Japan, and Khalil Qadasi, Professor Shudifat from Jordani, Jeff from Congo, Dr. Padayashi from South Africa, who is pediatric neurosurgeon, Professor Richard Arsaki, who is a spinal surgeon and a good teacher for a young neurosurgeon. Andreas Dimitriades, he is the president of the European Association of Neurological Societies, and my friends Javier and Marcio from Flying Creation. So different region, different generation of neurosurgeon. I just want to remind you that this committee is in addition, had that second name in addition, is known to be the Atos Alves de Souza Award Committee also. I never met Professor de Souza. He was honorary president of WFNS, and he was known to be dedicated to education for young neurosurgeon, He's from Brazil, but he was you can see this obituary that was written by African neurosurgeon Dr. Don Chambenois, and just to know that education had no borders, and with just one word to share the same goal, and we are honored to have this name for the committee and for the awardees. So as mentioned, the young neurosurgeon is a neurosurgeon within 10 years of having obtained the neurosurgical qualification. So each award shall consist on an honorarium of $1,500 US and certificates and waiver for accommodation and restoration. So all papers will be judged by the committee, should be original and published work on basic research on clinical studies related to the neurosurgery. Just let me to tell you that's what I'm presenting. It's just a screenshot of the bylaws. It's all the details are defined in bylaws. We had to do some things to adapt it to the evolution of technology. Like we will not ask for copy papers of the manuscript. We ask for PDF for all the for the paper for this unpublished work. And what is most important, that this award will be given as a recognition in front of all neurosurgeons at the opening ceremony of the World Congress. So this time it will be given in Cape Town in 2023, and also the awards will be advertised in World Neurosurgery and the Federation web, and of course in all social media communication tools for all neurosurgeons. So I invite you to share to send your papers. If you wanna have good papers and have to give awards, we need these papers. And there is a lot of work that was done about research in high-income countries, but also for low-middle-income countries. We understand as a committee that there is difference of support, difference of resources in different countries, and also different kind of impact of each paper. So we will judge that regarding this, the challenges, and also regarding the impacts. You will have all criteria of this that should be respected on the website of WFNS 2023 Congress, and all terms and conditions. Pay attention. There will be a deadline. So I think the submissions will start on July 2022 and end by March 2023. So our goal as a committee and as part of this dream to promote research in neurosurgery, especially in low-income countries, is that last time they received 60 papers for Bogota, and here, to be honest, we expect like a double, and we hope to have even more than that, and we need to work for that. We will communicate about the award. We will use the best channel of communication, which is the WFNS Neurosurgeon Forum. I was there for 4 years since the creation, and it's just amazing how I know the force of this committee and the energy of all members, and also of the chair. So we will use also our own social media tools and social media of other colleagues that are very strong and very large, and I think we are all members in many of them, neurosurgery cocktail, for example, and others. So also as a committee, we organize webinar programs about research on how to get the WFNS Young Nutrition Award. We will see the program in a few weeks, and these are the awardees for the last year, last time, that was chosen by the committee that was chaired by Paulo Pereira. And in this committee, just to give you an example, there was Professor Yoko Kato, Professor Graham Figan as members, and they have this tough task to choose the best papers, but in the same time they can't give an honorable mention for the rest of the papers, because they are the scores they adopt, and we adopt a scoring system. They're far from those choose for the awards. So we need to promote for people to produce research, but also to produce good research with good impact. As a committee, we had many collaboration with the other WFNS committees, and also we have the support of many leaders of neurosurgery in the world, like here you can see Professor Spezler, Professor Angela Bedi, Luis Borba, and Bojanovsky, and many others, and you can see here that we are planning to have more collaboration by the end of this month with the other committees, and also our own program. So thank you, Sasha. Thank you all for the kind invitation and for listening to me. And if you have any question, I will be happy to answer. Thank you.
Thank you very much, Dr. Fahd, for having you here and explaining about your committee's role, the finance, research, and awards are very important parts of every resident's and young neurosurgeon's life. And if that happens, if the award is from the WFNS and with the good prize money, it's always very helpful and honorable for the young neurosurgeons. So thank you very much for helping and introducing and telling us more about how people can apply for this particular awards. Thank you very much. Please be with us at the end. We've still got more 45 minutes. So at the end, we will have a discussion wherein definitely a young neurosurgeon would definitely want to interact and ask you questions to you. Now, after that, we've got Dr. Nkubaile Tango, who's from South Africa and who's got a major role in doing the activities of young African YNS committee along with Dr. Ignatius. Unfortunately, she's in OR, but she's agreed that she'll be able to at least say a few words and pass on some message for the young neurosurgeon. Nkubaile, are you there?
Thank you, Session, for the invitation, and it's really such an honor, and I'm so sorry that I can't even put my camera on and it will be a few words, but I also just wanted to just hopefully request that if I can just send a PowerPoint that you'll share with your attendees, because there really is a lot of work that all of us as young neurosurgeons are doing, but specifically in Africa. So I just want to mention that the strength of maybe being young neurosurgeons is that we're able to collaborate. And on this platform, one of the things that the Young African Neurosurgeons Forum was very active about is empowering young neurosurgeons and kind of realizing the resources we have within our continent and building strength. And specifically, we divided it under the leadership of Ignatius into three, which is mentorship, education, and research. He's spoken a lot about research, but as young neurosurgeons, we should all have a role in bridging the gap in terms of research equity. And from the WFNS Young Neurosurgeons Forum to the Intercontinental associations, that is one priority we all have as a group. And as we move forward specifically to Cape Town 2023, we hope that there'll be a diverse platform of young neurosurgeons from Asia, from Africa, from South America that are really publishing high quality work, because what we want to highlight is that there are a lot of resources. For example, in Africa, we're quite a heterogeneous country, so there's various areas of excellence within our continent. So it's all about just enhancing and working together. So we look forward. I know that Jeffrey and Fayed was also discussing about the award committee, which is amazing and excellent because it will really motivate people to have high quality research. And then another thing I just want to mention that I've been very proud of is as a group that we've achieved, Sessions currently the lead in terms of Asia for a survey that we've just completed looking at research capacity, and that is something exciting that we'll be also publishing within the next month to come. And it's been a lot of work, and Asia actually has had the highest amount of respondents, so we're really excited, and I'm sure Sasha will also be doing a sub-analysis of his respondents, so there's a lot to come. I'm sorry I need to keep this short, and I just wanted to thank Prof. Yakokotu and all your panelists just for this invite. And as I mentioned, Sasha, I'll forward a PowerPoint that you can just share with your delegates that will just give a bit of a brief outline of what we're doing. Thank you so much, and I'm sorry to keep it short. I think my resident is calling me now. He's just finished opening. Thank you very much. Okay. Thank you.
Yeah,
thank you very much.
Yeah, boss,
yes,
Kobile is the motto of the Young African Neurosurgeons Forum. I mean, if things have been working very well in Africa, she's been the person in the background doing most of the work, and you can see her activities in the WFNS Young Neurosurgeons Forum and the survey which we are actually conducting at the moment. So Kobile, I know you are very busy. She's in Cape Town, and it's Africa's best university with a very high patient volume. And as I told you before, it's not always easy to practice as a young neurosurgeon and then at the same time involved in education and training. Kobile, I wish you good luck in your surgery. We'll continue with the talks.
Thank you.
What PowerPoint was she mentioning? She has sent it to you?
Yeah, she will send it to you. She will send it to you so that it can be uploaded. She's going to send it.
Okay, no problem. I'll go through my mails. So meanwhile, first of all, thank you, Nkubaile, for having you. Although you were busy, but spared few time and few moments for us. That was definitely encouraging for the young neurosurgeon, and for the female young neurosurgeon, definitely you are exemplary. So thank you very much for having you for this unique session. After that, I've got. You want to say anything? Okay.
No, I just wanted to say thank you so much, and we'll be in touch. Thank you. Bye.
Thank you. So after that, we've got Dr. Elizabeth, who's from Mexico, and she's also part of Young Neurosurgeon Committee, and she's going to share with us briefly about one ongoing research activity she's going. Dr. Elizabeth, are you there?
Yes, hello. Yeah, I'm here. Can you hear me?
Yes. Please share your screen and go ahead.
Yeah, sure. Can you see my screen? Okay, well, yeah, everybody can see my screen, I guess, right?
Yes.
Okay, perfect. Well, thank you for taking the time to be here. And today I'm gonna talk about a project that we are working with other member of the committee, who is Jehan Sihua. I don't know if I'm pronouncing her name properly, but she's here and she was presenting at the beginning. So yeah, we are, as you know, this committee is also trying to improve neurosurgery in LMICs and creating, and as Ignatius said before, there is a lot of limitations in terms of technology, infrastructure, etc. And as he said, spine surgery, neuro-oncology, and cerebrovascular surgeries are quite challenging in LMICs. So we are trying to see if we could use the transcranial ultrasounds as an screening test for brain tumors in children in this case, and all in this phase of the study, and we want to also move this to adults, but at this moment we are going to focus on children. So just a brief refresh of the importance of having having a screening test for brain tumors is that, for example, in kids, brain tumors are one of the most common cancer in children. Is the most common solid tumor in this age, 0 to 14 years old. From all the tumors, around 4% of them are gonna present it in these ages, and it's estimated that every year, at least here in the United States, over 3,400 children will be diagnosed with a brain tumor. So it is a very important topic that needs to be addressed, not at very late stages, as we are diagnosing our patients, right, all over the world. So as we are saying, brain tumors are diagnosed basically when the patients are having symptoms. So the patients are having symptoms, comes to the clinic, and most of them are having symptoms related with intracranial hypertension, and then we do a CT scan or an MRI, right, depending on the resources and where we are. But from our knowledge, there are no screening tests available for brain tumors in children or adults. I mean, and now I want to tell you the difference between what is a screening test and what is a diagnostic test. That there are very different things. So the diagnostic tests are usually done to find what is causing certain symptoms, right? In this case, what is creating why the patient is having a headache, having nausea or vomiting, etc. But screening tests are done in people who do not feel ill, so it's aiming to detecting diseases in early stages. So for example, we are having these two scenarios where we are having a patient without screening, that is most of our patients, right? Any brain tumor patients are not screening for brain tumors. And what will happen if the patient were screening with any in this case we are presenting the transcranial ultrasound, right? But screening with any test, the scenario is very different. For example, the survival after 5 years without a screening test is 0, and the survival after 5 years with a screening test is 100%. And the reason is that, for example, even the mortality will be at 70 years old. The patient is presenting their symptoms, the cancer here, right? Their cells are mutating here. So it's gonna take all this time to start to present the patient presenting symptoms here, right? So then obviously patient, for example, with the standard care of treatment at this point, that is surgery, chemotherapy, and radiotherapy plus or minus immunotherapy, they die at 70 years old, for example. But if we are having a screening test here, so before the patient can have symptoms, we can give them treatments or undergo surgery with that patient and have like the maximal safe resection of their brain tumor, etc. So there are options. So the survival is higher because we are diagnosing the tumor before, because it is very important to mention that having the tumor or having the symptoms are not the same, right? So it is important to diagnose it before. So the WHO has some criteria to decide what type of pathologies or diseases could fit to have a screening test. And these are the three main things that the WHO are looking for. And I will say that brain tumors fit pretty well on this, because it says that the disease needs to have serious consequences, and well, brain tumors definitely have serious consequences, as we know, most of them. And for example, they say that the test must be reliable and non-harmful. In this case, transcranial ultrasounds are not harmful. They are they are not they do not create radiation as the CT. They are more available worldwide, more than the MRIs, etc. So reliable, we don't know exactly for brain tumors, but we know that transcranial ultrasounds are reliable for other type of intracranial pathologies, such as vasospasm, or hydrocephalus in kids, etc. So it is very reliable for other pathologies, and obviously this project is to see if it can be also reliable for brain tumors. And it says that there must be an effective treatment for the disease when detected at early stages. And definitely, if we detect the tumor at early stages, again, the resection will have highest chances of having a gross total resection, chemo, radiotherapy, or even other type of treatments or more personalized treatments can be an option for these patients, right? So definitely also the detecting brain tumors in early stages will have an effective treatment. So the benefit so we are proposing this, right? Using transcranial ultrasounds screening tests, and the benefits that we are seeing is that they are portable, they are more affordable than computed tomographies or MRIs. The downsides could be that the thickness of the skull could be something that could make some noise to the image, but There are some special transducers that actually are good for the thickness of the skull, and we can know that because they are already those transducers that are used for vasospasm. So there needs a special training for the operator. Yes, we just need to train the person who is gonna use the transcranial ultrasounds. But I mean, everyone needs to be trained for doing a surgery, taking an MRI, taking a CT scan. So I don't think that this is a really bad thing, but it is a downside down the road, right? At the end of the day. So if people, one of the main problems or the main concerns that we have been facing is that people have been telling us the skull thickness of children. So in this paper that was published last year for Dominic Fernandez, they were showing us how was the thickness of the skull at different areas of the skull, like more like to the isthmus of the temporal bone, more to the frontal, more to the occipital, etc. So they were seeing that the temporal bone were the thinnest, and obviously all the midline was the thickest. And so we are aiming the temporal to have a window in the temporal bone, and also for infratentorial tumors. We are thinking that perhaps we can use the occipital or lateral, a little bit lateral to the occipital bone to have that window. So this is another paper where they were showing from newborns to 3 years old. This is a prediction how they are getting the bone is thicker, right? How it is a prediction based on I don't remember exactly, but 14 cities, something like that. So definitely we are aiming again to have a window here, and on the back we want to have a window here, here, or here, right? So in this project, we are targeting to screen the most common anatomic areas of brain tumors in kids. For example, the cerebellum, which we are going to find astrocytomas, medulloblastomas, the fourth ventricle, that is the ependymomas, the pons for the IPGs, and cellular regions for craniopharyngiomas. So at this point, these are the areas that we want to get focused. And if we see the transcranial ultrasounds that are done already for more or focused for vascular surgeries, we see that they are the window can reach these areas, right? We just need to modify a little bit the technique to visualize more into the infratentorial area, but definitely we can see the midbrain here, then the third ventricle in here, the thalamus here, etc. So, and we just need to be trained on and in knowing how to read these images as we get to use to read the MRIs and CTs, right? And for example, there's another paper here that they were using transcranial ultrasounds for the cellular region, and definitely we can see here a pituitary tumor that it is in an asterisk here that we can see it, and also here the pituitary tumor with the cyst portion here, and we can definitely identify the tumor here, right, with the cyst portion here. So future directions with this project is that we want to include around 100 children with confirmed brain tumors, either way with MRI or CT scans. The tumors must be in the regions that we mentioned before, because that is one of our criteria at this point. And the ultrasound should be performed using 1 or 2.5 megahertz transcranial transducer, because we have seen that with less megahertz we can penetrate more into the brain with a thicker is called. So this is one of the things that we are doing in the committee, because we are again aiming to improve and moving forward the neurosurgery also in LMICs, and I think that also this project also will benefit the HICs, right? Obviously, because again, from my knowledge, there are not screening tests at this point, but definitely we are more than happy to collaborate with anyone who wants to join us. I don't know if
Thank
anyone
you.
has a question.
Thank you very much, Elizabeth. That is a wonderful research study you're doing, utility of transcranial ultrasound in children. That's definitely very good research capacity. And definitely, if you need any sort of collaboration, having it collaborated through different YNS committees would be definitely a very good randomized control trial. So congratulations, you're doing a great job, and we look forward to get associated with you for this particular project.
Yeah, thank you. Yeah, we are doing that with Jehan also, and we are happy to talk about this more in our committee.
Yes.
Yeah, thank you.
Thank you. Dr. Chen has just joined. Dr. Chen, you want to say anything?
Yes, I'm so happy to see Elizabeth has so much progressing. This story started from one day I saw just idea in our Young Neurosurgery Committee WhatsApp. That's a very great group in WhatsApp app. Then Elizabeth responds me so fast, and we make a network. Yes, with email at first. Then we think we should make a face-to-face talk. So later we talk online. Then she make much efforts for this research. I think our clinical research very important. This can push our profession move forward. So the neurosurgery, we are very busy. So I'm very respect her can make so much time on this project. So I wish you pursue this project and never never give up it. We need a more team member to join this project. This is one point. Another big point is the funds. We need grants to support our team and lab AC and imager AC. Just like in my topic, my presentation mentioned. So we welcome everyone. If you have any interest in here, in this project, you can join us. Maybe this project can perform in America, also in India or Africa, because ultrasound is easy to get in the clinic in the low-income countries, and very it's very meaningful for young for pediatric patient. We can detect the brain tumor early. So we welcome to any question and concern to us. We want to write a capstone or protocol. We also want to apply to any grants. We welcome you give us any information, we can apply the grants. Thank you so much.
Thank you. Yeah. Thank you very much, Dr. Chen. I'm so energetic, very happy to have you. Thank you for participating and for active discussion.
Yes. Yeah, one point I remember I watched another presentation, Dr. Hira Bohan from Toronto. She also mentioned this research. So maybe we can work together.
Yes.
Okay.
Dr. Hira is taking care of our medical student and resident committee. So she's very active and she has participated in the various research projects in the past. So she can be definitely a good help. So
Okay,
thank you
we
very
have
much.
new
Now
more
we're
members.
left,
Thank you.
we're left with another 22 minutes, and I would like to start my talk. I'll speak only for 10-15 minutes just to introduce our ACNS YNS committee, and then at the end we can have some time for the discussion. So let me introduce how the ACNS YNS started. So ACNS YNS was established as a subcommittee under ACNS on August 2020. That was a big pandemic storm going at that time, and nothing was happening. That's when we decided, under the blessing of our patron, Professor Yoko Kato, the president of ACNS. The Professor Azmi Alias is the main mastermind and behind the establishment of this YNS committee. And after approval of all the committee members, we established the ACNS Recruitment Board, and which was formed and headed by Professor Azmi Alias and was coordinated by Dr. Liu and me. And initially we thought to recruit at least one male and one female young neurosurgeon from each country from the Asia, with the basic objectives of, the same thing, like to bring all the young neurosurgeons under same roof to organize the educational activity to improve the knowledge and surgical skills of young neurosurgeons across the Asia and the globe, to encourage and improve the research capacity, and to recruit, train, and organize the centers for the ACNS fellowship program in order to provide more career-oriented opportunities for the young neurosurgeons. This is how our team looked like when we started. We had 35 members, and most of them were from Asia. And this was the logo we decided, and which was very much liked by our Professor Yoko Kato. And then she approved it, as she says that the future of neurosurgery is in the hand of young neurosurgeons. So that's how we decided that this is the young neurosurgeon who's carrying the burden of future of young neurosurgery and the burden of ACNS society. So we went ahead with that. Initially, we thought to recruit only the members from Asia, but then later on we thought that no, education for the young neurosurgeon cannot be only limited to Asia. And then we thought to break the boundaries, and we started recruiting members from the different committees. Initially, we started working in 3 different groups. One group was the research group, which took care of all the surveys, publication, multi-centric study, which was headed by Dr. Liu. Another group was, this was our first publication, which was there in the World Federation of Neurosurgical Society newsletter, which we had published in last year, 2021, September, after completing 1 year of ACNS YNS committee. Second committee is a multimedia committee, which is basically headed by Dr. Ben, who's the very active member of our committee. And third committee is the Connect committee, what we call. The job of this committee is to recruit different centers for the training of young neurosurgeon, and we call them as ACNS fellowship centers. So far we've got 14 centers, and Professor Yoko Kato, Dr. Balamurugan, who's the secretary of ACNS, and myself, we were involved in recruiting these centers. So this is how the committee looked. We thought of recruiting more and more members. This was the East and Southeast Asia, the Central Asia.
I'm not seeing the slides.
You're not seeing my slides?
Yeah.
Am I audible?
Yes, I'm getting you, but I cannot see the slide.
Okay,
yes,
let me
your
share
screen is fixed. Screen fixed.
Okay.
Yeah.
Are you able to see my screen now?
Yes.
Yes.
Okay. Okay. So, so that was Central and the Southeast Asia. One second. Yeah. Okay. The Middle East, the Africa, North America, the Latin America, and Caribbean countries. We've got many members from the Latin America. Those are the list of members from the Latin America, and from Europe, and from New Zealand and Australia. So the most of the activities which were done in the last 2 years was actually webinar-based education, because because of the COVID pandemic, the traveling was restricted. So most of the activities were webinar-based, and we actually also had a collaboration of this webinar along with the WFNS YNS committee and ACNS YNS committee, wherein we had organized this one session where our mentor, Dr. Azmi Alias, was invited to deliver a talk on endoscopy, cranial endoscopy. Another major important aspect of our committee was to build up the capacity of neurosurgery, to start up neurosurgery, and to progress the neurosurgery in the areas of low resource zone or the low resource country. And when the pandemic had started, all of us remember there was a military coup in Myanmar, and then we had initiated this support group wherein we conducted certain webinars and education for the young neurosurgeons in Myanmar and for Afghanistan. And that was one of the webinar wherein the Professor Myat, who is the president of Neurosurgical Society of Myanmar, and Professor Fawad Pirzad, who is the president of Neurosurgical Society of Afghanistan, was invited, and who is our quite frequent chairperson for various webinars. And we always followed this theme of inviting the 2 guest speakers, and there'll be 1 or 2 YNS speakers, and who will speak mostly on the same topic. So at the end, there'll be a good discussion or a debate about different aspects, how a young neurosurgeon should approach, and different tips and tricks from the mentors and the senior neurosurgeons. So that was about the about our committee. We've still got 15 minutes. I would like to talk about this one of the online database research which we had done, the challenges of neurosurgical training in the developing countries. I'll skip these few slides and then I'll come to, yeah. So what are the basic challenges? So if you see statistically, the Human Development Index and the data which is given in 2018, 2019, because after 2019, we've got the data of only COVID. We don't have any other data. So if you can see, these are the countries of low resource or developing countries. And these are the countries which are developed countries. So what are the challenges of neurosurgical training? If I can put the challenges in 3 different, there are before joining the residency, during the residency, and after the residency. We can see before joining the residency all over the world, the main 3 basic problems are there, that there's no common theory exam or practical exam. There are different exams in different parts of the world, and they judge basically based on that particular exam, that particular 2 hours or 3 hours of session. There are too much of competitive. Sometimes you don't get into a college which you desire or institute which you desire. And as I said, the assessment of the candidate is based on only on this particular this particular 3 or 4 hours of the exam which he has written, and there is no actual assessment of the candidate. So that's the problem before joining the residency. If you can see during the residency, the problems are there is no universal program. If you can see in one part of the world, there is one particular program, one part of the world, there is other particular program. If I have to give an example, the endovascular neurosurgery is not part of the routine neurosurgical training in various institutes. In various institutes, they say it is a part of routine neurosurgery, and you have to either, if the institute is having that facility, they get posting there. If the institute doesn't have facility, they go outside for that particular training. Duration of training is very variable from institute to institute. There are rotations are not fixed decided. There's a lack of multi-speciality training, as I was mentioning about the endovascular. No external posting. In certain institute, they do not allow candidates to go out, which should be one of the component of the training, because when you go to the other institute, you definitely learn certain more approaches and more strategies. Lack of academic activities, lack of academic funds, lack of mentorship, working hours are exhaustive. Sometimes the money paid to you during this particular training when the age when you enter into neurosurgery training is 25 to 35, and this is the time when you are sort of started taking the burden of your family responsibilities. So you need certain amount of money for the family and financial stability. Exit exam, certain institutes have the exit exam, and which are quite tough and difficult to get out. Worry about the future. As you go towards the end of your training, you are worried about the future and the lack of attention to your own health. When you have finished the training and when you have started, if you look at your size, you realize that you've not given any attention to your health at all. Now, these are the problems which are during the residency. If after the residency, if I can put, these are the problems like what to do now. The biggest question is what to do now, whether I should go for any fellowship or I should start practicing straight ahead. Whether I am capable to practice or not, where to practice, whether I should go for a government hospital and train myself more, get more hands-on, or am I fit enough to go to private hospital and make some money. Lack of mentorship and local neurosurgical society support is one of the factors. And there is no government policy per se as for neurosurgeon. Almost in any country, for their settlement or establishment. Now, this was one social media-based pilot study which I had done during the COVID pandemic, and it was based basically on the Facebook, WhatsApp, Telegram, Gmail, and WeChat. So one of the drawback of this particular study is that only people who had access to this particular social media apps were able to answer the question. Most of the residents were English speaking, and the study was also done in English speaking. There are certain questions which I had put, and these are the percentage-wise response. Just let's take a look at it, and then at the end, maybe if we can discuss the common theory exam, no assessment of the candidate before joining. So that is there almost in 80% of the candidates who responded from different parts of the world. Duration of the training, please excuse me if I am wrong, but this is how I've got the response and I've put it up. In Canada, there is 6 years, no general surgery rotation. USA, 6 years, no general surgery rotation, but there's mandatory research 2 to 4 years. United Kingdom, 8 years, no general surgery rotation. Australia, 5 to 9 years, no general surgery rotation. Italy, 6 years. Turkey, 5 years. Russia, 6 to 7 years. Switzerland, 6 years. Germany, 6 to 8 years. India, there is a 3 years post-general surgery training. That is 3 years of general surgery and 3 years of neurosurgery. Or we've got 6 years direct after the basic medical qualifications. So you can see there is a lot of diversity even in the duration of the neurosurgery training, and involvement of general surgery should be there or not. Academic activities, most of the institute, 50% of the institute do not have good access to the academic activities. Boys are just learning, students are just learning while they are doing their ward rounds or going for the cases, but there's no dedicated classes. Daily working hours, any complaint? Most of the people have no complaint about their daily working hours because they say they are there to work, and they've when they've enrolled themselves into neurosurgery, they are committed that this is a branch of neurosurgery which needs lot of commitment, especially in terms of time. So they do not have any complaints, but most of them, if I had asked and then when they had answered, most of the neurosurgery residents who are working for 8 to 12 hours, 15% were saying that there are no limits. We have to be there 24/7, especially when you are a first year post student. External posting, 80% of them did not have any protocol of going for an external posting for any particular institute. Lack of academic activities, any academic funds given by the institute, and even their thesis or their dissertation work is also, they have to put the money from their own pocket. Now, stipend is a very important factor, as I said, when you are at this age of your life, and most of the people are not happy about their stipend. Now, suggestions or wish list. This is how, after I had got this responses and when I had analyzed, I thought this can be a suggestion or wish list as maybe a young neurosurgeon committee. or not as an individual. The candidate assessment should be there before joining the residency. We've seen a lot of times, you must have seen in your institute also, there are certain candidates who gets enrolled in the neurosurgery residency, but then only after getting into it and seeing a real life, they understand that this is not a field for them, and then the seat gets wasted, and you get one less neurosurgeon out of that. There should be a universal program from institute to institute. International and international rotation should be there. People should not just get rotated inside the country, but they should be allowed to go to the other countries, and especially the Institute of Excellence. Improvement of the academics, either by online, hands-on, or caliber courses. This activity should be encouraged, or activity should be conducted by the institute themselves. Stipend is a very big issue, and actually it depends on the economic status of those particular countries, but it can definitely be revived. Fellowship programs should be, there should be, as I said, in ACNS, we've got this recruitment team, and which is the job of this team is to recruit certain centers. We designate them as a center of excellence, and wherein any person who goes and spends 3 to 6 months, we award them with the ACNS fellowship program. And neurosurgical societies help, as Dr. Fad is here, and who's told us about the WFNS award committee. Many of the young neurosurgeons do not know about this kind of societies or this kind of committees. So having more awareness of this kind of committees is definitely very helpful. But these are all the logistic issue. At the end of the day, what is important is to be serious, to choose your mentors. Mentors does not mean that the professors under whom you are getting trained, the mentors who are there in the past, you can read about their biography, and the mentors, the legends, living legends of neurosurgery out there. During the different conferences, you can have an interaction with them. Although now because of the COVID pandemic, we're not able to do that. But tomorrow we've got Professor Majid Sami, who will be interacting with us with all the young neurosurgeons. So thank you very much. So those are the different points which I wanted to put forward for discussion. I think we've got only 5 minutes. And to summarize, I would request Dr. Ignatius and then Dr. Fad to say a few concluding remarks, and then we'll go for the next session. Dr. Ignatius, are you there? May I please request 2 minutes concluding remark of this particular session, because we're just 5 minutes away from our next session.
Well, and so it means there are going to be no questions, right?
Pardon?
No questions. Are there no questions?
I don't see any questions in the question and answer box so far. But
anyway, I had a question to ask you. I mean, and a question for Elizabeth. Yeah, the survey, the study you did. I mean, is it published already, or you still having the data?
Sorry, no, we are starting that project actually. We screened one patient, but he was 17 years old and the tumor was in the pineal region, and we did it with a transfontanelar transducer because we didn't have the transcranial. So yeah, it was a totally just exploratory screening. But yes, we are starting that project, and we are looking for, again, some grant opportunities or something for the transducer.
I was speaking because I think I agree with you that we can do screening for brain tumors. But in public health, in global health, when you have to screen for a disease, it has to be something which is very, very common, having a high prevalence or high incidence of that sort. So if you have to screen for brain tumors, you're going to look at the cost of screening and then look at the benefits if it is detected. And then, sometimes maybe you might have tumors which are not going to be very visible with the ultrasound. So I think you need to look into all these parameters before getting funding to go for such a project. It's a very good idea, but brain tumors are not as common as other pathologies which we screen for, so we have to discuss it. And thinking about transcranial Doppler, well, it's a very good idea. we might get some centers in Africa to support, maybe to participate in the study, but we need to go into some details, I mean, for the practicalities. Yeah. But
No,
before
we are happy to discuss this, and please, that's the idea of this, is to know the weaknesses of the project to make them, I mean, to overcome those weaknesses, right? So yeah.
Now, before I give a closing remark, I don't know if Fad, you have a word to say.
I want to just say thanks to the organizers, and I invite all of you to submit your papers. Please save the date, July 2022, for we start accepting the papers, and the deadline is March 2023, and the website is wfns2023.com. Professor Graham Figan, Anthony Fijaji, and Padayachi, Nico Eslen from the organizing committee are doing great work to welcome all of us in Cape Town, and there is a lot of exchange that we can have during this World Congress, but most important is the science that we will share together. And you can have a lot of teaching through the WFNS Young Neurosurgeon Forum website, where there is many webinars about how to conduct research, how to write good papers, and also on the different pages and channels in YouTube. And just go ahead and send us your paper. It will be a pleasure to read them and to choose the best one, and even more than that. Thank you so much.
Thank you so much. Thank you so much. Yeah.
Thank you so
So,
much.
well, on behalf of the WFNS Young Neurosurgeons Forum, we want to first of all thank Professor Yoko Kato for coming out with this very brilliant idea, and which is concretizing today, bringing all the young neurosurgeons together. You know, she's a model to all of us. I mean, as I always tell you, she's traveled to almost every continent in the world. I mean, I met her in Harare. She's been in Kenya, Egypt, everywhere. So she will look up to be like her when we become senior neurosurgeons. And I see Sachin is taking her footstep. Sachin, well done for organizing, putting up such a very good program. We are very proud of you, proud of what you're doing in Asia. And we hope to maybe learn from you and maybe do similar things back in our respective continents. Thanks to all the members of the WFNS Young Neurosurgeons Committee who are here, Elizabeth, Shen, Kobile who came in and went. Ben, thank you so much for your time and putting up the program. We appreciate everything and looking forward to the rest of the Congress. Thank you so much.
Thank you. Thank you very much, Ignatius, Fad, Chen, Elizabeth, Henku Bailo, Laura and Marisa could not join, and Angelus could not join, but it was a wonderful program. What I thought, collaboration of Intercontinental YNS. I think we can, there is a scope, and there are different, there will be different opportunities for us to collaborate, especially on the ground of education and research, and we'll take it ahead. Thank you very much. We are starting with our next session, that is YNS Award Presentation Session, wherein different young neurosurgeons have put in their papers for the award category. Ben?
Okay, I'll share that.
Yes.
Thank you to everyone watching this presentation. I'm Adoraldo, a neurosurgeon from Brazil, currently a clinical fellow at the University of Toronto, Canada. Presenting the topic, Combined Approaches for Dural AV Fistulas, Hybrid Vascular Neurosurgery Training and its Advantages. Dural AV fistulas are pathological arteriovenous anastomosis in the dura mater, accounting for 10 to 15% of all intracranial vascular malformations. The treatment basically consists in disconnecting the fistula point, which can be achieved with open surgical disconnection or endovascular embolization. Combined approaches are useful when a single modality is challenging to be performed or fails to treat the fistula completely. So we can combine open surgical and endovascular technique. Here we present two cases illustrating combined approaches for dural AV fistulas. The first case is a 35-year-old male presenting with headaches over 4 months with no neurological deficits. His MRI revealed a right temporal encephalomalacia area with an underlying intracranial hemorrhage. And the sequences with contrast showed numerous tortuous vessels in that area. So the patient underwent a cerebral angiogram confirming the presence of a dural AV fistula with multiple feeders, mostly arising from the right external carotid artery, draining into an isolated segment of the transverse sigmoid junction with significant cortical venous reflux, meaning a high-grade fistula. Treating this fistula with a single modality would be very challenging. The open surgical technique would be risky with high risks of hemorrhage. And endovascular technique, the transarterial route would be challenging with so many feeders, and the transvenous route would not be possible given the lack of endovascular transvenous access to this segment. So we opted in favor of a combined approach. Initially, we performed a small craniectomy to expose that isolated segment. This was guided by navigation and obviously anatomical landmarks. And this gave us access by performing a direct puncture to that segment and placing a microcatheter inside the isolated segment. After that, we could then do the endovascular part, which consisted of coiling that isolated segment and simply disconnecting the fistula and treating the fistula. So we can see here the preoperative and postoperative angiograms comparison showing the exclusion of the fistula with this combined approach. The patient had an excellent postoperative course. He was discharged home with no neurological deficits, and in a late follow-up, he also does not have any headaches. The second case is a 71-year-old female presenting with left eye redness and significant proptosis for 4 months with no cranial nerve palsy. She had a CTA done showing an early filling of the left cavernous sinus with a venous pouch draining into a dilated superior ophthalmic vein. This picture here also shows the significant left eye proptosis. The cerebral angiogram revealed a left indirect carotid cavernous fistula with a venous pouch draining into the superior ophthalmic vein, which was dilated. So for this case, we initially tried to treat with a standard technique, which is an endovascular technique, since it's less invasive. We first tried the transvenous route through the inferior petrous sinus. The microcatheter was in the cavernous sinus. However, there was no communication to that venous pouch that we saw in the cerebral angiogram. So it was not possible to treat through this route. We then tried to treat via facial veins route. So we placed the microcatheter in the facial veins. However, the vessels were very tortuous, so there was no access to the superior ophthalmic vein. Subsequently, we also tried the less invasive procedure, which was a cannulation of the superior ophthalmic vein. However, due to anatomical difficulties, we also could not get access to the fistula. So we did an open transcavernous approach. So the patient underwent a left pterional craniotomy with an expansion to the temporal side and also to the sphenoid wing by drilling those bones, and then peeling part of the middle fossa to expose the lateral wall of the cavernous sinus. The ICG injection showed where the venous pouch was, draining to the superior ophthalmic vein, which is located between V1 and V2. So we did neuronavigation confirming the position of venous pouch and punctured the venous pouch. Once we punctured, there was a significant arterialized blood reflux, and then we injected thrombin through that catheter, and then we treated the fistula. After that, we opened the cavernous sinus, confirming that there was no more flow into the venous pouch, packed and closed. So this was enough to treat the fistula. A post-operative angiogram was done, showing the exclusion of the fistula, and the patient had a significant improvement of the left side symptoms immediately after the operation in the recovery area. And she was also discharged home a few days later with no new neurological deficits. Combined approaches for derivative fistulas can be a good option when the standard techniques fail or when a single modality is not enough to treat the fistula. Ideally, these cases should be managed by dual-trained vascular and endovascular neurosurgeons who have a high vascular anatomical knowledge, are versatile surgeons, are able to combine approaches as needed, as we saw in these cases, and have no bias towards a single modality because simply the surgeons can perform both modalities. Also, this way we can keep a very good patient-surgeon relationship since we don't need to refer the patient to other teams. These were the references used in this presentation. And I once again would like to thank you to everyone watching and especially to the committee for this great opportunity.
Hello, dear colleagues. My name is Anton Konovalov, and I'm a neurosurgeon of Burdenko Neurosurgical Center, which is in Moscow, Russia. It's a great honor to me and my team to take part in the World Young Neurosurgeon Congress, and we would like to introduce and share with you our B-Guide, which is the novel neuronavigational device. I would like to start from explaining what the stereotaxy is. The stereotactical procedure is a minimally invasive form of surgical intervention that makes use of three-dimensional coordinate system to locate the small targets inside the body, especially inside the head. Of course, you know and remember the typical procedures: biopsy, radiosurgical procedures, ablation, and stimulation. Here is the B-Guide neuronavigational device. It's made of titanium and it's a 5th grade of titanium. It contains of few parts. The first one is the base. The second one is the clamp. Then we have the bushing, swivel, and the rod. It has adjustable parts and we can set up the incline and rotation of this device. It's fixed by medical drill, and with the 3 screws to the skull surface. The perspectives of usage this device are EVD, deep brain stimulation, biopsy, and other different modalities. Advantages of our device are high accuracy, which is proven by preclinical and clinical experimental models. It's easy to set up and use in navigation, so it's really small. It's kind of pocket neuronavigational device. It's safe, and because of titanium material, it's CT and MRI compatible. The method we use to get the data and use the device contains of 3 simple steps. The first one, we need to perform the device identification of the CT scan. Then we use the 3D navigation of the model of the device and perform the movement of instrumentation. Then we choose the target and located with the incline, rotation, and depth. Here is the step-by-step case presentation of EVD procedure. First, we fix the device with 3 titanium screws on the surface of the skull. Then, we perform the CT scan of the head of the patient with the device. After that, we acquire the DICOM data and perform the modeling procedure. Then we use the software to calculate the device setup, incline, rotation, and the depth of insertion of the EVD. And after the proper data, we perform the procedure. So the result of procedure is shown on the last picture. The software which we use, it's a real simple, and you can model any type of navigation with our device. It's a high definition images, and you can simulate the procedure and calculate the proper parameters of the device and navigation in this software. You can simulate the rotation and incline of the device, and it's calculated on the software, and you get the right angles of the device and can manage them in the OR. So let's imagine the case when we need to locate some small target within the brain. So we can use the simulation mode and create the sphere which we put inside the skull. On the video, it's shown how we create the target. Then we can put it in anywhere inside the skull and calculate the navigational data. So we use the 3-dimensional coordination system to calculate the position of the target. So let's say we have the small hematoma. So I would like to color it with a red color. And let's put it somewhere in the anterior horn of the lateral ventricle on the right side. As I said before, we use the 3-dimensional coordination system. So the plane Z is fixed by base of the device on the skull, of the surface of the skull. And we can adjust the X plane and Y plane and calculate the proper angle of the path to reach this target inside the skull. Here is our team of the Big Eye device. We really honored to take part in this World Young Neurosurgeons Congress, and we would like to share our experience. We're looking forward for collaborators, and don't hesitate to contact us via email. Thank you so much for your attention. That's it.
Dear colleagues, my name is Chernov Ilya. I am from Burdenko Neurosurgical Center from Moscow, Russia. Let me introduce you the results of our study, which was dedicated to usefulness evaluation of trigger electromyography-assisted transnasal endoscopic surgery of skull-base tumor. This study was conducted by us since 2014 to 2021. The first question is why we decided to do it. In the case of skull base tumor, the cranial nerves can cut the tumor surface or be in a rough fusion with tumor tissue. Therefore, severe variation of topographic and anatomical relationships take place in the area of tumor growth. This tumor often involves various cranial nerves in the pathological process. Removal of the tumors is associated with high risk of damage of these cranial nerves. So our objective was to evaluate the effectiveness of trigger electromyography in ensuring the anatomical and functional safety of cranial nerve during endoscopic and the nasal transfemoral removal of skull-base tumor. For that, we provided a retrospective single-center cohort study included 73 patients. The main group included 30 patients with various tumors of skull base and signs of cranial nerve involvement. All patients received endoscopic transfemoral surgery with neurophysiological identification cranial nerves. In control group, there were 43 patients, also with various tumors of skull base and signs of cranial nerves involvement, clinically or MRI signs. All patients in the control group were treated also with endoscopic transfemoral surgery, but we didn't use neurophysiological identification of cranial nerves. The groups were compared in regard to demographic data, tumor localization and size, clinical symptoms, features, and volume of surgery, tumor histology complications, tumor recurrence and progression, and tumor treatment results. In source data, there were no differences pre-operatively. To carry out neurophysiological identification of cranial nerves, we used 8-channel Viking Select neurotransmitter, and before the operation, we installed needle electrodes in the corresponding muscles according to the generally accepted methodics. Intraoperatively, we use mono and bipolar electrodes for stimulation and in trigger mode. Here, let me introduce you our algorithm of actions during endoscopic transnasal removal of skull-base tumor. First of all, we removed those parts of tumor where they definitely cannot be nerves or any other structures like vessels. And then we try to search the cranial nerves in the thickness of the tissue, and in the absence of answer, a more so-called bold removal of the tumor occurs. In the case of obtaining AMI responses from any cranial nerve, we used bipolar electrode for more precise location, and the removal of the tumor occurs either more delicately or doesn't occur at all in the case of dense fusion of the tumor and the cranial nerve during its visualization. Thus, it's possible to make a map of location of the tumor of motor cranial nerves in the operating wound. And here you see the green points, places where no any nerves, and red points, it's places where we find cranial nerve. And after removal of other parts of tumor, we use control identification of cranial nerve in order to assess their functional state based on the obtained physiological parameters. So what the results? First, what we saw was that more radical removal of tumor was achieved in the main group. Also, in the main group, the frequency of postoperative deterioration of motor cranial nerve function was 13%, and in the other group, control, the frequency was 37%, and this difference is statistically significant. Also, we assessed quality of life using Karnofsky scale before the surgery and in the follow-up. It turned out that in the main group of patients, the quality of life is statistically significantly higher, which certainly speaks in favor of using this technique. So, thus, the technology and algorithm of identification of cranial nerve during endoscopic transnasal removal of tumor of skull base extending into cavernous sinus and a clivus or pontomedular angle allowed us to significantly increase the frequency of radical removal without any increasing of frequency of complications. And even reducing it. Thank you very much. Goodbye.
Good morning, seniors and colleagues. Today, my topic of presentation is the effect of orbitotomy on surgical freedom in endoscopic transorbital approach to a skull-based anatomical study. Endoscopic transorbital approach is a minimally invasive approach to perform orbitotomy to a skull base in a direct anterior manner using the endoscope. It's designed to overcome difficulties in endolabial approach to the skull base by opening a corridor lateral to the ICA and cavernous sinus. As an alternative to craniotomy, it provided minimal morbidity, better cosmetic outcome, and minimal brain retraction. Since 2020, our team has performed more than 15 cases. One of the difficulties will be the limited space within the orbit, causing the orbital retraction-related morbidities. As such, we would like to know whether the surgical freedom could be increased by lateral orbitotomy. So what does the literature say? In 2010, Mo published the first case series on endoscopic transorbital surgery. In 2018, a Korean group, Kong, reported that with lateral orbitotomy, they could achieve a better gross total resection for spinoorbital meningioma. In 2021, Kim reported that with orbital retraction larger than 1.5 cm, there would be a dramatic increase in the intraocular pressure. But there is a limited evidence concerning the surgical freedom. As such, we conduct a translational study, started with cadaveric study, followed by the anatomical study, and finally application to the clinical cases. The cadaveric dissections was performed by Dr. Calvin at Paris in 2018. The first step is to perform a liquid incision to take out the orbital rim. The periorbiter was stripped and the orbital band was released. Sphenoid ring was drilled to expose the middle fossa dura. Then the anterior wall of cavernous sinus was split and the anterolateral triangle could be reached. Then in 2021, our team performed the anatomical study at QEH. The DICOM data was retrieved from 19 patients and was analyzed using the OSIRIS, and the pediatric patients were excluded. Target points were chosen to represent different intracranial compartments, namely the foramen ovale, the foramen rotundum, both of them representing the infratemporal fossa, the terminal end of the pitchous segment of the ICA representing the cavernous sinus, and the internal acoustic meatus representing the posterior fossa, and the 3D coordinates of each target point was recorded. 3 types of orbitotomy was simulated in the software. The group 1 represents the full orbitotomy involving the supraorbital and lateral orbital rim. The medial limit could be the supraorbital lodge or the frontal sinus. Group 2 represents the partial removal of the supraorbital rim and the lateral orbital rim. And the group 3 represents the removal of lateral orbital rim only. Group 4 has the intact orbital rim. Angle of attack were calculated with the equation as shown here, whereas the surgical volume was calculated by dividing the volume of inches into a triangular pyramids. Data were analyzed using the SPSS and the Excel. Primary outcome would be the horizontal angle, which is defined as the maximal horizontal angle from the orbital rim to a target point, whereas the vertical angle was defined as the maximal angle from the lateral orbital rim to the target points. Surgical freedom were given by the volume of the pyramid extending from the orbital rim to the target points. This is a primary outcome result, not going through each number in this table, and have summarized it in a graphical format for easy visualization for the interest of time. By removal of the orbital rim, the angle of attack increased significantly across all groups to the same extent. Whereas for the surgical freedom, could increase significantly by 3-fold with the removal of orbital rim alone, 4-fold with partial removal of supraorbital rim, and up to 6-fold with full removal of supraorbital and lateral rim. Secondary outcome was defined as the mean distance, horizontal angle, vertical angle, and surgical freedom in the group with intact orbital rim to provide a basic reference data set for the skull-based targets for ETOA. The data was as shown. Again, for reminder, the targets were chosen to represent different intracranial compartments for ETOA. So this is the first study of its kind. By orbitotomy, it could increase the surgical freedom, horizontal and vertical angles of attack significantly. The angle of attack is a different concept from the surgical freedom. The increase of angle of attack was the same across the three types of the orbitotomy, whereas with full removal of the supraorbital and lateral rim, the freedom could be increased up to 6-fold. As such, removal of lateral orbital rim alone is effective to increase the angle of attacks, whereas the area of the orbitotomy was a main determinant of surgical outcome. By increasing the surgical freedom, retraction-related morbidities could be decreased. For deep-seated lesion, we will consider removal of the lateral orbital rim to increase the angle of attack. Whereas for the design of the extent of supraorbital orbitotomy, one could consider the location, the size of the lesion, the pathology, and also the instruments needed to remove the lesion.
We finally apply the principles to our patient. This is a case of orbital apex cavernous hemangioma. This is a short version of the video submitted in the well surgery. This is a preoperative MRI, and we performed the liquid incision. The lateral orbital rim was removed, and this is the corridor that we gained by removing the orbital rim. The periorbital was stripped, and we divided meningo-orbital band.
And the sphenoid ring was drilled to expose the middle fossa dura, and finally the lesion was taken out. And this is a post-op CT, and we reconstruct the orbital rim using the mini plate. So in conclusion, in endoscopic transorbital approach, the extent of orbitotomy is the main determinant of surgical freedom. Removal of lateral orbital rim alone is effective to increase the angles of attack to skull-based lesions. When supraorbital rim is removed, surgical freedom could increase up to 6-fold. Orbitotomy should be customized according to individual cases and should be considered for deep-seated skull-based pathologists in order to improve the visualization and minimize retraction-related morbidities. And this is the end of my presentation, and I would like to thank the multidisciplinary skull-based team of my hospital for this great project. Thank you very much for your time.
Is negative. Construction, exceeding to any anesthetic speaker at the first word. Thank you for invitation and giving me the opportunity to be a speaker at the first World Young Neurosurgeon Congress. The topic of my presentation is aneurysm excision and end-to-end anastomosis for fusiform intracranial aneurysms. The surgical treatment of fusiform aneurysm included clip construction, clip wrapping, excision, and end-to-end anastomosis, trapping with or without bypass. The middle cerebral artery and the posterior inferior cerebral artery often have a redundant parent artery that allows primary anastomosis. So here we report 4 cases with fusiform aneurysm that treated with excision and end-to-end anastomosis. The case 1 is a 46-year-old woman presented with headache. The physical examination is negative. And the preoperative neuroimage scan showed a right MCA fusiform aneurysm. Paternal and transsemial fissure approach was performed. The aneurysm resection and end-to-end anastomosis was the first choice. A proximal occlusion and the ECIC bypass or ICIC bypass was prepared. The aneurysm was located at the superior trunk of the M2, and we performed the aneurysm excision and end-to-end anastomosis. The SCG confirms the patency of the flow. And the post-operative DSA also confirms the bypass patency. The arrow shows the bypass. And the second case is a 17-year-old male and suffer from headache and after trauma 1 month ago. The DSA demonstrates a left MCA fusiform aneurysm. And the DE showed the intraoperative photos and the post-operative CT scan. CTA confirmed the patency of the flow. And the case 3 is a 53-year-old male and suffered from cerebral infarction 1 month ago. And the DSA demonstrated a right MCA fusiform aneurysm. And the direct clipping is impossible, so we also perform the aneurysm excision and end-to-end reanastomosis. Case 4 is a 36-year-old man presented with dizziness for 2 months. Physical examination is intact. A CT scan shows a calcification of the aneurysm. The DSA demonstrates a left PECA fusiform aneurysm. And a surgical strategy was introduced as following: a reversed C-sharp incision, occipital artery was harvested, a lateral suboccipital craniotomy was performed. And proximal occlusion and the OA to PECA bypass was prepared. An aneurysm section end-to-end reanastomosis or IC-IC bypass was also prepared. And this is the intraoperative image. The occipital artery was also prepared, but we performed the aneurysm resection and the end-to-end reanastomosis. The post-operative DSA confirms the patency of the bypass. And the bypasses consists of the ECIC bypass, ICIC bypass, and combination bypasses. And the ECIC bypass included the low flow, medium flow, or high flow. And the superficial temporal artery occipital artery low flow bypass. And the ECA radial artery to MCA is high flow bypass. And the ICIC bypass also included the reanastomosis with or without interposed graft reimplantation and in situ side-to-side bypass. This is our treatment category for fusiform MCA aneurysm. The treatment strategies should be based on the nature of the aneurysm and the location, such as the pre-bifurcation, bifurcation, and post-bifurcation, and the involvement of the lenticular striatal artery, and the clinical status. If the patient, the aneurysm was located at the post-bifurcation, such as the M2 or distal, we usually perform the excision and anastomosis. And the surgical nuance for reanastomosis including the redundancy of the parental arteries, extensive mobilization of the transected ends, completed excision of the pathologic arterial wall, tension-free reanastomosis, interrupted sutures in a end-to-end fashion. Aneurysm excision and end-to-end reanastomosis is an efficient revascularization technique for fusiform aneurysm that have one afferent and one efferent artery, obviating the need for harvesting extracranial donor arteries. That the bypass strategy should be designed according to the aneurysm location, the parent artery, and the in situ donor arteries. That's all. Thank you.
Hello, everyone. My name is Zhi Fengxi from Department of Neurosurgery, Huashan Hospital, Shanghai, China. Firstly, I wanted to thank Professor Bing Shi's recommendation to join in YNS Awards presentation and wish First World Young Neurosurgeons Congress a big success. So my topic today is to report a novel radiomics method to assist in IDH mutant glioma surgery and the prognostic stratification. This is the outline of my presentation. I will report with 3 parts. For glioma surgery, it is the Bible that the extent of resection strongly correlated with longer PFS and OS. But there are 2 questions. The first one is how we define gross total resection. Is it enough according to post-operative T1 enhanced and T2 flare MRI? The second question is how we delineate the boundary of glioma during the surgery. It may be hard for us to answer these 2 questions in the past. However, with more and more understanding of molecular characteristics of gliomas, it seems likely to answer above 2 questions by using several important molecular biomarkers, like IDH mutant, 1p19q codeletion. This is so-called molecular surgery. We reviewed manuscripts introducing molecular biomarker-guided glioma surgery. It was found that IDH mutant lower-grade astrocytoma benefits from improving extent of resection, while oligotumor has no survival benefits from resection extent. In high-grade gliomas, we can see from this important paper published on Uro-Oncology, the correlation between survival benefit and the resection extent is based on IDH mutational status. For IDH mutant tumor, resection extent should be referring to T2 flare boundary. For these papers, IDH mutation is highlighted in guiding the glioma surgery. As we know, IDH mutation only exists in tumor cells rather than normal brain tissues. Thus, this kind of feature enable IDH mutation serve as a navigator to delineate biological boundary of glioma. Furthermore, it can be detected by a surrogate called 2HG on MRS. So all these findings supported the hypothesis that IDH mutation can be used in molecular surgery. But for the consideration of intratumoral genetic heterogeneity, distribution and intensity of IDH mutation varied a lot. If we plan to use IDH mutation as a navigator in glioma surgery, we should make it visualized and quantified. So we make 2 steps surgical plan. The first step is to realize the visualization of IDH mutation. The method we adopted is MRI-based radiomics approach. 795 pathological identified gliomas with IDH mutational status at the T1 contrast T2 flare MRI images were recruited in our study. By analyzing MRI images from IDH mutant cases and IDH wild-type cases, we established an IDH mutation prediction model. The accuracy of IDH mutation prediction by this model reached 95%, very close to real molecular pathology results, and only 3 minutes were required for computer manipulation. The second step is to separate a tumor into thousands of small mosaic lesions, introducing the model in the first step to calculate IDH mutational ratio of each mosaic. Then we can depict IDH mutation landscape of the whole tumor. With pseudo color technology, the visualization of IDH mutation can be present on MR images. The tumor can be segmented as a whole with 3D architecture view to observe the IDH mutational landscape. Cold color means higher mutational ratio. Heat color means lower mutational ratio. This is a demonstration of IDH mutational landscape in IDH mutant tumor and IDH wild-type tumor. However, what we see above depends on computation. In the real world, we need to verify whether our theory is true or not. So we launched a prospective study. Before tumor resection, tumor tissue with different IDH mutation ratio were taken out by frameless stereotactic biopsy and the neural navigator based on IDH mutational landscape. Informed consent was obtained from 18 patients. This is a grade 2 IDH mutant astrocytoma case. Tumor tissue from both cold color and heat color location was taken out separately for further biological analysis. We detected 2Hg expression by mass spectrometry. We can see in cold color tumor, 2Hg expression is high. Vice versa, 2Hg is low expressed in heat color tumor. From histology perspective, tumor density and the vascularization is low in cold color tumor. This result was seen in 17 out of 18 cases, which demonstrated our computational method is accurate to visualize IDH mutation. This is histology pictures of these two tumors. Furthermore, we use overall survival analysis to in-depth validate our findings, as survival has always been golden standard to prove the efficiency of a new method. In our method, IDH mutational ratio features can be calculated quantitatively, so we attempt to use it as a prognostic biomarker. As seen in the results, IDH MRRF positive patients live longer than negative counterparts. It can also further stratify patients' survival within IDH mutation or wild type, which is in accordance with molecular findings in most updated C-Impact Now reports. And last, we explored that by using quantified IDH mutation on MR images can work as a precise follow-up tool compared with conventional MR follow-up, with advantages of more quick and less manpower consumption. In the conclusion, IDH mutation can work as a molecular guidance for glioma surgery, no matter for biopsy or tumor resection. Our normal radiomics method provided an approach for IDH visualization and quantification based on MR images. It can be used for surgical navigation, prognostic stratification, and clinical follow-up in glioma patients. However, there are several limitations in our study, like the small sample size and not reflecting the whole brain images. In the future, a prospective clinical trial should be designed to validate the efficacy of IDH mutant visualization in glioma surgery. That's all for my presentation. I would like to thank my colleagues in Huashan Hospital and my collaborators in Fudan University. And much thanks for your attention. Hope young neurosurgeon fellows can visit our new campus in Shanghai in the near future. Thanks.
Thank you very much, all the participants of the Young Neurosurgeon Award session. I think all the awards had a fantastic papers and very difficult topic, very difficult topic. I remember in my resident time, I used to make presentation like 1 Burhole versus 2 Burhole for chronic subdural. But this is the level of understanding and improvement in the young neurosurgeon has got today. Few of the very tough and difficult topics presented by the young neurosurgeons today. Dr. Alberto and Dr. Abida Shah was there. Dr. Alberto, you want to say anything?
Thank you, Sachin. Yes, I also enjoyed very much all the presentations, very difficult topics, as you say. I have a question actually, but I don't know if Dr. Chernov is online. Anyway, I will just say a comment about his talk. It's very interesting because he mentioned about neuromonitoring during transnasal surgery. Some people are concerned about the fact that neuromonitoring, of course, from one point of view, can improve the outcome, neurological outcome. But some people are concerned about the fact that using monitoring can actually reduce the extent of resection of tumors. But his presentation actually showed the opposite. So I think it's an important message to deliver. So neuromonitoring is helpful not only to preserve function, but also to help extending resection. My question was about, the kind of nerves that he monitored. I'm just wondering whether this improvement in nerve function is equal comparing different nerves, or if he noticed different extent of improvement for different nerves.
I'm not sure. Yes, you wanted to say something, Dr. Alexander? You are muted. Can you unmute yourself, doctor?
Hello, dear colleagues. My name is Dr. Chernov.
Oh, okay, nice. So you are online. Nice to see you. Yes, my question. I don't know if you got my question. So
no, can you repeat it, please?
Okay, so congratulations for the nice presentation. I said you showed that neuromonitoring is important not only to improve the outcome, neurological outcome, but also to improve the extent of resection, which is often debated. So I'm very happy that you showed these results. My question is, you showed an improvement of function for cranial nerves after using neuromonitoring for your operations. My question is this improvement equal? So is it the same comparing the nerves you monitored, or did you notice that some nerves have a better improvement compared to other nerves?
Thank you for your thank you for your talk about my deliver. So yes, there is such correlation between those nerves which were identified intraoperatively and those which improved in their functional status. And we noted that the extension of radicality really improves because we know where we can remove tumor without any dangerous impairment of cranial nerves. You notice it, and this is really important for us. And about your question, yes, it has been correlated between those nerves which did find and those which improved in status. Yes.
So some nerves can better improve compared to other nerves in your experience?
In our experience, much better improved. It was the third nerves, third, because the abducens is a very weak nerve.
Yeah. delicate. Yeah.
And third nerve, it really have potential for restoring its function after operation and after decompressing the carnosinus structure.
Thank you.
Thank you. Thank you. And I'm sorry, from this notebook, Alexander Gonovalov is ready to deliver his message.
Thank you very much, Dr. Cherno. And do we have any other questions from the participants or from the panelists? You wanted to say something? If not, we've got just 6 minutes before we're going to start our next plenary session by Dr. Alexander Konovalov. May I request Professor Yobukato to make a few comments about the presentations by the young neurosurgeons today? You want to say anything,
yes,
Professor?
I thank you so much. All the speakers, all talk were excellent, I think. Of course, the contents and the thinking way, and also the beautiful slide is another important factor, I think, to judge. And I think such kind of the motivation and such kind of the research mind is very, very important in the future career. We are all expecting here the future successful perspective the year. Thank you. Thanks so much.
Thank you very much, Professor. We're just 5 minutes away from our next talk, although Dr. Alexander Konovalov is already joined.
Dr. Albert, Dr. Ishu or Dr. Sandeep is with us now, or?
I didn't see.
Yes. Oh, 1 second. Alexander Galaevich is right here. It is his time, yes or no?
I think 5 minutes left before.
Yes.
Yeah.
Okay. Thank you.
Thank you.
Just 5 minutes.
Maybe meantime you can share your screen and check the technical issues, if everything is okay or not. Dr. Cherno, are you there? Yes.
Yes, right
okay.
now
Yes, we can see it. Yes.
Okay, very good.
Perfect.
Через 5 минут можно начать.
Они сами включат?
Уже нет, вы будете начать.
Через 5 минут.
Ну просто можно через 5 минут просто начать.
So although just a reminder that the certificate will be given to the plenary one session after you sign up the evaluation form, and I will post the link in the Q&A chat box.
Very good. Thank you, Ben.
I think should we have some promotion the video, maybe if you have a time.
Yes. No problem. I can. Hello, everyone. For this plenary session, for the young neurosurgeons, deep-seated tumors, especially the tumors at the thalamus or at the genu towards the internal capsule, this deep-seated tumors is always a great challenge for the young neurosurgeon to operate. Most of the time, we are left with only possibilities of just biopsy. But today we have Professor Alexander Conallo, who's going to talk with us about the microendoscopic surgery for the tumors which are situated deep and which are hardly accessible. So over to you, Dr. Alexander Conallo. You can share your screen and start your presentation, Doctor.
Саши, а там еще разом. Саши. Dear Dr. Sashin, dear friends, dear Yuka Kata, Yuka Kata asked me to present a lecture about microsurgery of deep-seated tumors and hardly acceptable tumors. I have to say that I started microsurgery just half a century ago. But I vividly remember the time where the neurosurgeon doesn't use microscope, doesn't use some microsurgical technique, and I can compare results. So microsurgery made practically a revolution in our specialty. The second short comments, I have say some words about the Institute of Neurosurgery, Moscow Institute of Neurosurgery. It's the largest neurosurgical place in previous Soviet Union and now in Russia. And all this time, for a long period of time, we gathered patients with difficult neurosurgical problem, mostly with brain tumors. And nowadays, every year we perform about 6,000 surgeries in patients with brain tumors. Да, не работает. I'm sorry, some small problem. Не работает. Сейчас. In the beginning, I have to say that microsurgery is not only how to use microscope, how to use special instrumentation. It's also very important to know the microanatomy of the brain. Nowadays, in your disposal, there are many very good atlases, books, and especially Rotten experience in microsurgery. But when we start our using microsurgery, we have to investigate microsurgical structure of the brain ourselves. You can see on the slide some examples of these preparations. The second point, which I also have to mention, is that dealing with the brain, using microsurgical instrument, you can perfectly know the internal structure of the brain, and especially the more important ways, pathways, such as pyramidal tract. And of course, modern neurosurgery, microsurgery, is also the control of the more important functions of the brain, especially when you try to remove tumor is such important and big structure as the brain stem. Now, a few very short comments about surgical approach. my understanding is that the surgical approach has to be strictly individual. Every neurosurgeon has to select approach according to knowing the pathology, according to the data which is investigated, I mean MRI, CT scan. Nowadays, the important brand of neurosurgery is keyhole surgery. In my understanding, keyhole doesn't mean the smallest approach, small trepanation. The approach has to be as small, such small that he can permit neurosurgeon to fulfill his main task, to remove the tumor completely or other lesions. And the size of the approach depends on the surgical technique, on the experience of the surgeon. So in every case, surgeon himself have decided which kind of approach he can use, what side of the approach have to be. The second comment is about the retractors. Nowadays, many surgeons prefer operate without retractors, producing the space for the surgery with two main instruments, aspirator and bipolar coagulation. But my opinion is that retractors, which were previously suggested by Yazargil, is still very important. But you have to use it just to hold the brain in convenient for certain position, not retract the brain, but just hold it in a relaxed brain in the necessary position for the neurosurgeon. Of course, such instrument as CUSA is of special importance when you deal with the deep-seated tumors. And a few words about navigation. Today, you heard a lecture about the navigation. Sometimes we use it. Of course, it is very important, any kind of navigation, including ultrasound navigation. But when we deal with deeply localized tumors, usually there is such very important anatomical structure which can help you to find the position of the tumor. I mean such structures as falx, as tentorium, foramen Monroe, and so on. When you use microsurgical instruments, it's very important that your hands will be relaxed. There are some devices which help you to relax your hands, but my experience shows that it's just enough to touch with your small finger solid surface, and your tension will be removed, and your hands will be relaxed. You can do very fine procedure. Now, one, for my opinion, very important comments. At the emotional part, emotional side of the microsurgical operations on the brain, when you use a microscope, under the microscope, you can see fantastic work of the structure of the brain. Small vessels, arachnoid structure, arteries big and small. So altogether, it resembles me the fantastic picture which you can see in the coral water, in the coral sea. And this emotional feeling, for my opinion, is very important. It's make you to be precise. That your movement will be fine, and you shall try to do your best, not destroy this fantastic world which you can observe under the microscope. I start a presentation of some cases of deeply seated and difficult for surgery tumors with craniopharyngiomas. Craniopharyngiomas are tumors which present very serious problem for radical removal. But in previous time, only a radical removal was the way how we can help patients, how we can treat them. Nowadays, in our disposal is also focal radiation, so not always it's necessary to reach complete resection of the tumor. But anyhow, this surgery still is very, very difficult because of the size of the tumor. You can see on the slide some examples. The tumors, craniopharyngiomas, may be solid, may be cystic, might be mixture of solid and cystic part, and they spread in different directions. So remove this tumor present a very serious problem. At the Institute of Neurosurgery, I was lucky during my long surgical life, operate about even maybe more than 1,500 patients, cases of craniopharyngiomas. But for me, there are two main groups which present a special problem from surgical point of view. I mean, giant cystic craniopharyngiomas, mostly pediatric pathology in small children. There are many ways how you can treat these tumors. Using the ACNS for the evacuation, the cystic contents, brachytherapy with radioisotopes, with bleomycin and some other medicines which you can put in the cyst. But this method, in my opinion, are not effective enough. So the best solution of this very serious and very difficult problem is to try to remove the capsule of this cystic tumor as radically as possible. It's exciting surgery. It's need from neurosurgeon sometimes hours of meticulous work of separation of the capsule of the tumor from the optic nerves, from the carotid arteries, branches of carotid artery, and other vessels. But finally, you can reach, in my majority of cases, quite radical removal of the tumor. And if it will be recurrent at some place, you leave some piece of capsule and it produces recurrence, so you can use focal irradiation of the recurrence. Another example of such kind of surgery. You see another large cystic tumor, and here we will show you some stages of the surgery. In the beginning, you can see evacuation of the cystic fluid. Now the separation of the capsule of craniopharyngioma, calcified capsule, from some important structure, from oculomotor nerves, as you can see here. Meticulous preparation permit you to finally solve such, fantastic picture as the base of the skull, basilar artery, and craniobasal nerves. The second group of difficult craniopharyngiomas is third ventricle craniopharyngioma. Quite, it is rare when they just occupy only third ventricle, usually spread outside the third ventricle in the basal system. When I start my neurosurgery, before microsurgery, removal of the third ventricle tumors are considered as untreatable pathology. But nowadays, when we start to use microscope, we can practically every day remove patients with such kind of pathology. Just several words about the craniopharyngiomas, which mostly are localized in the third ventricle. There are two main approaches how you can reach it and how you remove this kind of tumors. You can see here a tumor of the subventricle. Sorry, subventricle tumor, and you see the chiasma region. It's very much distorted. You can differentiate not optic nerves, not chiasma, but when you remove the cystic part of the tumor, you can see the normal position of the chiasma and optic nerves. So these tumors, I mean tumors which localized in the subventricle, can be successfully removed with the approach through the lamina terminalis, with subfrontal way or with interhemispheric approach. Look at the final stage of the surgery. After the radical removal of the tumor, you can see basal artery, brainstem. So it means that the tumor was completely removed, not only from the subventricle itself, but also in the basal system. And second way, which we use very often, is the removal of the subventricle craniopharyngiomas, but other kind of the subventricle tumors through transcallosal approach. A transcallosal approach, when you penetrate in the lateral ventricle, permits you to remove the tumor from one foramen Monro, from both foramen Monro, from the roof of the subventricle by splitting fornices, or using another way, so-called subchoroidal approach. I will speak about a bit later. So you can see the case of craniopharyngioma, which completely closed the foramen Monro in the beginning of the surgery, and final picture when the tumor was completely removed from the subventricle. Again, you can see the pons, basilar artery, and the telocell Tursk. I shall continue my talk about the subventricle tumor. Nowadays, we have a large experience in removal of different kinds of subventricle tumors. I just show you some examples and try to explain why you select such approach and what are indications for these approaches. Transcallosal way. Permit you to remove tumor from the foramen Monro. As usual, subventricle tumor enlarge foramen Monro, you are able to remove even giant tumors, as you can see from this relatively small hole. Even giant tumor, you can slowly make smaller and smaller, just cutting the tumor structure and cutting also the small cysts which are inside of the tumor. And slowly the tumor became smaller, and finally you can remove in giant tumor, which you can see in the beginning through the foramen Monro. In other situation, a giant glial tumor, pilocytic astrocytoma is benign tumor, occupying a very large subventricle tumor. And again, a transcallosal approach through the small hole in the corpus callosum permit you, through foramen Monro, to reach a radical removal of this tumor. We see such example. But even the tumor not only occupies the subventricle, but grows from the optic nerves, and you can't be absolutely radical to preserve vision. Even partial removal permit you to reach very bright success. I can show you one of these examples. You see small boy with hypothalamic glioma before surgery, very exhausted boy with cachexia. 3 months after surgery and 11 years after surgery, absolutely normal young boy. The transcallosal way permits you radically remove colloid cyst of the third ventricle. Colloid cyst of the third ventricle, it is illness which may result in sudden, very serious complications and even death of the patient because of the acute occlusion of CSF pathways. In my opinion, the best way how you can treat this pathology is radical removal through the transcallosal approach. Nowadays, also many neurosurgeons use endoscopic approach, an endoscopic removal of colloid cyst. But my practice, now about 500 cases, you can radically remove these lesions without serious complications. I show this example of third ventricle tumor in small boy just because in this situation it was used unusual approach through fanticulus. Through fanticulus, you open the skull and after that resect such quite a big hairy papilloma of the third ventricle. Now, briefly again about the other group of the deep-seated tumors. The tumor in the region of the pineal gland in posterior part of the third ventricle. Oh, sorry. So, excuse me. I continue as we talk about the transcallosal approach. When you use transcallosal approach, you can also penetrate in the third ventricle behind the venous triangle under the through choroidal fissure. You see wide open on the special preparation, wide opening the practically all cavity of the third ventricle. Using this approach, you can Using this approach, I'm sorry, you can see completely the lateral part of presentation. There is large tumor of the third ventricle which penetrate in the posterior fossa. This tumor was radically removed, completely removed through this approach. I shall continue possibilities of transcallosal approach. It permits not only remove tumor from the third ventricle, from subcortical structure, I will speak about that later, but also from the lateral ventricles. I show you very difficult kind of pathology. It is neurocytoma of lateral ventricles, lateral ventricles who start to grow from the septum pellucidum. Look at this picture. Giant tumor which occupy both ventricles and spread inside the third ventricle, infiltrate the walls of the lateral ventricles. Usually, this tumor is highly vascularized and incorporates the plexus in the tumor tissue. But anyhow, using transcallosal way, you can reach a radical, as in that case, removal even such giant tumors. Now, I shall speak about other group of the deep-seated tumors with localization localization in the pineal region in posterior part of the third ventricle. In this small region, this small region is the place where the different kind of tumor are happen, such as tumor growing from the pineal to pineal gland, pinealoma, pineocytoma, pineoblastoma, germinative tumors, germinoma, ependymoma, meningioma, and glial tumors. Many different approaches are suggested how to reach, how to remove this tumor. Mostly now we use two main approach, occipital, interhemispheric, and supracerebral approach. I can show you some example how it's better to select appropriate approach to this to tumor of this localization. Опять. As this surgery is usually performed in the sitting position of the patient. I shall speak about some problem of this position a bit later. As I mentioned before, there are two main approaches. One is interhemispheric occipital approach with dissection of the tentorium. Large tumor can be successfully exposed. You can see very well the posterior part of the tumor before surgery and completely removed. Other approach is infratentorial approach, on the surface, the cerebellum. It's nowadays we mostly use this approach because he is very convenient and permit you to observe veins, important veins such as galenic vein, basal veins in the final stage of the surgery, and usually very accurately separate them and preserve these very important vessels. But when you operate this midline incision, opening both lateral sinuses and confluence of cilium, it is dangerous to get such complications as air embolism, because sometimes the small veins in torculus region can be torn, and it result in the air embolism, very serious complication. That is why now we prefer to use lateral approach, even for the large tumors. Lateral approach under the transverse sinus permit you also radically remove even giant tumors of this localization. Look, before surgery, very spread tumors, teratoma, which occupied not only, of course, posterior part of the third ventricle and pineal region, but spread outside. But supracerebral approach permit you to be successful even in such very uneasy situation. And I shall repeat that in every case, you have select the more appropriate surgical way, thorough investigations, MRI picture, CT scan films to select the more reasonable approach to the tumor. Look at this very unusual case. Giant tumors, which occupies the practically whole the third ventricle. It penetrates through the very large aqueduct in the fossa posterior. On this reconstruction in red, you can see the spreading of the tumor. That's the ventricle part and fossa-posterior part. In this situation, I select the approach through the fossa-posterior. You see in the beginning the typical typical elements of teratoma, hairs. And I remove the relatively small part from the fossa posterior, and after that, through the very large aqueduct, was able to resect the whole, the big tumor from the third ventricle. And through the very large aqueduct, you can see some structure of the third ventricle, fornix, and foramen Monroe. Another situation, look at that picture. You can see a relatively small tumor which localized behind the quadrigeminal plate. What will be your solution? How you can reach and remove this tumor? In this situation, the decision was quite simple. Through the midline incision, the quadrigeminal plate, you see the hole in the quadrigeminal plate. The tumor was radically removed. What is the most important is that after surgery, all movements of the eye of the patient was absolutely normal. In some cases, you have to use combined approach, because with one approach, it's sometimes difficult or impossible to remove completely the tumor. Look at this kind of the tumor. It's localized, it's a glial tumor in the posterior part of the third ventricle in the aqueduct. So, so in the beginning, I reach and remove the excuse me, there's something. You see the upper. Ну что? Как не кликать? Что? А я не могу. I'm sorry. So you can see ourselves because I always change the position of slide. The upper part of the tumor was successfully removed with supracerebellar approach, and the posterior part, which penetrated in the aqueduct, was removed through the large aqueduct, and through it you can see some structure of the third ventricle after radical tumor resection. I just show how our results change in this group of patients with tumors localized in the region, spinal gland region and posterior third ventricle region. Nowadays, we operate practically without complications. But in the beginning, when we started the surgery, it was quite risky. A few words about the tumors which are localized in the thalamus, the subcortical nucleus, how they can be reached, how can be approached. And anterior thalamic tumors, you can see such examples on the slide, can be removed again with transcallosal way as on the side of approach, or also using contralateral approach. A contralateral approach, even sometimes more preferable because it permits better to expose the tumor on in the opposite hemisphere. when you deal with tumors which localize in thalamus, in subcortical nucleus, and especially important to know the position of pyramid tract. We always use the stimulation of the tract during the surgery, trying to preserve, not disturb it during the tumor removal. Very difficult case, a tumor of basal part of the thalamus which penetrates in the middle brain. In this situation, for our opinion, the best approach through the incision of temporal lobe and through the lateral through the temporal horn through the subchoroid fissure, we can reach the surface of the lateral surface of the tumor and remove it quite radically. And another example of how the tumors of the subcortical nucleus can be resected. Again, in this situation of special importance is knowing the position of the pyramid tract and stimulation during the tumor removal. The tumor was approached through the insula. Again, quite briefly, I can explain my attitude to the brainstem tumors. From the time of the Virchow, there was understanding that all the brainstem tumors are infiltratively growing tumors. But when MRI and CT scan start to use, it became evident that there is some group of the brainstem tumors which are very well circumscribed, which are focal, which be quite radically removed. On this slide, on the left side, you can see the typical diffuse tumor of the brainstem. You can differentiate under the microscope the cells of the brain of the tumor and some structure of the brainstem. On the right side, you see the typical expensive growing focal tumors, eloid astrocytoma, which just displace the structure of the brainstem, not seriously damaging them. The infiltrative growing tumors of the brainstem, it is a pity there is a more common pathology, and especially in the region of the pons. You see some picture of such tumors which infiltrate the pons, and it is a pity that till now we have no solution how to treat this patient. No chemotherapy, no irradiation are helpful. They can just for a short period prolong the life of the patient, but the result is always very pessimistic. But there is other group of the brainstem tumors, about 20–25%, which can be successfully surgically treated. These tumors are nodular, very well circumscribed tumors, and with cystic component or without cystic component doesn't important. Tumor with exophytic growth and spinomedullaris tumor. I shall present you some examples of removal of the brainstem tumors. But the most important is according to precise localization of the tumor to select a necessary approach. There's a lot of different approaches according to localization of the tumor. You can see some of them: perineal, subtemporal, presigmoid, retrosigmoid, transpyramidal, suboccipital, supracerebral, and so on. In every case, you have to select appropriate approach. And especially in this group of tumor, it's of special importance to use control of the functions of the brainstem, such as somatosensory and motor evoked potential, audio evoked potential, and especially mapping of the cranial nerves of the brain, motor nerves of the brainstem. It is important because in the beginning, look at the right side of the slide, the brain, the stem is so distorted with this tumor, so it's very difficult to find any anatomical structure in the beginning. Just several premises how you can remove different kind of the brainstem tumor. Look at this young boy. He suffered from the relatively small tumor, but localization of this tumor is very dangerous, just inside in the middle brain. It was not easy to select the appropriate approach to this tumor. And analyzing MRI films, we decided to remove it using subchoroidal transcallosal approach through the posterior wall of the third ventricle. And this tumor was practically completely resected, and you see no serious damage of the middle brain after surgery. Another example, young boy with a tumor of the middle brain and the giant cyst in the thalamus. And again, in this situation, I select the transcallosal layer, and through the cyst, I was able to radically remove this tumor from the middle brain. And again, I show this picture, the small boy, and 12 years after the surgery. A tumor of the midbrain, which was resected with lateral supracerebellar approach, with also very impressive result. I mentioned before that there is a group of the patient with exophytic kind of the tumor which grows from the brain stem. In this situation, the large tumor you can see on the left side originate from the medulla. It is a pity that the lateral part is covered with the picture. You can see it. The tumor was radically removed. You can see only small remnants in the region of the medulla. And last presentation, again, the tumor of the medulla before and after surgery, more than a year after surgery. And there is also the group of the tumor, which called spinomedullary group. They are not really brainstem tumors. They start to grow at the upper part of the spinal cord and displace medulla upper, growing into the posterior fossa. This tumor also have to be radically resected. Look at the very distorted spinal cord and on the level of the medulla. And after histological examination of pilocytic astrocytoma, after surgery, you see practically normal spinal cord, a normal situation in posterior fossa, and young boy with some complications, but very small. And here I can show you the result, our experience in the treatment of the brainstem tumors. In the beginning, the results were quite poor, mortality rate was high, but now, when we know how to select patients for the surgery, how to remove this tumor, which approach we can use, our number of complications is very near. Microsurgery reached fantastic successes. Mostly very bright neurosurgeon improved microsurgical technique. You can see the portraits of such, probably the best, very famous neurosurgeon of our time. I shall mention just Gezer Gulik, who suggests controversy system. It's microscope which permit you to change position, to change illumination, and so on and so on. It's change and make practical revolution in our specialty. But I have to say that the microsurgery is still developing. My disciples, my assistant, Professor Pischilauri, developed some adjustment for the controversy microscope. Look at this. It is such a helmet with the movement of the head, movements of the chin and lips. He every time can change position of the microscope, change the illumination, change the focus. So every time when under the any magnification, he very clearly can see the subject of his surgery, always in focus. Microscope is moving around the small trepanation in the skull. So even small opening, nowadays, Professor Pischilauri, he operated 1,000 patients with his technique, may remove even very big, very giant tumors just to the bar hole. But previously, I can say what permits to do this new microsurgical technique. Look at this case. It is large glial tumors in which the middle cerebral artery and all branches of middle cerebral perforating artery are incorporated in the tumor. But Professor Pischilauri was able not only completely remove this tumor, but preserve all these very tiny, very small perforating arteries. You can see in the left side below, with very good physiological result after the surgical removal. And now he very widely used bar hole surgery. So just from the bar hole, he is able to remove tumors, any localization, posterior fossa, temporal fossa, acoustic neurinomas, and so on. But look at the upper picture. It is giant tumor of the frontal lobe and hypothalamic region, which was radically resected with this technique just through the bar hole in the frontal lobe. Finally, I have to say that microsurgery reached fantastic results. Many tumors which previously was untreatable now are maybe successfully removed. But what is the most important, that microsurgery is still developing. It became some more and more technically improved. Thank you very much for your attention.
Thank you very much, Professor Alexander Kanalov. That was definitely very enlightening surgery. I have trained, my basic MBBS was in Ryazan, that is just around 200 kilometers to Moscow. So I've seen the Neurosurgical Institute where you are doing the neurosurgery and all. So thank you very much for this exceptional talk. I just have one question. Is most of this tumor, which are in the third ventricle tumor, especially, and especially in the children's of 10 to 20 years of age, whenever I have operated for the transcallosal approach, I've always noted there are a lot of veins going from the dura and veins over the brains, over the cortex. So how to handle this vein and enter the transcallosal without doing any damage, Professor?
Что в подходе к опухоли острой с наличием тренирующих вен, с оболочки там и так далее, как избежать проблем?
Excuse me, probably I not exactly understand your question. You ask about transcallosal way, how to preserve the damage of the veins. You see, with experience, usually it is enough 2 centimeters wide between veins to reach and remove any kind of tumor with transcallosal approach. But you can enlarge the space by separating veins. But practically in all cases, are able to preserve veins in this region. But more serious and more difficult are venous lacuna, which were very large in these places because of high hypertension. But you just clip or just suture the walls of these lacunas, venous lacunas, and it permits you to fulfill your transcallosal approach. Transcallosal approach I started to use practically 50 years ago, and for my experience, I use it several hundreds times, and always are satisfied with this route.
Thank you very much, Professor. Are there any other questions from the panelists? Professor Dr. Abhida Shah is there. Dr. Abhida Shah, you want to ask any question?
Hello, Professor Konalov. I'm Dr. Abhida from India, and that was a fascinating talk. I'm especially interested in intraaxial brain surgery and a lot of surgery for deep-seated lesions. And it was amazing how you have done all these tumors with whatever you had at that time. Sir, I would like to ask you, what is your strategy for insular gliomas, low-grade insular gliomas who present with one episode of convulsion? What would you do?
Спрашивает о инсулярных глиомах. Что вы делаете в настоящее время, когда имеется в виду при эпилепсии?
You see, I probably not exactly understand your question. You ask about the insular glial tumors, yes, or the tumors middle part of the temporal lobe which produce just insular tumors.
Just insular.
I mentioned that experience of my assistant, Professor Piscarouli. For my opinion, he made fantastic work. He has his own technique with 2 instruments. without spatula, he was able to completely resect this tumor and separate even very small perforating arteries. That permit to reach radical removal even you see it is infiltrative but benign tumors and reach very good results.
Thank you, Professor.
Thank you very much, Dr. Abida Shah. Dr. Ben, you want to ask anything?
Yes, and I saw that thank you, Professor, for your excellent talk. And I saw that many of the cases you do it in a sitting or semi-sitting position. So how would you cooperate with your anesthesiologist to prevent of the complications? Can you share some tips so that we could discuss with our anesthesiologist?
You see, nowadays, we operate patients in sitting position only with tumor which are localized in the pineal region. All tumors of posterior fossa are operated in lying position. But to prevent iron embolism, there is many ways how you can do it. Our anesthesiologist will use this method. But I mentioned one, from my point of view, very important trick. When you don't use middle line approach and use lateral approach, in this situation, you don't damage the confluence and small veins which goes to the confluence. And in our experience, hundreds probably cases with lateral position, we can see such a complication as iron embolism.
I see. Thank you so much, Professor.
So, Professor Konovalov, thank you very much for your great talk, as always. I still remember so many occasions I visited Budenko Institute, and also I have so much memory of the late Professor Potapov. Almost 1 year has passed already. So anyway, the Asian neurosurgeon, we all thank to your contribution to the huge education, in especially the difficult surgical techniques. My question is, in the future of the brain tumor surgery, I think, do you think it's becoming more minimally invasive, such as the usual use of the endoscope or some other modalities? How do you think about? Just let us know.
Dear God, thank you. I'm very glad to see you again.
Yes.
By television, but that doesn't matter. You see, developing is not only microsurgery. Endoscopic neurosurgery very fastly developed. Probably they has even better features than microscope because you can improve with endoscopic technique much easier than microscope. And in our clinic, we use it quite often. Mostly practically all basal tumors, chordomas tumors, clevus tumors, craniopharyngiomas. We use exposed basal transphenoidal enlarged approach to remove this tumor, even from the third ventricle. Now the situation changed. We use also assistance, endoscopic assistance in every kind of surgery, if it is necessary, of course. So my opinion is that endoscopic way is vastly developing, will be very important tool in modern neurosurgery, future neurosurgery.
Thank you so much. We will visit you again and again in the future. Thank you. Vladimir Benesh, please make some comment or some question to Konovalov.
Well, I've known Professor Konovalov for many years, and I always admired his work because it was something really special. The tumors he's resecting are really lesions which one gets aved, and one really is always afraid to deal with. So just congratulations on his surgical work, and just glad that Sasha was able to disseminate his knowledge throughout all the neurosurgical community, because he's been attending all the congresses. As far as I remember, he's been twice vice president of YNS, and he was always the most prominent neurosurgeon in Russia. So thanks for the lecture. I was very, very glad to hear it again.
Thank you. Thank you so much.
Sachin?
Закончил, да, слово.
Thank you very much, Dr. Vladimir Benes and Dr. Alexander Konovalov, for the excellent talk. You showed us few of the very difficult cases and explained us very in a more easy way how to approach this tumor and give better outcomes. So with that, I think our time is over and we have to move on to our next session. So our next session is Professor Vladimir Benes' session for skull-base surgery. So I think he has already submitted all the videos. Ben, yeah.
Hello, everyone. It's a great pleasure and honor to talk to ACNS members. And since I know that those are mostly residents, this is going to be an educational lecture. I'm going to talk on arachnoid membrane, mostly in skull-base surgery. I have nothing to disclose. And considering arachnoid or skull-base, we are in two spaces. In vascular, especially aneurysms, we are subarachnoid, in subarachnoid space. In skull base, model disease meningiomas, we are in extra-arachnoid. It's extra-arachnoid surgery. We want to lift the arachnoid, not to cut the arachnoid, open the cistern as long as possible. And we want to preserve the membranes because they form something like a border of dissection or plane of dissection. This is the vascular surgery, obviously, aneurysm in the carotid cistern, ophthalmic aneurysm. To the left, you see the optic nerve. And in order to clip the aneurysm, you need to dissect the arachnoid, sharply dissect it away from the aneurysm and away from all the structures you need to see. Actually, you can dissect the whole vascular tree, whole circle of Willis. You see here from basilar artery, both P1s, both posterior communicating, middle cerebral, anterior cerebral, ACOM complex, and you can get even to the opposite side from one single approach, frontolateral or pterional, doesn't matter. You can clip all the aneurysms in the upper basilar tree and in a whole circle of Willis, with the exception of distal anterior. The opposite is true for meningiomas. It is a similar location. We are in Sella turcica, and you want to stay within the chiasmatic cistern where the tumor is located. This is the tumor optic nerve, and this is the outer wall of the chiasmatic cistern. If possible, you do not need to penetrate that. You want to remove the tumor if it's single cistern tumor, which these tumors usually are, and preserve the walls. The reason behind this is well depicted on these two olfactory groove meningiomas, which are identical in volume. The difference is the edema, in this case unilateral, in this case bilateral, and in the position of the anterior cerebral arteries. Here you see that they are moved to the opposite side. In this case, they are in the midline. And on this graphic depiction, it's nicely seen that the left frontal lobe, even as well as olfactory nerve with olfactory systems, are covered and protected by several layers of arachnoid. On the other side, if the anterior cerebrals remain in the midline, then it's only single arachnoid wall covering the olfactory nerves and frontal lobes. the tumor is, let's say, like unilateral, or the anterior cerebrals are shifted, you see that at the end of the resection, the opposite side olfactory nerve is nicely preserved along with its arachnoid sheath. We've published that, and actually with unilateral approach to olfactory groove meningiomas, we were able to preserve good olfaction or normal olfaction in 50% of cases, and in another 30%, we were able to preserve at least some olfaction, which is rather important for the patient. We all need to study the anatomy of cisterns. These are Roton's pictures. They are excellent, but since they are drawing, they show the walls of the cisterns like single layer, which looks like impenetrable, which it is not. Actually, the cisterns are like trabecular system, with the exception of Lillienquist membrane and all outer walls. These are probably the best publications on cisternal anatomy by Kuruc. Not easy articles to read, but very good articles to get good orientation. These are our own anatomical studies, and you see that the Lillienquist membrane is really like impenetrable wall. To prepontine cistern, and they are only trabeculous and only like strands of arachnoid which are separating these cisterns. That's a very special technique of dissection. You soften the skull with special chemicals, remove the skull, then open the dura. So all the images are from below. And here it's very well seen that the walls of the cistern, the internal walls of the cistern, are not really a cistern which is closed, it's open, and it's obvious that there must be many openings and many holes in order to get some CSF flow. Actually, whole the skull base is on a very tiny strands, and you see that from anterior communicating or from olfactory cisterns down to CP angle cerebropontine cistern. It's something like a circle of a diameter of 35 millimeters. And since you are ACNS with table tennis experience, do remember that the diameter of table tennis ball is 38 millimeters. So this is smaller than the table tennis ball. This just to show that Al-Mefti, who described that the intradural origin of carotid artery is not covered by arachnoid, it's well seen. Again, we are looking from below. These are the dural lengths of the carotid. Another nicely documented location is the Petrous apex, which used to be here. Here is the fifth nerve, sixth nerve, and you see that outer wall of arachnoid as far as fifth nerve is rather distant from the brainstem, and it provides very nice plane of dissection, say in petroclival meningiomas. As soon as you get cranial of the fifth nerve, suddenly the arachnoid is very close to the brainstem, and suddenly these can be the easiest space for the meningioma to penetrate this, and then you do not have the plane of dissection between the brainstem and tumor. So what about arachnoid and cisterns? You should plan the approach with advanced knowledge of cisterns and expected arachnoid layers, where you will meet the arachnoid. In order to get this knowledge, you need to define the exact tumor origin, which is rather most easily done on T2 images. You will define this, in which systems we are doing our job. and it means what structures are going to be in each cistern. And if possible, if it's single cistern tumor, then stay within this one cistern. Do not get to the next cisterns where another structures may be. So this is something which I call cistern-oriented meningioma surgery. This is a slide which I have borrowed from my very good friend Pablo González Lopez from Alicante. Here you have the cisterns, arteries which are within which cistern, veins, and cranial nerves. And it's not a shame to get before surgery to this table and check which structures you are going to need and which structures you are going to endanger. Going back to aneurysm surgery, it's about the arachnoid membranes. You must dissect them, respect the arachnoid, but cut it, have an advanced knowledge of the membranes and cistern, cut the arachnoid, do not tear it. You may tear the aneurysm, and study its anatomy. Here is another ophthalmic aneurysm, and you see the optic nerve stretched across the dome of aneurysm, and the arachnoid, which is being dissected, this is the wall between the carotid cistern and chiasmatic cistern. As long as you preserve this arachnoid, at the end of surgery, you preserve the vasculature of the optic nerve, and thus you will preserve the function. Actually, in this patient who came to us with vision problems, these problems cleared and improved immediately after the surgery. Here you see the ICG and you see the well-preserved vasculature of the optic nerve. This is after, and you see that the optic nerve is getting its normal appearance. Meningioma surgery, opposite. It's also about the arachnoid membrane. You also should respect the arachnoid. You wouldn't like to penetrate it. You should have advanced knowledge of the membranes and cistern and do not cut it unless necessary. Just lift, dissect it free from the tumor. Of course, study its anatomy. This is a tuberculum stellar meningioma, and you see that at the end of surgery, you see both optic nerves, chiasm, and preserved arachnoid of the chiasmatic cistern. All the important structures are behind this wall of arachnoid. Another one, which is at the origin of the carotid artery, anterior clinoid meningioma, and see that at the end you have the clinoid, and you have the carotid cistern, which is preserved, and you have the chiasmatic cistern, which is preserved as well. More complex tumor of the anterior clinoid with encased carotid artery, and this is after the surgery. Only the carotid cistern was opened. Here is the Lilienquist membrane forming the posterior wall of your resection cavity, and the chiasmatic cistern was preserved at all. It was never opened. This is a little later in the surgery, and you see all the structures starting from the third nerve to the optic nerve. This is a complex case of anterior clinoid meningioma, and very strangely, the tumor penetrated into the cistern of lamina terminalis, which is very unusual. Here it is during the surgery. The lobule, which is within the arachnoid of the lamina terminalis cistern. This is the anterior cerebral artery here, so we are above the artery, and here is the lamina terminalis and tumor being in the arachnoid of the cistern. This is after surgery. Going to Petrous apex and posterior fossa, it's more complex there. Coming from cerebellopontine cistern, from posterior, you get into the ambient cistern, which is going along the side of the mesencephalon, then crural cistern, in which only the vein of Rosenthal is located, to interpeduncular cistern, and going posteriorly to the midline. There is quadrigeminal cistern, and one shouldn't forget the velum interpositum, which is also part of the cisternal system. So this is a CP angle meningioma, which is posterior to the cerebellopontine cistern, and you see that the arachnoid of this cistern, the lateral wall, the outer wall, is preserved. Thus, the structures 7th, 8th, 5th are never really uncovered and endangered. Petrous apex meningioma, the same case, the prepontine and cerebropontine systems remain untouched and still form the wall of your dissection or plane of your dissection, and all the structures within this system are preserved. More medially located tumor in CP angle, so only the cerebropontine system was entered, and you see the 7th and 8th after the resection of the tumor, still covered by its own arachnoid. Even more medially, this is the 6th nerve. The arachnoid bands you are seeing are forming the wall between the cerebropontine and prepontine system, and the approach is through the cerebropontine system. The tumor resection. Now you see the 5th and 7th and 8th, then the vein well preserved, and only very minimal approach through the cerebropontine system. And now we shall see the 6th nerve, which is more medially over here. And again, the arachnoid on this nerve, which is lateral to the nerve, is forming the wall between the prepontine and cerebropontine system. This tumor will be located in ambient system only, and the anatomy is like this. This is the petrous apex, here is the 4th nerve, and this is the outer wall of ambient system, its lower part. And this is after surgery. Again, the other systems are not penetrated, and the resection cavity is actually covered or formed by the arachnoid of the system. CC junction tumor, and after the surgery, here's the arachnoid wall, which is forming the wall between the anterior spinal system and pontomedullary system. 11th nerve, 12th nerve, vertebral artery, brainstem from the lateral side. And again, the arachnoid is preserved as much as possible. This is a multisystemic tumor, sphenopetroclival meningioma. The approach I use is supra-infracerebral in 4 stages in a way. First, the part which is in CP angle in cerebropontine system, then cutting the tentorium to allow for subtemporal resection and to allow entry into the interpeduncular system. So what you see is 7th, 8th, ICA, and 5th nerve. It means cerebropontine system. Then 5th and 6th, it means that here we are already in prepontine system. Then there is the trouble of the 4th nerve entering the ambient system. This is the most difficult structure to preserve. And at the end of surgery, we are in interpeduncular system, posterior clinoid process, P2 on the opposite side, optic tract and pituitary stalk, and ipsilateral, again posterior clinoid process, again P2, but the ipsilateral, the superior cerebral artery running towards you, and the 3rd nerve, which is above the artery. And the shiny structure here is Lillienquist membrane, which is the most anterior wall of dissection, much better seen on this image. This is the superior cerebral, posterior cerebral, and basilar artery, and Lillienquist membrane being the border of the dissection. And this is the whole dissection with cutting the tentorium. After, I always leave the piece in sinus. I don't enter the cavernous sinus for surgery. We've published the possibilities of this lateral supracerebral infratemporal approach in this article. And we are going into the midline, into the pineal region, where the system is not really that difficult, but this is a strange tumor which enters even the velum interpositum, it means the ceiling of the 3rd ventricle. We are talking this system, quadrigeminal, ambient, and velum interpositum. This is at the beginning, dissecting the tumor, cutting the tentorium on the right side, where there is a lobulotic tumor. Once the base of the temporoparietal region is exposed, that's enough. This is a little technical trick. If you insert the suture to the cut tentorium, you may use it for some more retraction, and in these cases, even 2-3 millimeters may be very important for your approach. So now we are dissecting the lobule underneath the temporal occipital region. Once this is dissected free and resected, you see the corpus callosum in the anterior part of the resection. And now we shall enter the third ventricle, and you shall see the arachnoid ovellum interpositum. It's over here, and you see the tumor still covered by the arachnoid and still being dissected away from the arachnoid planes. This is the third ventricle in anteriorly. And as the resection proceeds, you get the opposite side vein of Rosenthal, which shows over here and over here. And even the pleural system was entered. And now we are in the quadrigeminal system. This is the lamina quadrigemina, and tumor being lifted from the ectum. All right. Let's go. And this is at the end of surgery. You see that the cistern plane, as much as possible, is preserved along with the vessels, and the tumor is resected even from the left side by this supra-infra approach. This is the image after the surgery. You see that the velum interpositum is free of the tumor. To conclude the lecture, I will use what my very good friend Imad Kana is always repeating, and I believe that's enough for everyone to remember. The arachnoid is really a friend. It's your friend. It helps you in all the resection and in all your surgery. And what's important is that the arachnoid belongs to the patient, so leave it behind. As much as possible, use it as your guide, use it as your plane of dissection, but if possible, leave it behind. And this is my city, Prague, where all these surgeries were done. Thank you for your attention.
My name is Petr Skalitsky. I'm from the Department of Neurosurgery of Second Faculty of Medicine of Charles University in Prague and Motol University Hospital, mainly, and I will talk about the partial medial clinoidectomy with opticanal roof drilling for clipping of ophthalmic artery aneurysms today. Excuse me, I'm a little bit ill, so I'm sorry for any inconveniences with my talk. The main topic of my research is normal pressure hydrocephalus. I've listed some articles here. For example, this article provides an overview of pathophysiological mechanisms and diagnostic procedures. We have published the first experiences with a new type of Mitke valve in 9-page patients. We have evaluated the role of dash callosal angle and cingulate cell cosine in prediction of gait responsiveness after shunting in 9-page patients. And also in this recent article, we have been trying to find a new way of lumbar infusion test biosignal analysis using a machine learning approach, and we have found some interesting results. Also, I'm interested in other fields. For example, we have recently published this meta-analysis on cerebral cavernous malformations, where we have compared the treatment approaches in terms of their effectivity and hemorrhage rates after treatment. And also we have found that the deep-seated and brainstem cavernomas are more prone to bleeding. And in this article from the scientific reports, we have published some research with our interesting pillow that would be used to measure intracranial pressure non-invasively. Okay, that's enough with the self-advertisement. I have no disclosures in terms of this, what I'm going to present. Okay, the ophthalmic artery aneurysms. In the last 20 years, we have treated 172 ophthalmic artery aneurysms. Surgery was used in approximately 32% of cases. I don't want to talk about the benefits or risks of either a surgical or endovascular treatment today, but the first question that often comes to mind is the proximal control, and we haven't used it in almost all of the cases. We only reserve it for large and giant ophthalmic artery aneurysms. The surgical cases were treated via the frontolateral or pterygium approaches. You all are familiar with these approaches, but there is exactly some drilling of the sphenoid wing to narrow the corridor, to have it more wider, to get to the aneurysm and have enough surgical maneuverability. You can see that we have used a variety of approaches from these approaches. We haven't used drilling in almost 22 cases, and that means that sometimes the surgical corridor is wide enough, and so the targeted minimal drilling, which I'm going to talk about today, was used in 18 cases. And I think some cases where the anterior clinoid was drilled as a whole would be done via this approach today. So the ophthalmic artery aneurysms belong to the family of paraclinoid aneurysms, which are located somewhere between the proximal dural ring and the PCOM artery branch. And so we would be talking about the ophthalmic artery aneurysms, and these are located near the ophthalmic artery branch. So in terms of the surgical procedure, the first that you are going to see when you are going to reach on the base is the optic nerve, and you would coagulate and cut the dura above the optic canal and the middle part of the anterior clinoid process in case the ophthalmic artery aneurysm isn't seen well without this drilling. So this is the part that is exposed and drilled. Also, the medial part of the clinoid process is drilled, and then you have enough space to dissect the distal dural ring or the falciform ligament, and it allows you for a gentle traction to the optic nerve, and you can see the base of the aneurysm to clip it safely. This is what you will see in the operative microscope. So here is the extent of the dural coagulation and cut. The optic canal roof is then drilled. Someone would argue that he will do it with the charisma rongers, but if you use the irrigation enough, the risk of thermal damage is very low. So then you can place the clip, and here you can see that the optic nerve was decompressed. Again, the dissection of the decidual ring and the extent of the dural cut. So the first patient is a 47-year-old female patient. She complained of episodes of headache and vomiting. Otherwise, she had no neurological deficit. From the reconstructions of the MR angiography, you can see the ophthalmic artery aneurysms. Here is the ophthalmic artery. So after the sphenoid wing was drilled and the base was narrowed, the sheep-shaped dural cut, dura is fixed with stitches. Some more drilling. And we have continued intradurally. We have followed the base to get to the optic nerve. Then, once you see the optic nerve, the chiasmatic cistern was opened. Then the carotid cistern was opened, and the arachnoid is dissected. You can see the aneurysm, but there isn't enough space to put the clip safely. So the optic nerve. So we would coagulate and cut the dura from the optic canal roof and the middle part of the clinoid process. The bone is drilled. Irrigation is used to minimize the thermal damage. Then the falciform ligament and the distal ring were dissected, and now we can put the clip safely. Just a gentle traction to the optic nerve. Now we will use the ICG. No filling of the aneurysm. Postoperative angiography showed complete occlusion, patent ophthalmic artery. This is the postoperative CT scan. The second patient is a 62-year-old female patient. She had visual impairment, and here is the CT angiography and the aneurysm. Again, the 3D reconstruction and the aneurysm. The video. Again. The dura was coagulated and cut, and the bone is drilled. Distal ring is dissected. Huge compression of the optic nerve. Now we are around the aneurysm, and we can put the clip safely. Now we will use the ICG. No filling of the aneurysm. So we have decided to puncture the aneurysm, but unfortunately it bled. So we have put another clip. Wide thrombus inside the aneurysm, which was and dissected, and the optic nerve is decompressed. This is a post-operative angiography, complete occlusion, and patent ophthalmic artery. The post-operative CT scan. The third patient was a 59-year-old female patient. Here it was an incidental finding, but the aneurysm was huge and irregular, so she was consulted for the surgical management, and she accepted. So this is the aneurysm here on the CT angio. Here we have decided to drill a little bit more extradurally. So the sphenoid wing was drilled much more medially. We also use lumbar drainage in every case to keep the brain relaxed, but this would allow you much more of the surgical maneuverability. Then the dura is cut. You can see how much space you have. Again, the chiasmatic and carotid cisterns are opened. You can see the aneurysm, but we didn't have enough of the space to put the clips safely. So again, the dura beneath the optic canal roof is coagulated and cut. Medial part of the glenoid. Dura is cut. The bone is drilled. Again, dissection to distal dura ring and falciform ligament. Here we didn't have enough space to put the clip above the whole neck, so here we have put 3 clips, and then the 4th clip was placed to the rest of the neck. But the optic nerve was decompressed. The ICG showed that there was no residual filling. The postoperative angiography showed complete occlusion, patent ophthalmic artery, postoperative CT scan. The 4th patient was a 43-year-old female patient. Again, this was an incidental finding, and she decided to undergo the surgery. And again, here is what you will see once you do the frontolateral pteron approach and go at the front base to the optic nerve and the aneurysm, but the part of the aneurysm is hidden beneath the Kleiner process. So what you will drill a little bit of the bone here. Now you have enough space to put the clip. Again, complete occlusion and patent ophthalmic artery. So the technique was performed in 18 cases. The majority were females. The morbidity and mortality was 0%. And we can say that the technique provides enough of the surgical maneuverability is little bit less invasive than the drawing of the whole anterior clinoid process, and the intraoperative time is reduced, and the results are very good. So thank you for your attention.
Dear colleagues, the topic of my presentation for first World Young Neurosurgeons Congress 2022 is subarachnoid cisterns and their relevance to skull-base meningiomas. My name is Michaela May and I work as a resident neurosurgeon in Department of Neurosurgery and Neuro-Oncology in Military University Hospital in Prague, Czech Republic. I've graduated from the First Faculty of Medicine, Charles University in Prague. For introduction into the topic, I have selected a picture of the subarachnoid cistern from Cornerstone article published by Yashargil in 1976. The subarachnoid cisterns are expansion of subarachnoid space situated between the arachnoid membrane of the brain and its pale surface. We perform our research in cooperation with the Neurosurgical Department and Anatomical Laboratory of the Centre Hospitalier Régional Université de Tours, France. Upper photos show the microanatomical laboratory, and photos below show Military University Hospital in Prague and multifunctional neurosurgical OR. Methods. The following sequence of steps was performed. 5 adult cadaveric heads were obtained from the body donation program of the University of Tours, France. Vascular injection. Red latex was injected in the internal carotid and vertebral arteries, and blue latex in the jugular veins. All soft tissues, the mandible and the maxilla were removed, and the sphenoid sinus exposed anteriorly through a large opening. Small craniotomies with dural openings were performed. Specimens were set with a 10% formalin solution for 1 week. The specimens were subsequently bleached with 20% hydrogen peroxide solution added to 10% formalin solution. Baths were renewed weekly. Dissection were performed using an operative microscope Leica. Skull base were removed using the unspec high-speed drill or ronger. The olfactory cistern is situated in the superficial part of the olfactory sulcus. Its borders are straight sinus medially, orbitofrontal gyri laterally, outer arachnoid membrane antero-inferiorly, and olfactory membrane posteriorly. The olfactory membrane is continuous with the lateral lamina terminalis membrane medially and the proximal sylvian membrane laterally. Bordering cisterns are lamina terminalis medially, sylvian cistern laterally, carotid cistern posteriorly. Content is olfactory nerve, branches of orbitofrontal artery, and branch of frontopolar artery. So this is inferior view of olfactory cistern. There is dura mater, which was partially removed, straight gyrus, orbitofrontal gyri, tractus olfactorius, bulbus olfactorius, and branch of orbitofrontal artery. Olfactory groove and planum sphenoidale meningioma originates within the olfactory cistern. Below you can see 2 different cases. On the left, there is olfactory groove meningioma growing asymmetrically. It is divided by 3 layers of outer arachnoid membrane on one side and by 1 layer of outer arachnoid membrane on the other side. The edema is usually present unilaterally. On the right side, there is olfactory groove meningioma, which grows symmetrically. It is divided by 1 layer of the outer arachnoid membrane on both sides and the edema is usually present bilaterally. Chiasmatic cistern. Its borders are outer arachnoid membrane covering the tuberculum and diaphragma cellae antero-inferiorly, medial carotid membrane laterally, and the encephalic membrane posteriorly. Bordering cisterns are lamina terminalis superiorly, carotid cistern laterally, and interpeduncular cistern posteriorly. Its content is optic nerve and optic chiasm, pituitary stalk, and perforating branches of internal carotid artery. So the inferior view of chiasmatic cistern is on the upper picture with optic nerve and optic canal and its dura mater, olfactory nerve, internocarotid artery, pituitary gland. In the second picture, it's anterior view of chiasmatic cistern with optic chiasm and dense trabeculae below and pituitary stalk. Tuberculum cellae and diaphragma cellae meningiomas originates within the chiasmatic cistern and are in close relationship with the optic chiasm, which is dislocated superiorly. Carotid cistern. Its borders are anterior perforated substance superiorly, medial carotid membrane medially, medial surface of temporal lobe, and its outer arachnoid membrane laterally, and outer arachnoid membrane on the posterior clinoid process and cavernous sinus inferiorly. Bordering cisterns are lamina terminalis superomedially, chiasmatic cistern medially, Sylvian cistern laterally, interpeduncular cistern and crural cistern posteriorly. Its content is internocerebral artery and its branches, ophthalmic artery, posterior communicating artery, anterior choroidal artery, perforating branches, metacerebral artery, and anterior cerebral artery, as well as intracarotid membrane and dense trabeculae. So this is an inferior view of carotid cistern with internocarotid artery, neighboring chiasmatic cistern, optic nerve, ophthalmic artery, oculomotor nerve, posterior cerebral artery, diencephalic leaf, lateral carotid membrane, temporal membrane, and medial carotid membrane. The relevance of the carotid cistern to the anterior clinoid process meningiomas was first described by Almefti et al. In 1990. The anterior clinoid process meningiomas were divided into 3 groups. Group 1, the meningioma origin is proximal to the end of the carotid cistern. The meningioma encases the carotid artery and its branches with direct attachment to the adventitia. The optic nerve maintains an arachnoid plane from the chiasmatic cistern. Group 2, the meningioma originates from the superior or lateral aspect of the anterior clinoid process above the segment of the internal carotid artery invested in the carotid cistern. The meningioma encases the carotid artery and its branches. An arachnoid membrane of the carotid cistern separates the tumor from the adventitia, rendering dissection possible. The optic nerve maintains an arachnoid membrane from the chiasmatic cistern. Group 3, the meningioma originated in the optic foramen. The tumor is separated from the carotid artery by the carotid cistern, but it extends into the optic canal without intervening arachnoid plane. The interpeduncular cistern is situated between the cerebral peduncles. Its borders are the encephalic membrane superiorly, mesencephalic membrane inferiorly, and the oculomotor nerve and its cistern laterally. The bordering cisterns are chiasmatic cistern superiorly, prepontine cistern inferiorly, and cerebellopontine cistern inferolaterally. Its content is basilar artery, posterior cerebral arteries, and superior cerebellar arteries. There is inferior view of interpeduncular cistern with basilar artery, superior cerebellar arteries, posterior cerebral arteries, the oculomotor nerve, the encephalic leaf, pituitary stalk, internal carotid artery. The prepontine cistern is situated between the pons and outer arachnoid membrane of the clivus. Its borders are mesencephalic membrane superiorly, pontomedullary membrane inferiorly, and anterior pontine membrane laterally. The bordering cisterns are interpeduncular cistern superiorly, premedullary cistern inferiorly, and cerebellopontine cistern laterally. Its content is basilar artery, anterior inferior cerebellar arteries, and several veins. This is inferior view of prepontine cistern with basilar artery, anterior inferior cerebral artery, the abducens nerve within the lateral wall, and pons. The premedullary cistern is situated between the medulla and outer arachnoid membrane of the clivus. Its borders are medial pontomedullary membrane superiorly, lateral pontomedullary membrane, and rhomboid membrane laterally. Bordering cisterns are prepontine cistern superiorly, cerebellomedullary cistern laterally, and anterior spinal cistern inferiorly. Its content is the hypoglossal nerve, vertebral arteries, anterior spinal arteries, posterior inferior cerebellar arteries, and several veins. So this is the inferior view of premedullary cistern, vertebral artery, hypoglossal nerve, posterior inferior cerebellar artery, spinal cord, clival, petroclival, and foramen magnum meningiomas. The three stages in the evolution of tumor to brainstem relationship were described in the clival meningiomas by Sekar et al. In 1994. In the first stage, a good arachnoid plane is present. In the second stage, the arachnoid plane is lost, particularly at the site of maximal compression. In the third stage, the pia mater is invaded. Brainstem edema occurs because of a breakdown of tumor-to-brain barrier. On the right side, there are MRI of patients with meningiomas which originate within the prepontine and premedullary cistern. The cerebellopontine cistern is situated between the pons, cerebellum, and petrous bone. Its borders are lateral pontomesencephalic membrane superiorly, anterior pontine membrane medially, and lateral pontomedullary membrane inferiorly. Bordering cisterns are ambient cistern superiorly, cerebellomedullary cistern inferiorly, and prepontine cistern medially. Its content is the trigeminal nerve within its own arachnoid cistern, the fascial nerve, the vestibulocochlear nerve, the abducens nerve within its medial wall, superior cerebellar artery, anterior inferior cerebellar artery, and several veins which converge into the superior petrosal vein to form superior petrosal sinus. So this is view of cerebellopontine cistern with fascial and vestibulocochlear nerve, trigeminal nerve with internal carotid artery, abducens nerve, and trigeminal nerve, anterior inferior cerebral artery, and mediomeningeal artery. MRI depicted in the picture shows the cerebellopontine meningioma with preserved arachnoid dissection plane formed by outer arachnoid membrane. Cerebellomedullary cistern. Its borders are lateral pontomedullary membrane superiorly, trabeculae in front of the glossopharyngeal, vagus, and accessory nerve medially, and foramen magnum inferiorly. Bordering cisterns are cerebellopontine cistern superiorly, premedullary cistern medially, and the cistern is continuous via foramen of Luschka with lateral recess of the fourth ventricle. Its content is glossopharyngeal, vagus, and accessory nerves, vertebral artery, posterior inferior cerebellar artery, and several veins. In the picture, there is posterior view of cerebellomedullary cistern with glossopharyngeal, vagus, and accessory nerve, and fascial and vestibulocochlear nerve. Similarly, glossopharyngeal, vagus, and accessory nerve, vertebral artery, posterior inferior cerebellar artery, and hypoglossal nerve. Cerebellum. Foramen jugulare meningioma originate within the cerebellomedullary cistern. The MRI depicts foramen jugulare meningioma in close relationship with 9, 10, and 11 cranial nerve, as well as medulla oblongata. Conclusions. The skull-base softening using the hydrogen peroxide solution allows the acquisition of high-quality skull-base specimens. We suggest its implication in neurosurgical training to study complex skull-base topographic anatomy as a complementary method for arachnoid studies. The anatomy of the subarachnoid cisterns should be considered during the skull-base meningioma surgery. Outer and inner arachnoid membranes for important dissection planes which prevent perioperative damage to critical neurovascular structures. Thank you very much for attention. Here you can see some references.
Thank you very much, Professor Vladimir Benes and all his team for taking up this difficult topic and explaining it very well with different cases. I can see one hand raised.
I see someone raise his hand.
Yeah. I'm just promoting to the everyone allowed to talk. Yeah. Dr. Paulo Kadri, are you there? Andres is there, but he's not speaking. Dr. Paulo. Anyway, anybody has any another question for Dr. Vladimir Benes? We've just got 3 minutes for the discussion before we start the next session.
Yes, and thank you for the talk, Professor. And I'm Ben, a young neurosurgeon from Hong Kong. And thank you for the excellent lecture to show the alveoli membrane and its relationship to the surrounding structures. And it's very detailed and it's the most comprehensive lectures on the alveoli membrane that I have ever received. So during my training, I do not encounter such a great lecture that who explain the alveoli membrane in so much details. So may I ask during the training in your center, how often do you dissect on those alveoli membrane? Any tips for the specimen to preserve the alveoli membrane for the trainee to dissect on?
This is not easy. As you are asking for the dissections, we started in Tours, as Michaela has shown, because they had the technique which she published with them. And then the COVID came. So we had to do for ourselves, and it's pretty difficult. since we have very strict laws on using cadavers. So we were able over the past 2 years to obtain 3 or 4 cadavers only. But we somehow even improved the technique because in Tours they have microscope, but we are using exoscope for these studies now. And I can tell you that it's an excellent tool. The images are much better, the documentation is much easier, and some of the images Michaela has shown were with endoscope, with this exoscope as well as mine, and you probably realize the difference. So any resident can go there and do that. Unfortunately, the number of heads is very limited, so it's not really like say frequent program. It's a regular program, but not frequent. And good teaching.
Yeah.
Just one small question before we start the next session, Professor. Especially in case of cerebellopontine angle tumor, to have a good arachnoid dissection, do you prefer doing the lumbar puncture, or when do you do it? Because when you do the lumbar puncture, all the CSF goes out and then arachnoid dissection becomes very difficult. So what is your take on that?
In CC junction, I do the puncture at the dorsal spinal system, but in CP angle, I do not do that. If need be, I first check what it looks like, how are the leaves of the arachnoid situated, and then I open caudally to the tumor the pontomedullary cistern, by which I drain the CSF, and then return back to the tumor about which I already do have at least some information and some knowledge. And then I try to preserve the, to stay within the cerebellomedullary cistern, which is the most frequent location of the tumor.
Thank you. Thank you very much, Professor. That was an excellent. And I'll remember that line and I'll pass it to my juniors also, that arachnoid belongs to the patient, so you leave it there, don't remove it. Thank you very much, Professor. That was a take-home message.
You are welcome.
Thank you, thank you. So we'll move ahead with the next session, that is Professor Atul Goyal's session on craniovertebral junction fixation and anomalies. Dr. Ben, I think Professor Atul Goyal's talk will have to play the his recording. What he has
My
sent us.
dear young neurosurgeons of the world, and my respected and most respected Professor Yoko Kato. It is my great pleasure and honor to give this presentation and give a different version of spine surgery, a different thought process on spine surgery, a different concept on spine surgery. And I want to introduce to you the concept of central or axial atlantoaxial instability. What makes human different from other animals is that we have standing human position. All other animals are either four-legged or they have wings, but we have 2 legs and we stand and run throughout our life. The entire focus of our body is on the muscles on the back of the spine. There are no muscles anterior to the spine. There are no muscles adjoining the disc, adjoining the vertebral bodies. All the muscles are focused on the back of the spine, and lifelong standing human position makes these muscles vulnerable. And what happens is, due to disuse of these muscles, due to abuse of these muscles, due to injury to these muscles, there happen vertical facetal instability. So my dear friends, I am introducing to you a new concept, a concept of vertical facetal instability. And I want to discuss this issue further. Spondylolisthesis, lumbosacral spondylolisthesis, we all know. In the year 1999, we said that basilar invagination is nothing but C1 over C2 listhesis. Instability is the issue and listhesis is the result. Like we treat listhesis, we should treat basilar invagination. So this was a new concept in the field of basilar invagination. And we introduced a very new, novel kind of treatment for the earlier discussed fixed atlantoaxial instability. There were two types of instability, atlantoaxial instability, that were in the literature. One was fixed, one was mobile. For mobile, the treatment was fixation. For fixed, the treatment was decompression. So we said that it is never fixed. It is the result of unstable spine. It is more mobile than normal. It is pathologically mobile. And there is a possibility of reduction of fixed dislocation. Earlier, when the treatment was decompression, we said that fixation and reduction is the treatment. So in flexion extension, it does not move. That is called fixed dislocation. The treatment was decompression, either by transoral route or from posterior route. We introduced the concept that open the joint and manipulate the facet, introduce bone graft in the joint and fix the C1, C2. So, and realign the craniovertebral junction. So from decompression, we introduced the philosophy of fixation. So there is no decompression, only stabilization, and whenever possible, craniovertebral junction realignment. Basilar invagination, many of the young neurosurgeons in the audience may not know that the only treatment was decompression 25 years ago. For this group A, the treatment was transoral decompression. For this group B, the treatment was foramen magnum decompression. So in the year 2004, we said that this group is unstable and this group needs stabilization, and we introduced the term craniovertebral junction realignment. In the year 2004, my concept was that this group needs decompression because the anomaly here is a fixed dislocation. So from what my earlier concept was, that a group of basilar invagination needs fixation. So this kind of basilar invagination open the joint, distract the facet, realign the craniovertebral junction and stabilize. So we said that this group does not need decompression. And over the period of time, we have got several hundred patients where we have treated basilar invagination without decompression. So this was a case. You see, there is basilar invagination, there is Chiari and syrinx, there is listhesis of C1 over C2, open the joint, realign the craniovertebral junction and stabilize, and there is no need for decompression. In the year 2008, we introduced an absolutely brand new concept, the concept of central or axial atlantoaxial instability. If you read this article of mine, you will see that central or axial atlantoaxial instability is present in Chiari, in syringomyelia, in degenerative spine, in spinal deformities, in OPLL, in Hirayama. So if you understand what is central or axial instability, you can completely revolutionize or change the treatment paradigm for these entities. Now carefully see this slide. Type 1 is when the C1 is dislocated anterior to C2. There is atlantodental interval is increased. There is compression of the neural structures. There is listhesis of C1 over C2 and stabilization is the treatment. There is no decompression. Now carefully see this slide. This is listhesis or retrolisthesis of C1 over C2. There is no atlantodental interval disturbance. There is no neural compression. The conventional treatment is decompression. We have said that this is central or axial instability and you need to stabilize the atlantoaxial joint. Then we introduce another beautiful entity of central or axial instability, means type 2 and type 3. There is no atlantodental interval disturbance. There is no facetal malalignment, presence of Chiari, presence of assimilation of atlas, presence of basilar invagination, presence of Klippel file abnormality, and presence of a number of anomalies, including Chiari, syrinx, They are all indicators of atlantoaxial instability, and atlantoaxial stabilization is the treatment. So type 2 and type 3 are called central or axial instability. There is no atlantodental interval disturbance. There is no there may or may not be any compression of neural structures. So basilar invagination, as we progress, we said that not just group A, even group B is unstable, and instability is the cause of basilar invagination, and stabilization is the treatment. For both group A and group B basilar invagination, we said that atlantoaxial instability is the treatment and stabilization is the treatment. For both group A and group B, more often than not, group B patients have central or axial atlantoaxial instability. So basilar invagination, the concept is instability is the problem and stabilization is the treatment. There is no role for any kind of decompression, whether anterior or from posterior. So there is no atlantodental interval disturbance, there is no facetal malalignment, there is basilar invagination. Basilar invagination is a result of instability, is a secondary phenomena. Tonsillar herniation, syringomyelia are secondary phenomena. The concept is all the secondary phenomena are due to chronic atlantoaxial instability. They are naturally protective and they are reversible. So basilar invagination, Chiari, syrinx, and all these issues are secondary, naturally protective, and reversible. So we have to understand that there can be facetal malalignment even in the absence of atlantodental interval disturbance or neural compression, and stabilization is the treatment. For such basilar invagination, the whole world will do decompression. When there is no atlantodental interval disturbance, there may be facetal malalignment, or there may not be any facetal malalignment. The basilar invagination is secondary, Chiari is secondary, syrinx is secondary, and stabilization is the treatment, no decompression. So basilar invagination, Chiari, and syrinx are neural and musculoskeletal, naturally protective phenomena in the presence of chronic atlantoaxial instability. So in 2013, we wrote this article, Is atlantoaxial instability the cause of Chiari malformation? So Chiari is not primary. Chiari is secondary to atlantoaxial instability. It is naturally protective and it is reversible, and atlantoaxial fixation is the treatment. More recently, I wrote this article on our experience with 388 cases of Chiari, where we have done only stabilization without any form of decompression. Now my experience, of course, is quite geometrically increased and quite rapidly it is increasing. So there is no atlantodental interval disturbance. Presence of Chiari and syrinx are indicators of atlantoaxial instability. There may or may not be facetal malalignment. You stabilize and you see an absolute magic in the clinical symptoms, clinical recovery from the patient, and radiological recovery. We have seen that syrinx reduces in 100% of patients when you do a scan after 1 year, and it reduces in about 50% of cases if you do a scan after 2 months or 3 months, and it reduces to some extent in almost 100% in about 6 months of time. So reduction of syrinx, this is preoperative image. You see reduction of syrinx. There is no atlantodental interval disturbance. There is no compression. There is mild atlantoaxial facetal instability. Whether it is present or not, atlantoaxial stabilization is the treatment. Even when there is no bone malformation, even when there is no basilar invagination, presence of Chiari, presence of syrinx are indicators of atlantoaxial instability. So the concept is, when there is atlantoaxial instability, there can be several secondary issues like basilar invagination. Basilar invagination may or may not be associated with Chiari, may or may not be associated with syringe, may or may not be associated with bifid C1, may or may not be associated with Klippel file. So whichever of these anomalies is present are indicators of atlantoaxial instability. They are all secondary and they need, whether they are present in cohort like basilar invagination present with Chiari, with syringe, with platybasia. So they can be present together or separately. And they all indicate the presence of atlantoaxial instability and indicate the need for stabilization. So there is Chiari, there is no atlantodental interval disturbance, there is no facetal malalignment. I have done only fixation as the treatment. So we have now got several hundred patients where Chiari with syringe, with or without the atlantoaxial facetal malalignment, no atlantodental interval disturbance, you stabilize and you see remarkable clinical improvement and remarkable recovery in the radiological features. So this is another case where there is a simulation of atlas, some facetal malalignment, Chiari malformation, syringomalia, only stabilization, and you see reduction in the syringomalia. So Chiari is one of the several secondary features which are secondary, which are protective, and which are reversible, and we should not call them malformation. We should call them formation. They are naturally protective like airbag. So chronic atlantoaxial instability may be associated with C1 bifid, C2-3 fusion, Klippel file, platybasia, Chiari, syringe, external syringomalia, syringobulbia, external syringobulbia, short head, short neck, basilar invagination, short body, kyphoscoliosis, torticollis. So all these features are secondary to chronic atlantoaxial instability. They may be present together. They may, one or two may be present together, or they may be present discretely. Whenever you see any of these secondary issues, they are indicators of atlantoaxial instability, and they are indicators of the need for atlantoaxial stabilization. So when there is chronic atlantoaxial instability, several naturally protective things happen, like cervical fusion is protective and indicates atlantoaxial instability. Bifid anterior and posterior arches are secondary and they indicate atlantoaxial instability. Os odontoideum is secondary. And when you see os odontoideum, there is no need for decompression. And decompression is obviously a negative form of treatment. You stabilize and the person is cured. So this is a case with multiple bone fusions. This is a case with bifid. There is no compression. Compression is not primary. Compression is secondary, and compression is protective, and compression is reversible. You do stabilization, atlantoaxial stabilization, and an absolute beautiful clinical result. Similarly, syringomalia is secondary to chronic instability. It is helpful. It is not harmful. Idiopathic syringe, you see this idiopathic syringe, so it is present without Chiari, without bone malformation, without real atlantoaxial instability, but this is an indicator of central instability. You stabilize, and this is the treatment. No syringostomy, no decompression should be done. Musculoskeletal anomalies like short neck, torticollis, and various other musculoskeletal anomalies are secondary to chronic instability. You stabilize, the neck will increase in length, the neck will stabilize in the evening or very quickly after operation, and you can give a beautiful smile to the patient. So there is tilting of neck. These are secondary, and this is protective. You stabilize, and you quickly get a beautiful neck. May not be a beautiful smile in this case. So atlantoaxial instability is the issue. So we have got several hundred cases now where there's such neck deformities are there. And the issue is unstable atlantoaxial instability. You stabilize. Dorsal kyphoscoliosis. Now we have realized that this in this age group, in these children and young adolescents, More than 80% of time, the problem is central or axial atlantoaxial instability. There's no need to do multi-segmental stabilization. You do atlantoaxial stabilization and all the related symptoms will disappear absolutely quickly, and even the torticollis and kyphoscoliosis will disappear or reduce quite remarkably. So central or axial instability can itself be a cause of cervical myelopathy. There is no need for compression. There is no need for compression to be present. If it is present, it is all right. But presence of serines, presence of bifid are indicators of atlantoaxial instability, and you have to stabilize. We have been doing anterior cervical surgery for degenerative spine all our life. So this was my chapter in Sweet and Schmidek book, where I had written about anterior approaches to the cervical spondylosis. So these kind of anterior discoidectomy, corpectomy, and this kind of stabilization, I was doing myself for a long time, to the extent I wrote the chapter for Sweet and Schmidek book on multiple occasions. I also introduced this kind of technique of tricortical screw insertion long time ago, and these tricortical screws can by itself be stabilizing factors. But now my concept has completely changed for last 15 years. My concept is the entire problem of human body is standing position, and all the muscles of the back of the spine, which are focused on the facets, are the problem. Disc is not the issue. Disc is, you have to revere or you have to respect the disc. Disc can never be a problem. This is my concept. Craniovertebral junction instability, nobody really understands or discusses. This is the only this is the first article in the literature where craniovertebral degeneration has been discussed. We always talk of C5, C6, C4, 5. Sometimes C3, 4, rarely C2, 3. We never talk of C1, C2 degeneration. I have to say that atlantoaxial joint is the most mobile joint of the body. Atlantoaxial degeneration is the most frequent degeneration. Now carefully see this slide. Presence of osteophyte, joint space reduction, buckling of the posterior longitudinal ligament are secondary to vertical spinal instability. Vertical. These are secondary issues. Osteophytes are secondary issues. The reduction in the joint space is secondary issue. They are protective and they are reversible. There is no need for decompression in this situation. Stabilization is the treatment. Presence of ossification of apical ligament. These kind of osteophytes in front of the body of C2 are secondary phenomena, secondary to unstable atlantoaxial joint. Atlantoaxial stabilization is the treatment. Decompression is a negative form of treatment. Retroodontoid pseudotumor. The whole world was doing transoral decompression for these kind of entities. We introduced the concept that these are secondary, like osteophytes, to unstable atlantoaxial joint, and atlantoaxial stabilization is the treatment. And this osteophyte-like pseudotumor will disappear spontaneously over the period of time. So this was my first article on this subject, which has completely changed the treatment paradigm for this clinical entity. So is instability the nodal point of pathogenesis of both cervical spondylotic myelopathy and OPLL? My answer to this question is absolutely yes. Retroodontoid pseudotumors like osteophytes are pannus, cysts are secondary and they are reversible. Retroodontoid pannus in rheumatoid arthritis is secondary to vertical instability. It is like an osteophyte. You stabilize and it can disappear, as mentioned in our article on this subject. Now carefully see this slide. You see reduction in the joint space, multiple disc bulges, presence of osteophytes, presence of buckling posterior longitudinal ligament are all secondary. They are all protective and they are all reversible. The issue is unstable spinal segments, and the treatment is spinal stabilization. So this concept of vertical facetal instability is an absolutely revolutionary concept in the field of degenerative spine. So about 15 years ago, I introduced this concept of facetal distraction. You introduce spacers into the facetal articulation and you can have immediate reversal and new disc formation, reversal of ligamentum flavum buckling, ligamentum posterior longitudinal ligament buckling in the immediate postoperative period. So there is no need for decompression, and it introduced a new hypothesis, a new concept. Whenever we talk of degeneration, we talk of disc issues, we talk of disc degeneration. So there is no problem with the disc. Disc is naturally protective. Disc space reduction is natural and secondary. So these kind of multiple bulges, ligamentum flavum buckling are all secondary. You introduce spacers and you can get immediate postoperative reversal of radiological features, including new disc formation, buckling ligament are straightened, and there is no need for decompression. So we have done several cases at that time, which was my favorite operation, such kind of no decompression, arthrodesis of the spinal segment is the treatment. So you see multi-segmental issues and the treatment is only stabilization without any kind of decompression. Arthrodesis is the aim of the surgery. So intra-articular spacers and arthrodesis was the concept that we talked about 15 years ago. So this is preoperative and arthrodesis. There is no laminectomy, there is no anterior surgery, there is no posterior surgery. So this kind of thing, the whole world will do anterior ACDF, 1 segment, 2 segment, 3 segments. So we have done multi-segmental facetal distraction without any bone work. And now many people in the world are doing this kind of treatment. And many of you who are in this business know that this is a new concept and a new philosophy, and this is now gaining ground in many centers in the world. So this was my article in 2011, 10 years ago, when we talked about our experience with facetal distraction for single or multi-level spondylotic radiculopathy and myelopathy. So this was an alternative hypothesis for spinal degeneration, and facetal distraction spacers were introduced as a form of treatment. So these were my spacers, and I have patented these spacers on multiple occasions. More than 21 patents of mine are there on this subject. So we also talked about disc herniation. So disc herniation can resolve or regress in the immediate postoperative period, like this kind of when the posterior longitudinal ligament, the whole world will do anterior surgery. So we had done multi-segmental posterior facetal distraction and the disc has disappeared in the immediate postoperative period. I will talk more on this subject after some time. So we introduced the same concept for lumbar multi-segmental stenosis by introduction of spacers without any form of decompression. And this was also published in Journal of Neurosurgery about 8 or 9 years ago in 2013. So decompression of the compressed or deformed neural structure has been, this is the basis, like compression is the problem and decompression is the treatment. This is the basis of spine surgery. So we introduced the concept after, you see, earlier I used to do distraction spacers, but in 2013 we said that there is no need for even spacers. You do only fixation for degenerative spine. Only instability is the problem and only fixation is the treatment. And more recently, I wrote this article with our experience with 215 cases. You read the title that muscle weakness related spinal instability is the cause of spinal degeneration and spinal stabilization is the treatment. So this kind of multi-segmental compression, you do only stabilization and you see the magic with the patient. And this, after about 1 or 1.5 years, the entire compression will disappear spontaneously. So these are secondary, these are protective, and these are reversible. Only stabilization and no decompression from anterior or posterior is necessary. So this is another multi-segmental. There is no decompression, only stabilization. There are not even intra-articular spaces. And you see the whole spinal cord is reformed after some time, and all the secondary issues are resolved spontaneously. So we should look at spinal degeneration in a different perspective. Instability is the cause of symptoms, not the compression, and stabilization is the treatment. It is not neural deformation or compression, but instability that causes symptoms in degenerative spine. More important is we should know which segments are unstable. It is not what radiology says, those are the segments unstable. You should see radiological features like osteophytes are indicators of unstable segments. You should see clinical features, and you can see intraoperative by manipulation of the spinous process adjoining segments. You can see, like in this patient, there are 2 segments where there are osteophytes. I have done only fixation in more than 4 segments. So understanding of which segments can be unstable can be on radiological features and also on clinical guides and direct intraoperative guides. You see, this has spontaneously disappeared without any form of decompression. So this is multi-segmental. The whole spinal cord is as good as new. There is no decompression, only stabilization is the treatment. Another beautiful thing that nobody in the world realizes, that multi-segmental cervical spondylotic myelopathy can be associated with atlantoaxial instability on a very frequent basis. So atlantoaxial instability is central in majority of these cases. There is no compression. Multi-segment degeneration, you see there is facetal malalignment, which can be a natural, normal phenomena also. But in the situation like this, you have to include atlantoaxial joint in the fixation construct. There is no need for decompression, and an absolute magic can be seen. So there is compression here. There is absolutely no compression here, but there is facetal malalignment. I have included C1, C2 in the fixation construct. More importantly, when the degenerative cervical spondylosis is severe, in severe myelopathy, atlantoaxial instability is more frequently than not present, and you have to include even when there is no compression, even when there is no facetal malalignment, more often than not, you have to do atlantoaxial stabilization in the fixation construct. The concept about lumbar canal stenosis is not a compression. It is not a stenosed canal. It is unstable phenomena. Decompression is not necessary. Stabilization is the treatment. So you see the title, Role of Stabilization and Futility of Decompression as the treatment. So this is multi-segmental lumbar canal stenosis. There is no need for decompression. It is unstable segments. You have to do stabilization. And you have seen in most of my cases, I am doing transarticular or Camillus technique of fixation. What happens to osteophytes when you do fixation? Osteophytes disappear spontaneously in almost 100% of cases if you do a good fixation and if you do imaging after 1 or 2 years. So these are multi-segmental osteophytes which disappear following surgical treatment. So we should not use the term stenosis as, which is a misnomer. You should talk about multi-segmental instability. Cervical kyphosis should not be treated by osteotomies. This is an indicator of unstable spine. So there are 3 types of cervical deformities. In this, there is atlantoaxial fixation. You do only atlantoaxial fixation. In this situation, this kind of deformity, you have to find out which are the unstable segments, and you have to stabilize the unstable segments. And central instability can be present in a number of cases, even when there is no atlantodental interval abnormality and no facetal malalignment. You have to do atlantoaxial stabilization in the fixation construct. So instability is the problem. Stabilization is the treatment. There is no need for removal of these bones, and there is no need for osteotomies of any kind. Now I talk of another subject which is revolution in my mind, like disc herniation. The whole world will remove the disc. Microdiscectomy using endoscope and lateral approach and all those kind of things. But what I'm saying is that there is no need to remove the disc. Disc is secondary to an unstable spine. Disc is a result of instability, or disc herniation causes instability. You stabilize and there is no need to remove the disc. So this kind of disc herniation, the whole world will remove the disc, and then probably some will do fixation. I'm saying just do fixation and this disc will resolve and the patient will magically improve in the immediate postoperative period. So my series was published in World Neurosurgery some years ago. I wish that you read this article of mine on cervical radiculopathy. Same concept we talked about lumbar radiculopathy, treated by only fixation, no decompression of any kind, no discoidectomy of any kind. So this is the disc herniation. This is the disc herniation. You do only fixation and the disc disappears spontaneously after a period of time. So identification of the unstable segments and stabilization by Camille's technique, I prefer it as the most fantastic, most beautiful technique of stabilization, simple and quick. Ossification of posterior longitudinal ligament, the whole world does only decompression. So we have said that OPLL is secondary to multi-level chronic instability. We were doing anterior surgery for these kind of problems, and we had introduced limited oblique corpectomy. For the first time in the literature, this oblique corpectomy for OPLL was introduced by us in 2005. Many people are still doing, but we have completely abandoned this kind of oblique corpectomy, and removal of this was published in my article. So now our concept is only stabilization the ideal treatment for OPLL? So there is no decompression, only fixation. You see, there is OPLL. We have done only fixation without any form of decompression. And believe me, my friends, a magical result that you have never imagined in the treatment of this difficult clinical entity of OPLL. So you do only fixation in OPLL, and that is the treatment. Atlantoaxial instability is very frequently the cause of OPLL. So you have to include atlantoaxial segments in your fixation construct. This is mentioned in several of my articles on the subject. So in high OPLL, even in low OPLL, atlantoaxial instability may be associated, and you have to stabilize atlantoaxial and subaxial stabilization. So atlantoaxial and subaxial stabilization as a treatment of OPLL is an absolute revolution. Can it revolutionize surgical treatment of myelopathy due to OPLL? Absolutely, my dear friends, absolute magic. Hirayama disease is very well known in Asian countries, and nobody knows the treatment. We have said that central, even in the absence of atlantoaxial compression, even in the absence of neural compression, multisegmental instability is the cause, and multisegmental stabilization is the treatment. So we have removed transoral surgery from decompression from the world of neurosurgery, which has become an historical operation. Now we have said that foramen magnum decompression can become historical, and we are now saying that anterior surgery for cervical spine degeneration and OPLL can become an absolute historical operation. So this is my prediction, and I am absolutely convinced about it. So from only decompression to only fixation, a century-long journey of cervical and lumbar degeneration. So finally, my slide, compression is never primary. Compression is always protective. Compression is reversible, and decompression is never the treatment. Stabilization is the treatment. Thank you very much, my dear friends, and I hope you get some new concepts, new ideas, and I hope you look at these things in a different perspective. Thank you very much. So thank you, dear friends, for listening to rather long lecture. Just a minute. And I hope you have enjoyed it. I hope you have got some fantastic messages from this lecture.
You're using two.
Yeah, I know. Just. So can you hear me now?
Yes, sir, we can
hear you. Okay, Sachin, now, you know what, I know there may be several questions, I'm sure, but we don't have time for those questions
Hello,
at this
everybody.
time, because now
I am Luis Carelli from Rio de Janeiro, Brazil. I'd like to thank Professor Goyle to be here at this beautiful Congress of World Young Neurosurgeons 2022. And I'm going to talk about the craniovertebral junction, my perspectives. Craniovertebral junction instability. I'm going to talk more about the congenital, Chiari, basilar invasination, rheumatoid arthritis, this kind of disease, complex disease. And this instability can be translational, vertical, or both. And the fixed atlantoaxial dislocation, the concept was no reduction after traction or next extension. And the neural compression can be by posterior arc or by odontoid process impingement. We have several ways to treat these pathologies. Observation, if the deformity is mild. We can do anterior approach, retropharyngeal or transoral, for direct decompression. Posterior fusion and decompression, or C1, C2 facet distraction and realignment. And this realignment can rely in cases of primary disease or revision case, and we can use a lot of instrumentation, different kind of instrumentation. We can use stainless steel, titanium, PIC materials, bone. And this example of doing only observation. The disease, the deformity is not severe, and only close follow-up is needed. In other circumstances, with severe anterior deformities and malformation, sometimes direct address it to the pathology from the front, it is the best way. This is an example of labiomandibular split tongue approach to direct decompress the craniovertebral junction by the anterior extended transoral approach. Posterior fixation, stabilization, and direct anterior approach. But my perspectives changes during the past decades. Learning the principle and the concepts, most of the disease can be done by the posterior approach. This is the evolution and the concept of the realignment and the stabilization in most of the cases with monosegmental fusion, C1, C2, C0, C1, and this example of dealing with this pathology, congenital, severe congenital atlas aplasia with a fixed rotatorium dislocation, treated only by posterior approach. We don't have landmarks at the posterior approach. You need to be careful dissection to avoid the vertebral artery injury during the approach, and done the surgery only with C1, C2 realignment and fusion. This is a female patient with a fixed C1, C2 dislocation, and we apply the same concept, distraction, and to improve fusion, we can add bone or some kind of case. This is a titanium Harms case. And the surgical technique, well described in several articles in the literature, in prone position, allogravitational traction. In some cases, we have a necessity to cut the C2 ganglia to have a more open window to address the C1, C2 cartilage, and do the job, distraction, and inserting when is needed spacers, inserting screws, rods, and bars. This is the technique, posterior approach, mobilization of the facet joints. Here, the necessity in this case to cut the C2 ganglion to address the joint space, inserting the screws, like in a freehand approach. In some centers, people have navigation, other modalities. In our center at this time, we don't have navigation. We do this in freehand way. And after doing this beautiful job, reduction by posterior approach only without the necessity to address the anterior spine. And after that, with some osteotomies, with increasing in the size. This the other size is a pavement, and after that, inserting the cage. This is another case, congenital basilar invalidation. In the past, I'm looking only to the midline, to the compression of the odontoid process. Some surgeons like to do the decompression from the front, from the transnasal approach or transoral approach, but realignment is the secret. Position is the secret of the surgery. You put the patient in this allogravitational traction, neuromonitoring if you have available, and the same job. Distraction, put a spacer, here a titanium mesh cage. In this severe basilar invalidation, it's difficult to reach the C1 and the occipital, the condyle, the assimilation of the atlas. And you need, in my point of view, to cut the C2 ganglia in this case. And here insert bone graft. Other secret, insert a lot of autogenous bone graft. Havert the bone from the iliac crest and put it posterior. Post-operative X-ray, reduction. But in this patient, developed acute respiratory failure. This is the CT scan and the MRI. We can look more careful about the bone fusion with the titanium mesh cage comparison with the P cage, with less subsidence also. We published that. Other comparison. And the technique again, posterior approach, indirect reduction. You can see indirect reduction of the tip of odontoid process, stabilize the craniovertebral junction. We have a lot of literature supporting only C1, C2 long screws fixation instead or for occipitocervical fusion with better biomechanical properties with this kind of construction. Another case, in my perspective, don't address by transoral approach pseudotumors. Pseudotumors or panus for rheumatoid arthritis or other disease, we can distract and realign, and with distraction, the episode tumors disappears. It's an MRI control comparing before and after surgery, and the patient recover a lot of the neurological function. And for finalizing my talk, we can talk about Chiari, we can talk about deformity in conjunction with basilar invagination. This is a case, a severe basilar invagination with cervical scoliosis. We planned the surgery with biomodel to look for the curse of the vertebral artery, and we applied the technique with unilateral concave distraction to correct in the same time the scoliosis, the torticollis, and to correct the basilar invagination, doing indirect decompression of the odontoid process. Here, using a PIC cage again and stabilizing unilaterally with screws. Another case is small children, 5 years old, severe basilar invagination and cord compression from the front. Again, angiotac, we performed the surgery, distraction, insert a PIC cage during the surgery, and the C1, C0 screw make a small lesion at the vertebral artery, the segment V3. We do the primary suture, restore the perfusion of the vertebral artery, and in that case in particular, we change the construction to an occipital plate to avoid another damage in the previous injury of the vertebral artery. Another topic, the Chiari malformation with instability, doing the surgery by posterior approach and the distraction and realignment. Here, type B, Chiari instability, treating by posterior approach. This is the MRI of the patient. The position to address is again, to attack this joint at the craniovertebral junction. Sometimes very difficult to do this kind of the job. You need to angulate the angle of the attack. The occipital bone, the patient sometimes had the platybasia associated with basilar invagination. It's to address to do the distraction. It's not so easy. And here again, with the microscope position, distraction, this C0, C1 joint, inserted the screws, realignment. You have some publication to support in doing that with good results. And here again, realignment of the facet joints, stabilizing and realignment of the craniovertebral junction of the patient treating this Chiari disease. This is the picture and the video of the patient with severe ataxia, but this patient recovered for strength of the muscles, recover of the motor function, and you are seeing at this video. Another case of doing Chiari revision, this patient underwent posterior fossa decompression, duroplasty to treat the Chiari disease and developed a olosyringomelia. This olosyringomelia, like a protective effect that described by Professor Goyo, and this instability that caused damage to motor function. And what we planned for this case, this patient had kyphoscoliosis, severe kyphoscoliosis, narrow deficits, and the approach internal like a Wilts approach. We maintain the fibrous, the previous scar tissues, and address the articular surface from the lateral part from the midline. You do the distraction, inserting bone graft here after doing all the job at the articular surface. And here insert the tricortical bone. With this kind of result, good clinical result outcomes recover the rent grip function of the rent. Here the bone ossification, here the facet fusion, insert the tricortical bone here and stabilize the facet joints. And for take-home message for young neurosurgeons to treating craniovertebral malalignment, craniovertebral junction, in my point of view, more than 95% we can address the facet joint and realign and stabilizing the craniovertebral junction area. In some circumstances, you need to go to occipital. It's not so many cases. And in some cases, also you need to revise by anterior approach like transoral operation. Thank you for your attention.
Yeah, Dr. Lewis, that was wonderful presentation. You have done beautiful cases, and I can see that you have done very complex cases. So I think you have progressed in the years to a very master craniovertebral junction surgeon. Congratulations to you, my dear Lewis. And I wish and I wish that you go further and your concepts improve further in the field. And I'm very happy to hear your presentation, Luis. So we'll go to the questions later. We now have Girish Solanki, one of the very innovative neurosurgeons of our times, mainly concentrating on pediatric population, a very well-known teacher in England. And I'm very happy to have him on the show. Girish, are you ready with your presentation?
Yes, thank you very much, Atul. Can I share my presentation?
Yeah,
can I share the screen?
Yeah, please.
Fantastic. I'm just looking to see what I can get. I think at the moment I got the.
Sorry to interrupt, Professor, but just wanted to tell you that we are a little bit running short of time. So if you could, I understand that your topic is very interesting and we all would love to hear. But the problem is where the next session is already a live recorded session and we don't have control on that. So just wanted to tell you, Professor.
Okay, I'll try and do my best to rush through. First, I just wanted to very quickly thank Professor Kato and Professor Goel for the kindness. First of all, an amazing organization. I'm delighted and honored to be part of this. My topic today is pediatric issues in management of craniovertebral anomalies. Are you able to see the shared screen?
Yes, very much, beautifully.
Okay, so no conflict of interest. I think, I don't think I'll be able to do this in 5 minutes, but my intention was really to talk to you about craniovertebral junction composition, a little bit about measurements, embryological basis, biomechanical leading instability, and then the new concepts. And you, of course, already heard Professor Goel's amazing new concepts, which we are all kind of digesting and learning to introduce in our practice. Common complex pediatric issues and algorithm for treatment, Chiari, surgical examples. And now, of course, most of the neurosurgeons today are very well versed and knowledgeable. So I'm going to go a little bit quickly on this section to try and make up time. We know that the craniovertebral junction is made up of skull, spine, and all the other soft tissue elements. We know that all of this that I've listed here can be contributory to skull-based anomalies. But more important for us is this. What are the bony lesions that we may need to surgically intervene? And in our pediatric practice, the most important for us is the assimilation of atlas, where you lose movement at the atlanto-occipital joint, with all the movement then being put onto the C1, C2 segment, which then increases the motion and leads to instability. And in most cases, assimilation of atlas, as you know, there's also associated fusion of C2 and C3 lamina, which then also puts pressure on the C1, C2 joint. In addition to that, the more significant embryological mechanism is the pro-atlas homeotic transformation, where the fourth occipital somite malfunctions and the clivus becomes short and stubby with an elongated dolichoid dens leading to brainstem compression. And then there's a host of odontoid abnormalities, which we kind of put together, clustered as dysplasias and hypoplasias. And what happens with them is that the cruciate ligament is unable to hold the hypoplastic odontoid onto the anterior arch of C1, and you get atlantoaxial instability. and also odontoid very well known in Down syndrome, leading to atlantoaxial instability, and of course unilateral C2 or C1 hypoplasias causing torticollis, deformity, and need for correction. And then a whole series of fusion anomalies, particularly Klippel-Feil and Noonan syndrome, which in pediatric practice, of course, we see quite a lot of those. So these bony lesions are sort of the landmark lesions for us in terms of management of craniovertebral junction anomalies. Embryologically speaking, all you have to concentrate on this picture is the fourth occipital somite, the proatlas, and to some extent the first cervical somite. Pretty much 99% of all of our bony abnormalities arise from those two segments that lead to instability and result in need for surgical correction. So measurements, again, I'm going to go very fast here because you're very familiar with all the measurements. That's McRae's line and Chamberlain's line. Those are pretty much the ones that stood the test of time in terms of measuring the relationships between the skull and the spine. In the coronal image, you can see that we've got the digastric line, which is about a centimeter above the atlanto-occipital joint. And we've got the bimastoid line, which runs along the tip of the mastoid processes and crosses the atlanto-occipital joint. So these ones allow you to assess whether the anatomy is normal or not. And then the basal angles, which are pretty much important to tell us about platybasia, basilar invagination. And pretty much every surgeon that does skull-base surgery can eyeball the angles. They don't really have to measure them anymore. But these are the angles that we must know by heart. This is an example of a patient with a violation of the Chamberlain's line, and you can see the assimilation of the atlas with fusion of the anterior atrial C1 onto the clivus, and the type A basilar invagination with the odontoid inside McRae's line or foramen magnum. And then on the coronal section, the flattening of the occipital condyles can be very easily measured by the clivus canal angle. So this is a sort of angles and measurements that we all have to do. And I just wanted to bring them to your attention. This is platybasia. You can see that the clivus here is nearly horizontal and pretty much in line with the condyle or the lateral mastoid C1. And this is a very severe angle and a hallmark of platybasia. This is from the Goel collection, a clivus dysgenesis, where the clivus itself was pretty much absent, resulting in severe basilar invagination because there's no clivus holding the C1, C2 down. These are more concepts of basilar impression and invagination. I'm going to kind of go a little bit quicker here because I think most people understand the difference. But one thing that I wanted to point out is that if you have basilar invagination, the problem is that the spinal bones are moving up, including the dents. If you have basilar impression, the spinal bones are not the problem. The problem is the skull base, which is soft in conditions like osteopetrosis, Paget's disease, hypothyroidism, and so on. And what is happening is that the softened skull falls upon itself inwards and rises up. For example, achondroplasia is another condition. And this is the difference, that in basilar impression, the problem is soft skull. In basilar invagination, the problem is the upward movement of the spinal bones into the skull. So again, moving forward, you've heard today Professor Goel talking about atlantoaxial instability as the core problem in a number of craniocervical junction problems, particularly in patients with Chiari, syringomyelia, and the concept of the central atlantoaxial instability and its applications in a number of pathological conditions, which certainly merits a lot more investigation. You've already heard about this, so I'm not going to go into more detail. And going back to the bony abnormalities, so atlas assimilation, I think, is the most important for us, and we need to know this a little bit better than we do currently. Lots of classifications on this. YD classification, I think, is the most thorough of this. And you can see that in group 1, you get atlas assimilation with atlantoaxial subluxation. In group 2, actually, there's no atlas assimilation, but there's odontoid hypoplasia or maldevelopment. And in group 3, there's neither atlas assimilation or odontoid hypoplasia, but there is odontoid dislocation, atlantoaxial subluxation. So it's quite an interesting classification. But of course, you need to have the number of cases to be able to actually look at this. And then I talked to you about dense dysplasias, and of course the big one is ostodontoideum, either dystopic or orthotopic, which very much plays a part in our practice. These are examples of atlantoaxial instability X-rays, dynamic X-rays, and I absolutely agree with Professor Goel's talk about that atlantoaxial instability is not two-dimensional, it's three-dimensional. So it's not just what you see, because sometimes you can't see it. Here's an example of a normal patient with pretty much a normal atlantodense interval and a large posterior atlantodense interval. But then as the C1, C2 vertical relationship changes in basilar invagination, you find that the ADI increases with the posterior atlantodense interval decreasing. Here you find that as the C1 now goes further down into a more chunky part of the odontoid, that both ADI and become normal. And this essentially is because, it's not because the patient got better, but because C1 is going down further in basilar invagination. And if you look at the coronal images, this is a normal appearance, but in basilar invagination, you need the lateral masses of C1 to separate, because C2 cannot go up unless the lateral mass of C2 separate. And that is the pathway for biomechanical failure and basilar invagination formation. So you can see here, foramen magnum, this is C1. You can see the angle of C1, C2 becoming angled with an increase in the distance. And then finally, C2 just slides up between the lateral mass of C1 and you get basilar invagination. So this is the biomechanics of basilar invagination. Unless this happens, the C2 doesn't actually rise up, and you'll see them on CTs and MRI scans quite clearly. So here we go. Basilar invagination is a primary developmental defect. Basilar impression is a quiet form of basilar invagination from softening of the skull base. And of course, platybasia is very much part of the what's happening at the skull base. There are various types. Professor Goel has already talked about this aspect. Also the facetal instability, type A, type B, type C. So I'm going to jump this area because it's already been discussed. Central facetal instability. Here's an example of basilar invagination. In children, we have to operate on these patients. So what are the big groups for us is the metabolic skeletal impairment, where you get all the MPS children. Here are some of those. Then we have children who come with severe compression of the craniovertebral junction with myelopathy. So these are the children with accelerated ossification, like in achondroplasia, pseudochondroplasia, hypochondroplasia, hypophosphatemic rickets. And you can see that somebody that comes like that is going to require craniovertebral decompression in the first instance, and in some cases then stabilization as well. These children, of course, require massive intraoperative monitoring, and we use intraoperative monitoring in all of these cases to make sure that we protect the craniocervical or cervical medullary function. This is a child of achondroplasia. And then, of course, we have those that cause basilar impression, the children with bone fragility or hypermobility disorders, and osteogenesis imperfecta, osteopetrosis, Argyro-Cheney syndrome, Paget's, osteomalacia, hyperparathyroidism. All of these conditions then lead us to a condition where there's such softening of the bone that stabilization, distraction stabilization becomes necessary. And in the same group, inflammatory conditions, of course, rheumatoid arthritis is very well known to all of you, but Grisel syndrome, typically in children, causes atlantoaxial instability and sometimes requires fixation. Similar types of arthritis in psoriatic and ankylosing spondylitis have also required treatment. And then you have this whole range of genetic syndromes like Down syndrome, DiGeorgi, neurofibromatosis, and so on, that also require fixation. Craniofacial disorders like Crouzon's, Goldenhar, cleidocranial dysostosis, vascular disorders, Marfan's, Ehlers-Danlos. There's a lot of work going on in Ehlers-Danlos syndrome, publications talking about hypermobility connective tissue disorders, improved with cervical decompression and craniocervical reduction in fusion. So for those interested, there's a lot of publications on that. And then, of course, the segmentation failure syndromes like Klippel-Feil, Noonan, Turner syndrome. So you can see it's a bit of a, going around the world in 3 minutes or so. I'll give you an example of atlantoaxial rotatory subluxation. We got a lot of this. And in the past, I was amazed to see that lots of the children would be fixed. And even I used to use halos on them. But we did a good study, and this is one of my fellows, Sam Budika Vimla Chandra. He then presented this study where we looked at about 10 or 15 years of work, and we set up a protocol where when children come in with atlantoaxial rotatory subluxation, if they have Fielding and Watkins grade 1, they only get a collar and muscle relaxants and only manipulation under anesthesia if they fail that. And we found that in 90% of our cases, just hard collar and muscle relaxant was highly effective. And we have pretty much reserved the halos for grade 3 and 4 or treatment failures requiring surgery. Papers now coming out substantiate what we've been saying, that a significant number of cases that have been operated and been fixed probably did not require that. Cervical kyphosis, another very difficult condition in children. This is a child with neurofibromatosis type 1 with severe compression. You can see on the CT, this is on the MRI scanner. When you have conditions like that, then you really, pull your hairs out and become very religious suddenly. In this case, of course, we did intraoperative distraction, and you can see that the distraction allowed us to extend and stretch the bones. Initially, my plan was actually to go anteriorly, but after such a good distraction of the bones, we did a posterior fixation with very good effect, and then subsequently did a gutter vertebrectomy and fixation from the front, and the child is doing very well. So again, I'm going to jump this section because you're very familiar with symptoms. And all I wanted to say is that a lot of things that we see, actually red herrings, for example, Chiari, syringomyelia, they're actually the things that strike us first, but in fact, that is not the cause of the problems. And in fact, the cause of the problems can be at many different places, as you can see here. And if you treat those causes, then the Chiaris and the syringomyelias get treated. So what do you treat first? So for example, if you got hydrocephalus, and about 7 to 9% of patients with Chiari will have hydrocephalus. For us, if we have hydrocephalus, I would then just simply do an ETV and observe. And in 90% of the children who present with hydrocephalus and a Chiari or syringomyelia, they will regress with a simple ETV. And that's in our study now. Children who come with craniosynostosis or craniocephalic mismatch, we carry out a posterior calvary augmentation. And those that have skull-base anomalies will require either stabilization, decompression, a reduction of deformities, or a multitude of interventions. The surgical approaches, Luis has done a fantastic job, so I'm not going to spend a lot of time here, and I'm going to jump this section as well. So let's just put it all together. We, in Birmingham, have developed an algorithm now for management of Chiari using where it comes from. So if it is hydrocephalus, what we tend to do, and I'm just going to put it like this. So the patient that comes with the Chiari, syringomyelia, and has got ventriculomegaly, undergoes an endoscopic third ventriculostomy. If the child has a craniocephalic mismatch, you'll go on the posterior calvary augmentation. If the child has scoliosis requiring correction, we'll also go a posterior calvary augmentation. If the child has basilar invagination or craniocervical junction anomalies, which are either stable or unstable, they will undergo a fixation and reduction. And then, of course, you get monitored. And then there is a separate series of patients which have distal lumbosacral dysraphic conditions, and those get the dysraphic treated initially, and that usually resolves their syringomyelia. I don't know if Sachin, would you give me an opportunity to show some examples? Or
maybe 1 or 2 examples you can show, doctor, because our next session, I've just kept it on hold because this session is very, very important for the young neurosurgeon.
Okay, buddy. I'll just show you. So what I'm going to show you is, I got us. If I can show you 3 examples, it will give you the 3 different types of treatment. So this is an example of a child who had a Chiari, ventriculomegaly, and syringomyelia. And you can see that the child presented, you can see the syringomyelia, the Chiari, and ventriculomegaly. So this child, initially I was told to do a Chiari decompression, but in fact I did an ETV, and you can see what ETV did. You see on the right-hand side, the syringomyelia, Chiari, hydrocephalus, and on the left side, within a year, the syringomyelia completely disappeared. The Chiari had regressed by a simple ETV. So patients who come, the 7 to 9% of patients who have a Chiari and syringomyelia with hydrocephalus should undergo ETV first. It's a small procedure, and it results in 90% of the cases getting better. So that's the hollow-cord syrinx, and that is after the ETV. So I definitely encourage, our young neurosurgeons to consider that. Then this is a second example of a child with cranial synostosis, Chiari and syrinx with the tight cranial vertebral junction. Here's the cranial synostosis. Here's the Chiari and the syrinx. And in this case, we just did a calvarial augmentation. The calvarial augmentation resulted in spontaneous deflation of the syrinx, as well as in regression of the Chiari. This is another child that came in without cranial synostosis, but with a Chiari, syrinx, and a tight cranial vertebral junction. And in this case, we carried out again a posterior calvarial augmentation, and the syrinx deflated and the Chiari regressed. So this pretty much kind of attests to our algorithm. And this is a child with MPS 6. These are children who have severe instability. I'm going to jump this one and just show you this one here, because the child with basilar invagination of a severe type, you can see the Chiari, the basilar invagination, ventral compression of the brainstem. This, I wanted to show you this because you can see the vertical C1, C2 joint here. And this is the difficulty that we face when you do this surgery, that you actually have to identify the vertical C1, C2 joints, distract C2, and this is why I firmly believe that Professor Goel's advice here of C1, C2 joint distraction is the right approach in these patients, because once you distract the C1, C2 joint, they will align. And this is what we did here. We did an occipital cervical fixation on this child, and you can see that once we did the distraction, the joints are now aligned on top of each other. You can see preoperatively type A basilar invagination with a simulation of atlas, postoperatively complete regression of the basilar invagination with a very good alignment of the facets, and this is pre and postoperative imaging. I think I'm going to stop here because I've really, and I'll just conclude to say that treat the problem, not the consequence. If you have a Chiari and a syrinx, they are effects, not diseases. Consider the problem. If you have hydrocephalus, carry out an ETV. If you got a supratentorial or foramen magnum compression, do a posterior calvarial augmentation. If you have a compression, like in achondroplasia, carry out a foramen magnum decompression. If you have instability, by God, you got to do a C1, C2 fixation. And if you have a basilar invagination, a C1, C2 distraction fixation is what I would recommend. Thank you so much.
So I thank Girish, Dr. Girish Solanki and Luis Carelli for their presentations, and I hand the proceedings to Dr. Sachin. Sachin, please go ahead.
Yes, so we do have some time to take the questions. It was a very interesting and useful session. That's why we put the next session on the hold. I think we can take a couple of questions, but I had one interesting question. I always wanted to ask you this question, but earlier I thought I was too small, and now I finished my graduation. I've started working with, I'll take little courage and I'll ask you. So, Professor, why is it that you're saying that facetal instability is the cause? Then why is this single instability give rise to multiple different kind of pathologies? Some people develop anterior displacement of the posterior dura, that is Hirayama. Some people will have OPLL, some people will have disc, and some people will have facetal instability. So why is that this one particular facetal instability, axial facetal instability you're causing, giving rise to a different kind of pathologies? What is your take on that?
Sachin, that is a very interesting question, and that is a question which remains to be answered, to tell you the truth. But what happens is, what the issue is, when there is an acute instability, suppose there is a trauma, there is a road accident, and there is an acute instability, what happens to the neck, there is spasm, there is severe pain, and there is those kind of things. But in chronic instability, there are several natural protective measures that happen, and that instability is taken care of for a long period of time. Like sometimes there is, like I mentioned, that basilar invagination, Chiari malformation, platybasia, Klippel file abnormality, and so many other abnormalities are consequences of chronic instability. Even degenerative spine is a consequence of chronic instability. Even OPLL is a consequence of chronic instability. Atlantoaxial and subaxial instability. So chronic, when there is a situation of chronic, something natural or divine happens that protects the thing. Sometimes there is series. That question remains to be answered, Sachin, but these are the things that happen, and the issue is atlantoaxial instability, and stabilization creates a magic, and that we have to understand. Even if it is not really understood today, it will be understood tomorrow. I have no questions, no doubt about how the things happen, and who is the father, and how many children the father has. Atlantoaxial instability is the father, and all the other things are children. You treat the father, the children automatically fall in line. That is the concept. Sachin.
Thank you.
Sachin,
Thank you very much, Professor.
Sachin, can I ask Luis a question? I very much enjoyed.
Just one small question, because
very quickly. I just very much enjoyed your presentation and the video where you showed the C1, C2 distraction, and you were able to put in a metal spacer. Is this something that you can, is FDA approved, or something that we can buy here in Europe as well? Because I've been having quite a lot of difficulty in finding a small size C1, C2 distractor.
Thank you for your question, Solansk. What I done, I usually starting, if you have a small children, you can use it like a mesh cage, like a titanium mesh cage, number 10, and you can customize this titanium mesh cage, promoting compression and make it, instead of a circular way, like an oval way, compression lateral to lateral position, and you transform the cage in a small piece to use in young children. But in my experience, after 6 or 7, maybe 5 years old, you can use, if you want, a standard peak cage for ACDF. You can use your template to measure the exactly height, exactly size of your template, and you can insert in your black direction to avoid the vertebral artery, and use a standard peak cage using the ACDF surgery. You can do this job, and if it's not possible, use only bone.
Okay, Luis. Okay, Luis, the next session has started. We terminate this session. Thank you very much, Sachin. Thank you, Yoko. Bye-bye.
Thank you. I thank you all the speakers, and apology for the, because of the time, we can't hold or we can't take any more questions. But tomorrow, since you have a white matter dissection session, we can take some more questions, have some interaction, doctor. Thank you very much.
Center in Japan. You can see here my short CVs. My field of interest includes the surgical treatment of cerebral AVMs and complex cerebral aneurysms. During the past several years, more than 300 patients with cerebral aneurysms underwent aneurysm repair in my institution. And about half of the patients underwent direct clipping. In my institution, the number of direct surgery is not so decreased even in the current endovascular area. But the proportion of complex cerebral aneurysms, including the large or giant, thrombosed, dissecting, so-called BBAs, and regrowth after initial clipping or coiling, is increasing. For patients with posterior circulation aneurysms, of course, the majority of the cases were treated with endovascular coiling, and only the less than 20% of the patients underwent direct surgery for aneurysm repair. Assembly. The candidate for direct aneurysm surgery is anterior circulation aneurysms in majority of cases, and posterior circulation aneurysms account for only less than 5.0%. During the 7 years, only 47 patients with posterior circulation aneurysms underwent direct repair for their regions. About half of the patients had a ruptured aneurysms, and most frequent localization is basilar artery, followed by vertebral artery and PCA. And large or giant or thrombosed morphology was observed in 17 patients. The skull-based approach was needed about more than 2/3 of the patient, which includes orthozygomatic approach, petrosal approach, bilateral approach, and retrosigmoid approach. Direct neck clipping of the arteries or trapping of the parent artery was achieved only 18 patients, and significant proportion of the patients underwent complex procedure of trapping and bypass, flow reversal or alteration, or hybrid surgery or with the direct surgery and endovascular surgery. Especially the bypass for aneurysm observation was needed in 17 cases. And surgery was performed in our hybrid OR, where intravascular and direct surgery and intraoperative CT is available. Let me show you some cases. The first case is a ruptured basilar chip aneurysms. So you can see here the wide base ruptured regions. So patient underwent direct neck clipping with satisfactory result via the orthozygomatic approach. The next case is partially thrombosed large basilar SCA aneurysms. You can see here the intra-aneurysmal thrombus. So patient underwent neck clipping with satisfactory result via the orthozygomatic approach. In these patients, the ruptured aneurysms were initially clipped more than 10 years ago, and the patient suffered rebleeding due to the aneurysm regrowth. The aneurysm is very, very hypotensioned, and we decide to make clipping via the translaminar terminus approach with assistance of the endovascular temporal basilar artery occlusion. The result was satisfactory. These large basilar SCA aneurysms were initially treated by endovascular coiling with good result, but 1 year later, the patient showed gradual neurological deterioration due to the thrombotic recurrent aneurysms. So our treatment decision was direct neck clipping with intra-aneurysmal thrombectomy or immediate decompression of the brainstem. After surgery, patient recovered well with resolution of the symptoms. This patient also suffered progressive neurological deterioration due to the giant partially thrombs vascular SCA aneurysms. You can see it's severe mass effect to the midbrain. Our treatment decision was same. Surgical neck clipping associated with intra-aneurysmal thrombectomy for immediate decompression of the brainstem. After surgery, patient condition improved. This patient also suffers progressive neurological deterioration due to giant partially thrombosed vertebral artery aneurysms, severely compressing to the medulla oblongata. Our treatment decision was same. The trapping of the parent artery associated with intra-aneurysmal thrombectomy for prompt decompression of the brainstem. After surgery, the patient recovered well with resolution of the symptoms. Additionally, some fiber techniques were needed to obliterate those complex regions. The bypass used includes OA pica in 8, STA in 2, STA PCA in 1, V3 RA-P2 high flow in 3, and EC Sharpener P2 high flow in 3. The most frequent bypass is the OA pica for ruptured pica enveloped VADA, like this. So after the VA trapping and OA pica bypass, patient recovered well without ischemic complications. Each patient had ruptured pure pica dissection aneurysms. So treatment decision was same: proximal pica occlusion and OA pica with satisfactory result. This ruptured distal pica aneurysms was initially treated by clipping. 12 years later, the coil was used for recurrent aneurysms. But 6 months after coil procedures, patient showed gradual deterioration due to the regrowth of the aneurysms compressing to the medulla oblongata. Our treatment choice was proximal pica occlusion and OA pica side to end bypass. Patient recovered well and symptoms resolved after surgery. This patient suffered subarachnoid hemorrhage due to the dissecting aneurysms at VA union. After initial conservative treatment, the parenteral occlusion with high flow bypass was performed, and then contralateral endovascular parenteral occlusion was followed. Patient recovered well without neurological deficit after surgery. But the result was not always good. This patient suffered progressive neurological deterioration due to the giant huge hole vaginal aneurysms. So we treated the high flow bypass with endovascular proximal occlusion. The result was post-operative angiography was very well, but patient suffered permanent deterioration due to the expansion of totally thrombosed giant aneurysms. Previously, proximal occlusion with high flow bypass was frequently applied for large or giant vaginal chip aneurysms, but results was not good. Frequently, the patient suffered fatal subarachnoid hemorrhage after flow alteration. So now we gave up this technique. Instead, we frequently use hybrid surgery for large or giant vaginal chip aneurysms recently. The concept was the surgical necroplasty to change the aneurysm to the sidewall type, preserving the functional perforator from P1 of both sides, then immediately followed by coiling for aneurysm devascularization. So patient recovered well after this hybrid surgery. This is our second case of this type of hybrid surgery, and library demonstrated on link in 2013. This is a clinical result of the bypass surgery for posterior circulation aneurysms. So you can see that the ischemic complications remains a significant problem, and surgical morbidity is relatively high, and about half of the patient, only half of the patient had good prognosis after bypass surgery. On the contrary, the result of hybrid surgery was very nice. So all patients achieved good outcome after surgery. This is the clinical result of all direct surgery for posterior circulation aneurysms. Ischemic complication rate is about 14%, and there is a significant morbidity of CSF leakage. And molecular ranking scale was good in about 70% of the patients. This is our current treatment strategy for posterior circulation aneurysms. Of course, the endovascular first, if available. Then we try to simple clipping because the clinical result is very nice. But if clipping or trapping is not available, previously we tried trapping a bypass for floor alteration for aneurysms of obturation. But currently, we prefer hybrid surgery rather than trapping a bypass or floor alteration if available. In these presentations, I report the current treatment strategy and clinical results for posterior circulation aneurysms. I think the direct surgery still has a role for the treatment option for those complex lesions, but ischemic complication remains to be elucidated, especially for bypass cases. Finally, we have been accepted many foreign fellows to run the state-of-art cerebrovascular surgery.
We are ready to accept young cerebrovascular surgeon to 1-year granted fellow. The scholarship will start in April 2023 to March 2024. So if you have a candidate, please let me know. Thank you very much for your kind attention.
Professor Sano, and now and also the Professor Kurita and Professor Katsumi Takizawa will speak afterward. My curricula vitae is I was born in 1945. Now I am 77 years age, and graduated Keio University 1970, and then going to the Filter Health University to be a professor, and then after the Filter Health University, I am emeritus professor there, and also Shinkabashi Hospital's vice president and director. And I am doing now the outpatient clinic in Kawasaki area and Nagoya area, 4 areas, and surgery is 3 areas, and in one is the Shinkabashi Hospital, it's the Kawasaki, and Aoyama Hospital in Nagoya area, Aichi, and sometimes in Shimamoto Neurosurgical Clinics in Kyushu. Now my personal aneurysm clipping is 4,900 cases. So today's my topic is esoterica of aneurysm surgery. And important is the dome coagulation is change the aneurysm shape to easy clippable shape by dome coagulation. This is one of the esoterica. And this is the case of the anti-communicating aneurysm. And this is the operative view. And we have to draw before the surgery to make it image. And this is the aneurysm left side terminal approach. and put the temporary clip on. Here you can see the we are coagulating the back side of the aneurysm and foreside, and to make it easy to clippable, and using the ring clip, and first to adjust the tip point, and also a little bit small. Then now we add another clip. This is ICG showing where. This is post-operative drawing showing nicely, and temporary clipping time is only 3 minutes and 54 seconds, less than 4 minutes, like this. And post-operative 3D CT angio nicely clipped and preserved ECOM itself. And second one is the multi-clipping. Make image the final pattern and put the clip the deeper part first. This is the point. And you have concentrated the tip of the aneurysm tip of the clip blade. Then this part will be clipped by the second clip. That is the important. First one, you have to just concentrate to the tip of the blade. For example, this is the MCA aneurysm, and preoperative image we are drawing as usual. Here you see this is the MCA aneurysm. Put a temporary clip on, and yellow thick part and very red thin part, and coagulate to make the shape easier to clippable. And deep thicker part will be clipped, and then another one is a thin part is clipped separately, and of course the perforator preserved in the ring side, and obliterate of the thin part also. Then this is the temporary clip off, and check the and post-operative drawing is like this, and preserved every perforator thus, and nicely clipped. This patient was allergic to the contrast media. Then we don't have a 3D CT angio. The growth of the aneurysm. And this is the case of the MC aneurysm. We put the clip like this way and see like this way. And post-operatively, M2 is a little bit narrow, I think, but 3 months afterwards, it became growing nicely. And then 1 year afterward, it's good. 2 years, nice. And 3 years also, very good. But 4 years afterward, the growth of the aneurysm, a little bit. Then, and it's growing 4.5 years afterward. Then we decide to deoperate, and this is operative view, and this is with the clip. Then this is remove the clip off like this way. Then we imaged. Then the one branch will be bypassed by STA-MC anastomosis, and including that branch will put a clip on, and alternating flow by clip. Then we clipped it, and after the bypass, but the 4 times temporary clip is 2, 3, 3, and last one is almost 6 minutes. And post-operatively, this is nicely, patient is good, and now patient is completely well. And same patient, almost the same patient came and a branch is coming from the aneurysm itself. If we reconstruct only by the clip, maybe it regrows. Then we decide, we check the operative view by Swedish angio, and we decide the one branch by the SDMCA, and then include that the branch will obliterate of the aneurysm. Then it's an alternation flow of the only the sidewall type of the aneurysm will change it. So postoperatively, this is the one we did. Only temporal clip is 5 minutes and a little bit more. And postoperatively, STMCL is okay, and also aneurysm gone, and main branch was remained. And this is another case, and a large aneurysm we are putting on a clip like this way and wrapped by the nerval sheet. Little bit remained, but this patient more than 8 years no regrowth. Probably that is we wrapped